Welcome, Dr. Archana Bhatte, ma'am. Ma'am, can you hear me? Dr. Archana, ma'am, can you hear me?
Please unmute yourself.
Good morning. Good morning, everyone. Dr. Gajanan, sir, can you hear me? Dr. Vela, sir?
Morning, I can hear you, Dr.
Good morning, sir. Dr. Kismat Raf, good morning, sir.
Good morning. Am I audible?
Yes, sir. Yes, sir.
How far you have reached? Because
Yes, sir.
you must be traveling, huh? How far you have reached?
I'm just the outskirts of Karar.
Acha, rate is there, huh?
Range is there. Range is there.
We'll start in 5 minutes.
Sure, sure.
फिलहाल सर जरा बोलाल का
नाही ऐकू येत आहे. तुमचं माईक अनम्यूट आहे पण आम्हाला ऐकू येत नाहीये.
can't hear you sir.
नाही ऐकू नाही येत आहे. मी लॉग आउट होऊन परत जॉईन होणार का विथ कॉम्प्युटर ऑडिओ ऑप्शन?
सर तुमचा आवाज येत नाहीये वेल्हाळ सर.
तेच तुम्ही सांगा.
जैसे आप ज्वाइन करें.
Monica.
Starting the program in 10 minutes. Welcome everybody. Dr. Sanghamitra, you are joined.
Yes, I have joined. Thank you.
We'll start in 5 minutes.
A very good morning and a warm welcome to everyone who has joined us online for this webinar today. My name is Dr. Ganesh R. Nair. I'm a faculty in the Department of Community Medicine, HM Medical College, Keynote, Navi Mumbai, and also a member of the IPHA. And I'll be your host for today. The topic for today's webinar is artificial intelligence and digital tools for public health professionals. My health, my right. So I also have with me today Dr. Prasad Venkankar sir, who is the HOD of Department of Community Medicine, and also Dr. Shashank Galvi sir, who is the Vice Chancellor of MGMIHS. So for this webinar, we have with us online also who have joined us very eminent personalities from the field of medicine and public health, who will be guiding us and enlightening us on this topic of AI and digital tools. So as we all know, artificial intelligence, that is AI, has the potential to change how people live, work, and even play. It can be used to automate tasks that humans do. It can also help make decisions faster based on data-driven insights, which can reduce the risk of errors that come from human judgment. So it can increase our accuracy and precision. AI is available all the time, 24/7. It can also perform tasks that are hazardous for humans. It can also make decisions without being influenced by emotions. So for application of this, we have various digital tools available which have become very handy for us today. And many of these digital tools are available at the tip of our hands on our smartphones as well as laptops. So today, we are going to discuss the same on how to use AI and digital tools to our advantage as a public health professional, which would in turn help us help ourselves and the society to achieve optimum health conditions, which is our basic right. And that is this year's World Health Day's theme of 2024. That is my health, my right. So hence the name of today's topic. So for this, we have each and every speaker whom we have with us today brings in so much of wealth of knowledge that I can assure you that we all will be enriched with a lot of knowledge by the end of this webinar. And we will have some very important takeaways for application of AI and digital tools in our respective fields of work in public health. So without any further ado, let us begin with this webinar. So begin with this webinar, we have amongst us some eminent speakers to whom I will introduce you, and then we will have a lamp lighting seminar, a lamp lighting session, and then we will have speeches from them. That will be surrounded. So the very first speaker whom we will have with us is Dr. Shashank Galvi sir, who is currently the Vice Chancellor of MGM, Institute of Health Sciences, Keynote, Navi Mumbai. He is an eminent educationist with vast administrative and statutory experience of more than 42 years. He is also a member of Board of Management at MGM University, Aurangabad, and Dr. Homi Bhabha State University, Mumbai. He is a member of Academic Council of Diva Patil University, Pune as well. He has worked as a Registrar and Dean of Faculty of Medicine for 6 years at Maharashtra. He has been a member of MCI and worked on Executive Council of MCI. He has also been a PI for the use of pentavalent vaccine in multi-centric study for Serum Institute of India. So we have so much to talk about, sir, that we can't fit everything in one slide. So pardon us, sir. So the next, along with sir, we would also have Dr. Sanghamitra Ghosh, ma'am, who is the National President for Indian Public Health Association, who has served in all the 3 services. A very proud moment for us to have her with us. She has worked in Air Force, Army, Ordnance Factory since last 22 years. She has rendered numerous services at the Family Welfare Center. She has received many awards and recognition, again, for which the PPTs will be short for us to explain what all she has achieved. And she is presently also serving as Joint Secretary at the headquarters of IPHA and also a member of IEA, IMAF, and ISSRF. So welcome you, ma'am. Then we have Dr. Gajanan Velhal, sir, who is currently the Professor and Head of Department of Community Medicine at BKL, Malavalkar Rural Medical College, Savarde, Chiplur. He has been the past president for IPHA, Maharashtra chapter. He is a recognized PhD guide for 36 years of experience. He has published more than 90 papers in various medical journals. He has worked as a WHO medical consultant for RNTCP. He has also started new initiatives during a stint at GSMC, that is KEM Hospital, Mumbai, such as fellowship programs in infectious disease, yellow fever vaccination center, epidemiology research center, palliative care OPD services, and many more. welcome you, sir. And then we have Dr. Deepak Kismatrao, sir, who has an MD degree and also is a public health field leader who has achieved a public health leader fellowship from CDC India. He currently works as a regional technical specialist for airborne infection control with FIND India, which is an international NGO. He's also an executive member, counseling member of IAPSM. He has more than 20 years of experience, field experience, of which he has worked in many places. In Mumbai, he has worked for containment of epidemic into the 2005 deluge. He has also worked in programs such as HIV, RNTCP, RCH. He has worked with organizations such as UNICEF. He has also worked in funded program by the BMGF and FAR. So welcome you, sir. So with this, we would start with today's program. Since we are very traditional in our approach, because of that, though we cannot have a typical land lighting ceremony because we are conducting a webinar, but we still believe that we can give a feel of an in-person webinar. We thought we would have some digital lamp lighting at least, since we are talking about AI as well. So we would also have our Dean sir who will be joining us shortly during this program. So as he comes, we would introduce him also. So we would just do a short lamp lighting ceremony online, though we can't do it in person. So I hereby welcome and invite Dr. Shashank Dalvi sir to give his words of wisdom.
Good morning, everybody. All the August members, Dr. Sangamitra Ghosh madam, Dr. Vella sir, Dr. Prasad sir, all the faculty members of the community medicine department at Mumbai, Dr. Himmat Rao sir, and the number of all other members who have joined to this particular webinar. More than 400 persons are to be joined for this particular webinar. And I hope they all will join for this particular webinar. The members of 8 branches of preventive and social medicine, community medicine, IPHA, IAPSM at state and national level. Today, the right theme for this particular webinar on the occasion of WHO Day and its celebration and its further proceedings. What are the things that are going to come up and those things we have to deal in the field of the healthcare? Those will be discussed and deliberately. My health, my right is the theme of WHO Day for this particular year that has been given by WHO. Since number of decades regarding the health, the availability of the health, everyone, the availability of the health for all in 1980 at the Almata Declaration and Health for All, by 2080 that particular theme, and even after 24 years, whether really the health is available to each and everyone, access to essential health services should be regarded not as just as a privilege to that particular person, but it should be considered as a right. That is the interpretation of WHO, and which is not really available in most of the countries. Nearly 50% of the population of the world, more than 4.5 billion, is divide up the essential health care services, and we are also not away from that particular thing. In today's area, the artificial intelligence and the digital health, that is the theme that has been chosen for today's discussion. And data and the importance of data is very much. When we see the data on various activities in the field of the health, the first question comes to our mind is how much the data is reliable, how much is the data accurate. On this data, how we can plan the program, base the program, plan the various activities, monitor the program, they evaluate the program. So the correct availability of the data is always the problem and the question. And digitalization is going to solve this particular problem. There are many problems in the data collection, the manipulation of data, incomplete data, duplication of data, inaccurate data, errors of commission, errors of omission. Those are occurring in the data collection. All those can be avoided with the digitalization of the data. And digital health card, and that particularly is going to surely help in future, in coming days, for the taking the various actions in this particular field. For the minimum essential healthcare services, large number of schemes, those are being made available in the country. Maybe at the state level, maybe at the national level, because the health is the subject which is in the list of the board. The state list as well as the central list, as it is, health is the responsibility of state as well as it is the responsibility of the center. So in the both, the schemes are there. In the state, Mahatma Jyotiba Phule Jan Arogya Yojana, the scheme is there. At the central level, the Pradhan Mantri Jan Arogya Yojana, the scheme is there. And the implementation of these schemes correctly, and this digital health card and digitalization and digitally collection of the data will be very, very important. The artificial intelligence is coming in the big way. The health is not an exception for this. In today's the various discussions, the various speakers are going to speak on the use of artificial intelligence. There will be the many things, the artificial intelligence and its use in a right way. That is also very important. The one thing that should be remembered always, that the artificial intelligence should remain as a co-pilot. That should always assist to the human population for the betterment. And we should not be the victim of artificial intelligence anyway. Artificial intelligence should not master on us. We should master on the artificial intelligence, and we should use the artificial intelligence for the betterment of the human mankind. There are many ethical issues in the artificial intelligence. Those will be also deliberated in today's discussion. And very right thing that has been raised on this occasion of WHO Day and the discussion that has been arranged, and that will go a long way in the discussion and brushing up our knowledge and take away the various good points from today's various discussions in this particular webinar. I wish all the success and the best luck to this particular webinar. I compliment the Department of Community Medicine of MGM Medical College, Navi Mumbai, for organizing this webinar on this successful way. Thank you very much. Thank you very much.
Thank you, Dr. Sashant Dalvi, sir. Thank you for those words of wisdom and motivation. So we hope to make this webinar very informative with the help of all our eminent speakers that we have. Thank you for the very motivational start, sir. Thank you for your best wishes also. I would like to call upon Dr. Sanghamitra Ghosh, ma'am, for the next talk.
Good morning. Am I audible?
You're on.
Good morning to everybody. Good morning, sir. This is esteemed dignitaries, respected colleagues, my fellow public health professionals. It is an honor to address you all today on this momentous occasion. As we gather to explore the potential of artificial intelligence and digital tools in revolutionize public health, it is essential to acknowledge the significance of this year's World Health Day theme, My Health, My Right. Firstly, congratulations to IPHA Maharashtra State Branch and MGMIHS for organizing this webinar. So, the pursuit of universal healthcare access is a fundamental human right, and we must leverage every available resource to realize this goal. AI and digital technologies have emerged as powerful allies in our mission, offering unprecedented opportunities to transform the way we approach public health challenges. Advancements in AI and machine learning have paved the way for early disease detection, personalized treatment plans, and efficient resource allocation. By harnessing the power of big data and predictive analytics, we can identify potential health risks, monitor disease patterns, and implement targeted intervention to mitigate the spread of illness proactively. Moreover, digital tools have become vital in bridging the gap between healthcare providers and underserved communities. Telemedicine platforms, mobile health applications, and remote monitoring systems have the potential to extend quality healthcare services to even the most remote and marginalized populations, ensuring that no one is left behind. However, as we embrace this technological advancement, we must remain cognizant of the ethical and privacy concerns that accompany them. It is our responsibility as public health professionals to ensure that AI and digital tools are developed and deployed with transparency, accountability, and strict adherence to data protection regulations. In conclusion, the synergy between AI, digital tools, and the principles of universal healthcare access embodied in this year's World Health Day theme holds immense promise for creating a more equitable and resilient public health landscape. Let us collectively harness the power of these technologies while upholding the fundamental human rights of individual to access quality healthcare services. Together, we can build a future where cutting-edge innovations and ethical principles coexist, empowering communities and ensuring that every individual right to health is respected and fulfilled. Long live IPHA. Thank you so much.
Thank you, Sangamita, for your motivational words. Thank you so much for your words of wisdom, ma'am. It's a pleasure to have you with us today. Ma'am, to all the participants, all the delegates who have been putting their names and email IDs and registration number on the chat box, we would request you, it's not required because since you have already registered through a proper registration form before entering this webinar, so that data is already with us. In case if you haven't, then you can put it in the chat box. Otherwise, it's not required because we already have all data. We already have almost 198 participants who have joined us. So we were expecting that more would join us in the due course of time because we have more than 450 registrations with us today. So moving on to our next speaker, I would invite Dr. Gajanan Velhal sir to share with us his words of wisdom. Welcome, sir. Sir, you're not audible, sir. Sir, you're still not audible. Sorry, sir, but we can't hear you, sir. So you can sort out the issue in some time, sir. Meanwhile, we'll move on to the next speaker. We'll come back to you, sir. But thank you very much, sir, for your presence. Sir, please, as it sorts out, we would get you back. Meanwhile, I would like to call upon Dr. Deepak Kismatrao, sir, to share his words of wisdom with us.
Good morning, all of you. Am I audible?
Yes, sir.
Thank you. It's an honor and privilege to be a part of this distinguished speakers and amongst this august gathering. I think it's really, at the outset, I would like to thank Mahatma Gandhi Mission Institute of Health Sciences, and as a secretary of IPHA, it's a pleasure that we are having this apt topic of artificial intelligence and digital tools in public health at the auspicious occasion of World Health Day 2024. We all know, I think we heard from Dr. Dixit and Dr. Sangamitra Ghosh, very words of wisdom from them, and just would like to add few points in that. It's really important for us to have both the spectrum working together, the equitable access to healthcare, as well as use of the artificial intelligence and digital tools in public health. We all know in India, we have these two spectrums very, at the two different ends. One, we are still struggling at some point of time for equitable access to healthcare, or to some, I would say, for example, if we take a simple investigation of HbA1c for diabetes, we still have issues about access to this in the rural population. While on the other spectrum today, we are talking about the artificial intelligence and digital tools. So I say it's an apt topic today because this is how probably, both these spectrums have to work together. And somewhere down the line, we are able to use this artificial intelligence and digital tools in our rural population also, so that there is an equitable access to the population. Other important thing is that, as rightly said, is that we have, a great challenge of the proper data that should be available for this artificial intelligence. If we don't have a reliable data, then the prediction that will be done by the artificial intelligence could be wrong. So it's very important that we have this reliable data for prediction. In fact, in one of the programs, we have been using artificial intelligence to predict the outbreak of diseases. So it's a very important tool for us in public health as public health specialists, because outbreak, controls is one of the key for us in the public health. Uh, so, so when we are actually trying to do this prediction, the reliable data, as I said, is very, very important. Otherwise, if we are not able to detect the outbreak correctly based on the epidemiology of the disease, then we will not be able to formulate the policy in a proper manner. So, as I said, both these spectrums are really important from the point of view of public health. Having affordable, accessible, and equitable services to all the population is one end of the spectrum, and other is using this high-end artificial intelligence and digital tools in the country. So with that, I feel that all the new and the current public health specialists should look into this aspect of taking both the spectrum together, uh, as has been declared by the WHO on this auspicious World Health Day of 2024. So thank you very much. I would again like to thank Dr. Prasad for giving me an opportunity to talk on this apt topic today. And I wish best wishes to the webinar today. And we have a lot of distinguished speakers, and I think a good deliberation would happen on the artificial intelligence on today's day. Thank you so much. Thank you, Dr. Ganesh. Over to you.
Thank you, Dr. Deepak sir. Thank you so much for your words of wisdom. I would request Velhal sir, who was trying to join in from other link, if possible, sir, could you please come in and share your wisdom as well? Right. 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 Uh, Unfortunately, it looks like Velhal sir is not able to join because of some technical issues. We would move on with our program. We have the next topic by Dr. Prasad Vengankar sir. The topic is use of AI tools. Use of AI tools by public health professionals. By Prasad Vengankar sir.
Can I share it from here? Anil,
नहीं नहीं हाँ
can I share it from here?
थांबा आधी so सरांची पोहोचा. So Dr. Prasad Vengankar sir is currently the professor and head of Department of Community Medicine, MGM Medical College, Keynote in Navi Mumbai. He has been the former National Professional Officer, that is NPO, in WHO for fields of emergency and humanitarian action, as well as polio eradication with the WHO and Government of India. He is currently the president of Maharashtra State Branch of IPHA and also the vice president of Maharashtra State Chapter of IAPSM. He also has held many important positions in editorial board and various other public health associations. He has also held several conferences. He has been a part of several conferences held himself. His main interests are non-communicable diseases, health economics, and IT. So we would have sir today for speaking on use of AI tools by public health professionals. So we welcome you, sir. Please take forward the course of discussion for us. Share karo.
Good morning, everybody. Am I audible?
Yes.
So the topic is basically I'm introducing as a first speaker here for today's webinar. AI tools, for some it is scary, it's new. We're a little shy for their use. Then partially we are ignorant also how we can use them. My session is just to introduce about it, and throughout the day we'll deliberating with further details. Various speakers will be going into the examples and even the hands-on. And the topic is such big, we may not be able to finish everything in today's one day. So IPHA will definitely have even future events dedicated to some specific things based on your feedback. The feedback form link which you will receive in the chat box. Kindly make it a point to fill it up and give your feedback that will help us for further programs. So let us look into the basics and understand what is AI. So artificial intelligence, the science of building machines that can learn, reason, and act in ways that normally require human intelligence. And it is achieved by studying human brain patterns and cognitive processes to develop intelligent software and systems. It can perform a variety of advanced functions, including seeing, understanding, and translating spoken and written language, analyzing data, and making recommendations. Some examples which most of you must be knowing is the chess-playing computers, self-driving cars, virtual shopping capabilities, factory input-output data analysis, and then fraudulent transaction identification. So many of them. So if we see the types of artificial intelligence, they are reactive machines. This is the most basic type of AI. These machines only react to what is in front of them in a given moment. They're limited memory machines. These machines have a limited understanding of past events. Theory of mind machines, an early form of artificial general intelligence, and self-aware machines. These are theoretically the most advanced type of AI, and these would have an understanding of the world, others, and themselves. So basically, these are the 4 types, but then 3 more types are added. One is a narrow AI or artificial narrow intelligence, then general AI or artificial general intelligence, and super AI or artificial super intelligence. We'll be going in further slides about these terms. We need to know the understanding of these terms. Some subsets apart from this, they include the deep learning. Deep learning is a method that teaches computers to process data in a way inspired by the human brain. Deep learning models can recognize complex patterns in pictures, text, sounds, and other data to produce accurate insights and predictions. Another term you must have heard is a natural language processing or NLP, which has the ability to integrate data with natural language text or voice. As the public health professional deals with data in a huge way, there's a lot of potential of NLP for the public health professional. This weak AI or narrow AI, what is it, and what is a strong AI or general AI? So weak AI refers to AI systems that are designed to perform specific tasks and are limited to those tasks only. These AI systems excel at their designated functions but lack general intelligence. Examples include voice assistants like Siri or Alexa, recommendation algorithms, and image recognition systems. Weak AI operates within predefined boundaries and cannot generalize beyond their specialized domain. Strong AI, that is also known as general AI, that refers to AI systems that possess human-level intelligence or even surpass human intelligence. In fact, that has a special category has been now created, that is super intelligence, which I had mentioned earlier. Strong AI would be capable of understanding, reasoning, learning, and applying knowledge to solve complex problems in a manner similar to human cognition. Though it has been said that it is still not achieved, many things are in pipeline, which you would realize by the deliberations by our other speakers, and you would realize that yes, we are near achieving it and we are near using it. There is another term you must have heard is a generative AI. Generative modes are a class of machine learning models designed to generate new data that resembles a given training data set. Learn the underlying patterns, structures, and relationships within the training data and leverage that knowledge to create new samples. A public health professional works a lot in the field, gets exposed to a huge data, and here is the opportunity to use the generative models through probabilistic modeling, latent space presentation, adversarial training, autoregressive modeling, and reconstructions of error minimization. Due to the paucity of the time, I'm not going into the details of this, but then it has a huge potential for a public health professional to use this model for the research, conclusion, and then definitive interventions. There is another term which is explainable AI. AI has taken over most of the fields. Relying blindly on AI for crucial decisions is still doubtful. When we get some response from the AI software, we wonder, is it correct or is it wrong? How I'm going to be sure of that? To solve this problem, humans have developed explainable AI that maintains transparency over its actions and helps humans get explanatory results from AI algorithms. It is also known as XAI when incorporated into systems. This will be able to explain the logic behind decision making, indicate the working mechanism, and indicate their strengths and weaknesses. I'm going to show the example of this to you in further slides. So further aiding in deciding their reliability. So when we look at the role of a public health professional, basically three activities a public health professional is involved in. Service, that is practicing public health in the field. Research, that is for the benefit of the future decision making. And then teaching the students and those who are working in the field also on the job teaching. And all these roles, the public health professionals can use their AI. We deal with a lot of data in all these three things, at least especially with service and research. And then we can incorporate it in teaching in the form of creative content, which we require a lot for the teaching purposes. I'm giving you the example of using ChatGPT for a purpose. You can say it is for the research. Everybody knows that we have to give the references at the end of the research article. And then they have to be in specific Vancouver method. So I received an article by my student who had mentioned the references, but they were not in proper Vancouver method. There were a huge number of references, 40 references. Now that means I have to go to the website and check each and every website and then confirm what is the appropriate citation should. So instead of that, I took the help of artificial intelligence, the ChatGPT software. So I gave the prompt, convert following text into Vancouver style citations, and then I put the citation there. The ChatGPT gave me the answer like this. I'm not happy because again, this is not correct citation. But as I said, they have given me the logic also, the sources. But then what is to be done? Because I cannot take it as a proper reference. Artificial intelligence can change, provided I change. So I changed the prompt. I put the prompt how to cite following text, and then I put the reference. I thought, let us see what the ChatGPT says. So the ChatGPT's answer, it was again almost same. It seems we are not communicating well. It gives the sources, but that relationship between me and the artificial intelligence is not still established. I might be understanding the answer of artificial intelligence as a wrong, but artificial intelligence is not understanding me. So then I have to change again. So I changed again the prompt. Now I have written identify errors in following citation and revise it in Vancouver style. And then I gave the reference. Now a little bit artificial intelligence software started understanding me, because I had changed, I had improved my communication, and I learned I need to develop the skills for communication with the AI. Now what it is saying, volume 5, issue 2. But again, that is not Vancouver style. I'm still not happy, but I'm happy that AI understands me. So I again changed myself. I improve my communication and I changed the prompt to the ChatGPT. So now I write, identify errors in following citation and revise it into Vancouver style, ensuring completeness of format. It's again the same. Now AI understands me better. It says it is 2012, volume 5, bracket issue 2, and even the page numbers have appeared, 34, 37, and that as a reference number 1. So I'm very happy. And then another thing which I noticed in that logic is that it has said a cross-sectional study from the PubMed Center. Earlier, it was not telling me, but now it has realized what I want everything. So now I know that this article has got a PMID also. So that means if I tell artificial intelligence, it will provide me that also. So finally, I put 17 citations all together by changing my prompt. And then my prompt is identify errors, revise it into Vancouver style, ensuring completeness, and I added and correctness of format. And 17 citations I have put. Obviously, there is no place in the slide to show all that, but I got all 17 citations corrected in no less than 5 seconds. And the answer was, the citation format is inconsistent across entries. The revision ensures uniformity by following the Vancouver style guidelines. Each citation, including author names, article titles, journal names, publication date, volume issue numbers, page numbers, and relevant identifiers such as PMIDs. So in 10 seconds, I got 17 citations on the references, got corrected, but I had to take efforts to put the correct prompt. So moral of the story is that the AI softwares are very effective, very useful, provided we learn how to handle this. And that is the purpose of today's webinar. And all the speakers who are expert in this field will step by step explain you, even will give you the hands-on for using AI softwares. And I'm sure that will help. Thank you.
Thank you so much, sir. for your insightful presentation. I'm sure all the delegates here would definitely pick up something very useful from this presentation. So we would move on to our next topic on empowering healthcare with generative AI, exploring role of ChatGPT. For this, we have with us a very eminent personality, Dr. Amit Kumar De, who is a consultant physician in diabetology, obesity, and metabolic disorders, practicing in Kolkata, West Bengal. He has an experience of over 12 years in clinical practice with diabetology as the primary subspecialty. Here, as you can see online, that he's a winner of multiple awards, which I can keep counting one by one. He's a fellow of many societies. He's a founder chair for Doctors AI, which is a medical community connecting around 400 healthcare practitioners on AI. He's also the host of a fortnight medical podcast series, which is Med AI, Decoding AI in Healthcare. That is a global reach out and viewership in more than 60 countries. So we have a very prominent and dynamic personality with us today. His areas of interest in research include obesity and metabolic syndrome, diabetes in the elderly, CGM in gestational diabetes, artificial intelligence in diabetes care, precision diabetes care. So, apt person to speak on artificial intelligence. I would request all the delegates to put any of their questions if they have with for any of the speakers to put it on the chat box. We would definitely answer them in the due course of time. So I welcome Dr. Amit Kumar De, sir, to please take forward this course of discussion.
Thank you very much, dear organizer, for the kind introduction. And at the outset, I would like to sincerely congratulate all the dignitaries at IPHA for taking this initiative to sort of create an awareness about artificial intelligence and its nuances in the domain of healthcare. I sincerely thank Dr. Shashank Dalvi, Dr. Shangamitra Ghosh, Dr. Gajanan Velal, Dr. Deepak, and of course, Dr. Prasad for setting the context to my session. So if any of you could confirm me that my slides are visible, it's moving.
Yes, sir.
Then we can proceed. All right. So over the next 30 minutes, I'm going to take you through the nuances of using generative artificial intelligence effectively as well as ethically in the domain of healthcare with a focus on public health. And as we all know and understand that the most readily available AI tool which is available to us is ChatGPT. It is based on generative artificial intelligence. And thanks to Dr. Prasad for kind of introducing those terms in his previous talk. This is something which is very useful and very effective if we are using it in the right way, in the proper place, in the most ethical and effective way. So these are my disclosure. I will be talking about a proprietorship LLM like ChatGPT and also give you examples of other generative AI tools that you can apply in your day-to-day activities in the field of public health. But of course, I don't intend to endorse any one of them. It is solely for the purpose of illustration. So if you look at the whole spectrum of artificial intelligence, these 8 blocks that I have drawn here would be the 8 pillars where you would find the application of artificial intelligence occurring very rapidly. The nuances of using it would increase over the next 2 to 5 years, if I can sort of tell you that. So you're looking at personalized care, personalized treatment, taking us a step forward in precision medicine. You'll be looking at a lot of these AI tools, these large language models working as virtual health assistant. ChatGPT or GPT-4 is already in the process of being used in that format. You are already seeing the use of deep learning algorithms, convolutional neural network, in advanced diagnostics like medical imaging. Predictive analytics is something which is very important, and I'm so glad that the dignitaries today brought up this topic of having a clean data, a structured data to give you the right kind of predictive analytics. If you've been following the development that is happening in AlphaFold developed by Google, you will see how protein folding and unfolding can be quickly augmented, and that would go a long way in improving drug discovery, escalating the phase 2 and the phase 3 trials of drug discovery. And you will find the use of generative AI, natural language processing in treatment optimization. Robotics will get added to it in optimizing surgery, and telehealth will be enhanced in helping individuals, even in the rural health population, towards remote AI monitoring. And then perhaps we can start talking about equitable healthcare for the general public of India at large using technology and artificial intelligence. So a quick look at how these segments overlap. So you have artificial intelligence, and a subset of artificial intelligence is training the machine to understand a set of data and then giving output based on certain algorithmic principles on that set of data. So that is called machine learning. Another subset of machine learning is deep learning, which is kind of based on the neural networks, kind of similar to the neural networks that runs in our brain. And a lot of deep learning you will find finds application in the domain of radiology. So if you try to sort of extrapolate a little bit more, you can see computer vision, robotics, all this is coming. Machine learning has got three predominant subdivisions called supervised, unsupervised, and reinforcement learning. And it goes on with deep learning, and then comes a part of deep learning as generative artificial intelligence. So that's what we're going to be talking about today. And a example of generative AI tool is Chat GPT, Midjourney, Stable Diffusion, etc. Now we have so much more. So Dr. Prasad in his last talk gave you an introduction about what general AI and narrow AI means. So as of now, what we are all dealing with throughout our spectrum is predominantly narrow AI. It is being tailored for specific tasks, and general AI is something which is called also as strong AI. It is kind of known as machine intelligence, where the ability to learn, understand, and perform can be done at par to a human with its own comprehension beyond a specific set of instructions. So I think we are still some time to go there, but probably there are predictions that in 2027 we will be reaching a phase where we'll be looking at a full-fledged general artificial intelligence. Before I dwell a little bit more into Chat GPT, let's understand these terms well. I understand that a lot of public health professionals, students, postgrads, and researchers are connected here amongst the 221 audiences that I see connected. And these definitions would probably help you understand how you can apply AI. So you're looking at generative AI, which is basically a science. The term means generative. So you're generating context based on a set of instructions. So while the science is called generative AI, the application is through the help of large language models. So by the name of it, you understand it means that it has been trained on a large set of data. So hence it's called large. It involves language training involving natural language processing. So it is called a language, and it is a model which has been structured by humans. And one such example is Chat GPT or GPT-4 or 3.5 that we will be talking about. The term natural language processing, to simplify, basically means that you talk to the computer in your own language, the computer converts it into its code language, and it talks back to you in your own language. So that is the essence of using generative artificial intelligence through the foundation of model of a large language model, and thereby applying it in natural language processing to various chatbots. Now, if you're using generative AI, you will have to get yourself familiar to these terms, and one of it is called prompting. In the previous presentation, Dr. Prasad showed how changing the terminologies of the prompting kind of makes such a big difference. So it basically means giving a hint or a question to the computer to get it to respond. The science is called prompt engineering. And if you do not develop the art of giving the right prompt, then you will end up putting yourself in a situation which is called artificial intelligence hallucination. The medical term of hallucination we all understand. But in AI, you don't want to get into that phase of hallucination where your foundation model or the transformer model is throwing the output here and there without specifications of what you are asking. So now you have OpenAI in 2022 came up with a generative preform transformer called Chat GPT or GPT. GPT is the foundation model. So what is GPT? It means generative. It is pre-trained on a set of data, on a huge set of data. That's billions and trillions of parameters. And it is called a transformer model. That's kind of a base model on which it is trained. So there is a foundation model that it works on. It has a capability of generating human-like text, and not just text now, it is also image and videos you can generate. It should be coherent, it should be relevant, and most importantly, if you're using it in the domain of healthcare, well, it should follow the rule of medicine, that it should not do any harm. And that's where all the nuances comes of understanding how these models perform and how they work. So it starts with a model architecture, and then that architecture undergoes various sets of pre-training. And over the layer of pre-training, the foundation model is fine-tuned. And this fine-tuning is done, of course, by the maker of the model. And while there is a fine-tuning going on, there is also a layer of reinforcement learning which is added that makes it so effective. So every time you're giving a prompt to ChatGPT, it is learning, it is memorizing it, and the next time it is improving its output based on the fine-tuning, the very minuscule fine-tuning that is happening constantly at its level. And there is always a layer of iterative refinement that goes on to these models, wherein it keeps on building its foundation model. The model keeps on changing through all the input that we put, like a drop in the ocean, in using it in our day-to-day activity. So how it has evolved, you had the original GPT version, and this has been going on for quite a while, although it all became very famous with the launch of it in 2022 November. But the research behind it has been going on for many years, for over a decade perhaps. And then you had the GPT-2, and you had the GPT-3, and you can see how each stage the training is involving a larger set of parameters. So that is the essence of a large language model, that the larger set of parameters, for example, GPT-3 is trained on 175 billion parameters. So the larger set of parameter it is trained on, the more effective it is going to be in its output. That is why you get a difference in output when you're using ChatGPT 3.5 and ChatGPT 4. Biggest advantage of ChatGPT is, or GPT for that matter, is the continuous refinement. And this refinement makes it so useful and so nuanced to that specific use case. As a healthcare professional, we find, wow, this can give me the outputs in such a organized, in such a structured manner. The same kind of response can be found from a lawyer or a chartered accountant when they're using ChatGPT, because the refinement is so fine is that it keeps on learning from the inputs that people keep putting across the globe, like, a drop in the ocean. So the next step was, of course, ChatGPT 4, and that's what most of us will be using and are using going ahead. And it has got so many applications and customs that we want to learn and use. So the earlier days, we had ChatGPT plugins, the advanced data analytics, and DALI was also a component that is using stable diffusion to kind of create those images, generate images from text-based input, and you can try all this on your own. But with the launch of ChatGPT, a new feature started coming up wherein you can build your own custom GPT based on the need gap or your use case. And through my talk, I'm going to show you how you can actually use ChatGPT to build your custom GPTs for public health, which might be just used in your local platform, maybe in MGIMS or through the platforms of IPHA or any other locally you can use. So this is a mind map which we created at Doctors AI for how doctors can start exploring ChatGPT into their daily activities. This itself has been made using a whimsical AI tool, which is itself a generative artificial intelligence tool. So the first place where you can start using, I would say, is in medical information retrieval. That is something very important. Like, for example, extrapolating the citations and getting it structured. In patient education, this is a bigger place where you will find use cases, especially in the domain of public health, and it can be used at every level. We are exploring using generative AI tools for clinical decision support. It's still not very well evolved. Research is still going on. A lot of ethical questions comes in, and a lot of questions need to be understood about how the model functions before we start implementing the CDSS in our clinical practice. In professional education and training, you can use it to train healthcare workers. In administrative assistance, a big task reducing job can be done, using ChatGPT or any of these generative AI tools. And of course, in research assistance. Now, let's give you a quick understanding of how you can get your prompts correct. So, at least after today, most of you who are joined here would be able to prompt in better. So, the first thing is you need to understand the purpose. You need to define what exactly you want to achieve from the interaction with the AI model. Try to keep it as clear as possible. Do not write ambiguous words. You have to be concise. You have to be specific about what you're asking. Also, you need to experiment. Like you got an example earlier on how changing simple word in the prompt is changing the output. So you need to keep on experimenting with different prompts, and it's an art that you can develop by understanding the science. And as clinicians, as healthcare professionals, I think we will be mastering this art. There are certain terms. So one is, of course, priming the prompt. So for example, you can give it an example like you're a researcher working in an institute. So it starts thinking like a researcher. So you're priming the prompt. You make it purposeful. You give them a purpose, and you could give an example. Like, for example, you're an assistant trained in healthcare, etc. And that's how it starts thinking before generating the response. These are some of the examples of the different prompts you should use, like an open-ended question. You could use a sequential prompt, one after the other. You could use a role-playing prompt, like giving an example. You could use a refining prompt or a negotiation technique, chained prompts. You could have a linked prompts, one after the other. And now the GPT-4 will also remember. So it memorizes your previous prompts, and you can start building your inputs based on those previous prompts going on ahead, which is called a tree of thought. So it's like a conversation with an AI tool, giving its power to remember what you have spoken or you have communicated with that earlier. Now let's understand where we can apply a GPT in healthcare. Okay, so let's look at the most commonest application will be in virtual health assistants. We are already working on that. In patient interaction or healthcare worker interaction, also you can use appointment scheduling, medication reminder, in data analytics. These can be done by simple API integration of the GPT with the tools. In mental health support, I'll give you some examples in medical training, in research, and in telemedicine. What are the problems that we encounter? Just try to compare, heads on. The first problem we see is the early detection of the non-communicable disease. If you're looking at chronic diseases, we often as clinician practicing metabolic health, I feel medication adherence and compliance to treatment is a big challenge in the outcome. We can't tap to the patient at the right point of time to bring in the lifestyle and behavioral change. Regular monitoring and follow-up becomes a problem. Cost of care, education gap, a psychological impact, complex treatment plans, access to specialized care, and of course language and communication barrier becomes a big hindrance in public health or when you're trying to address non-communicable disease challenges. So can chat gpt or GPT-4 help you with that? Let's explore that. So you can have personalized education, you can have medication reminders, you can give them monitoring assistance, you can have health resource guidance, you can simplify a complex medical jargon into simplified chat format where a person can understand, even if the person belongs to a rural population with a lower literacy rate, or even if you want to explain a simplified example to a 10 or 12-year-old kid. You can give exercise recommendation, dietary advice, and treatment clarification, but of course, and always keeping the human in the loop, never replacing the human. So, what are the examples in public health? So, you can have health awareness and education programs. You can create a GPT which can help you have these automated response that can help you with personalized education. So, it will memorize the inputs given by the individual, and it will give a more personalized education recommendation to that individual rather than a generalized recommendation. In diabetes, these are things that we are building. So you can have a diabetes self-management education. We have spoken about this in so many forums. The DSM is so important in personalized care. And as a diabetologist, I would be looking forward to use a GPT where you can have a chatbot to provide instant responses, dietary tips, clarification of treatment, medication reminders, and bring a behavioral change. Guide them to the right resources. Sometimes with so much of resource on social media, people get misguided. So you can have a bot who can guide the patient to the right resources, give them personalized answers and access to health information. That is so very useful. Let's look at an example here. Now, we're going to kind of run these videos a little quickly. So this is an example, as you see, how ChatGPT sort of gives a personalized treatment education to a patient who is just sort of telling them that, look, I'm a diabetic patient and I need some advice. And you can see how the GPT model here is going to quickly pick up that and start saying that I'm not a doctor, but these are some of the general tips that I can give you about what you can do to go with. This is something similar to what a healthcare professional or at large a public health professional or a healthcare worker would do at large. This kind of guidance can be generated and more personalized way for the individual. The other example is going ahead with disease surveillance and reporting. So you can use it for data collection and real-time analysis by integrating with the right tools. So a lot of API integration and technology collaboration is required here. And at Doctors AI, we are working with certain kind of collaborations. Another very important aspect where you can use these generative AI tools is in mental health support. The biggest advantage is it will provide 24 into 7 health support with a conversational AI. And it is going to give personalized answer, maintaining anonymity as well as comfort. But here we have to be very careful because when you're using a GPT, it doesn't always maintain anonymity because it is a general large language model and not a specific medical use case large language model. But we still can try using it. And this is one such example wherein the person is typing in that, look, I've been diagnosed with type 2 diabetes and I really feel depressed about it. So can you guide me how I should go about with it? It starts empathizing. So your generative AI tool like a GPT can start empathizing with the individual and gives a nuanced guidelines, start following education, support, seek help. If you need help with a psychologist or a counselor, go ahead and seek that, stay positive, stay informed, etc. You can use these chat GPT and GPT tools for continuous learning and training. I mean, you can use it to train the allied paramedical healthcare workers in a more regional format and also in their own language, which is very important. So you can take out the language barrier because by far and large, it understands all the language. And if you ask them to generate something in your regional language, the support system, it's quite strong enough to give you back those answers. And again, you can use it for public engagement and feedback. So you can integrate one of these generative AI tools to a form and you can get an interactive survey. And it not only understands the engagement there, and it also gives a more stronger feedback about community engagement. So it is like just not taking the responses in a Google form, but using some kind of an integrated kind of a generative AI platform, which can be more communicative with that individual, engaging them into more productive responses. So for non-communicable diseases, now let's look at some of the examples how we can use Chat GPT. So one such example that we have explored is using data analytics. So you can use it to analyze your glucose monitoring data. And of course, Dr. Alok Modi will be speaking later. He will show how you can use GPT to understand your SMBG readings. You can use it to integrate for alert system, reminder notification, get a trend analytics of your blood glucose level or your blood pressure levels, and give reminders to the individuals as well. In aged patients, chronic care, people with multiple pills, multiple comorbidities, pill mixing is such a huge burden. If you can imagine integrating a natural language processing tool with a medication reminder box that would perfectly work with timely alerts, dose clarification, missed dose guidance, medication interactions, and also give them about adherence tracking. And not just that, if you can integrate in the right way, you can also have the entire thing extrapolated to the clinician, that whether the patient is actually taking the medication on time, the right medicine in the right time, or maybe even to the caregiver, to the children of that individual who is probably staying away in a different country, about improving the compliance of that individual. So the potential is huge. But as clinicians, we need to find those need gaps and applying it. And that's what we believe in Doctors AI. Let's look if it can help you in giving a dietary recommendations. And I think all of you here would have tried this, generating its own, your own customized diet plans using a chat GPT. It gives fantastic guidance, but of course, it's not a replacement to a dietitian, never. It will always need the human in the loop to understand what it's giving and what kind of output it is generating. But again, it can give you good dietary tips about balanced meal, carb counting, controlled portion, something which a dietitian or with a busy clinician might not be able to give because of the dearth of time. And this is something that through a chatbot or using these chat GPT platforms, you can empower your patients to get these kind of response. And you can see this, you can see how beautifully it gives even a sample menu plan, tells that this is not a replacement of a dietitian, and it always acknowledges. So you can use a GPT in non-communicable disease, let's say integrated with a glucometer, a powerful tool to monitor blood glucose, and using natural language processing, it can actually speak to the patient and give them insights about how their blood glucose levels are fluctuating. Those things are already going to come tomorrow or day after as these things evolve. We are all wearing a smartwatch. I'm wearing one. Most of you would be wearing one. So how about you having a natural language processing tool speaking to you about your heart rate, about your blood pressure, or about your calorie intake or your calorie output, and gives you recommendations and targets based on your individualized way. So these things, I think GPT-4 or any other large language model, we now also have Llama and so many other large language models which can be integrated. We have Mistral and so many LLMs which can be integrated with the wearables. So with this, starting on, you guys can start working on personalized treatment care plans, kind of build a GPT, and I'll show you here how you can build a GPT. What we have done here is, for example, we have used the chat GPT to simply analyze a continuous glucose monitoring graph. So if some of you working with diabetes, we know you would be understanding what a continuous glucose monitoring graph is. It's like a continuous monitoring of the blood glucose by monitoring it from the interstitial fluid. And you can see how it takes the complex graph and summarizes through advanced data analytics into a simplified version. For a doctor, you don't need to understand this because you would probably do, but for an allied healthcare professional, like an educator or a dietitian, this makes such big impact. Let's explore further. Look at this continuous glucose monitoring graph, and you can see everything in yellow means the blood sugars are on the higher side. And this is the average reading of the average graph. This is what you get in the Libre scan of the patient. If some of you are using it, you would know, and you would see how the graphs are all over the range. It's not nowhere between the range. Now we developed something called a CGMS guide or a glucose guide. What this does is that it analyzes the graph, and it kind of helps the individual in understanding the summary of the graph. So you can see how it is going to be. I fed the whole graph, which I just showed you earlier, into this custom GPT, which we have built. And this has been now trained over, I think, 500 continuous glucose monitoring data from my system. And it's continuously learning because it is available in the public domain. And all of you can start exploring it right away and start using it. So you just have to be a subscriber to GPT-4. This doesn't run with GPT 3.5. So you can see it took the whole graph, and it gives a summary of the entire conversation, the entire graph. So the complex graph has been summarized using generative AI through a custom GPT, understanding its variability. It comments on the blood glucose fluctuation. It tells about the glucose summary and also gives some insights on individual day-to-day analysis. So that is a powerful tool that you can not only give it to your educators or dietitians, but you can also give it to your patients that, look, put your graph in this and you'll get an analysis of your graph. So get your phone on, start scanning this QR code. And if you are a user of GPT-4, then you can start using this right away. Start exploring this. Do write back to me with your feedbacks, how it is giving the output in your continuous glucose monitoring graphs. And we've been doing so many things. Like, for example, we are working, this is still not in the public domain yet. We are working on how you can use a note assistant. For example, a conversation between a doctor and a patient can be summarized, and speech to text conversation can be done. And you put that into a GPT or a custom GPT. There are many such tools also now, and it summarizes the whole conversation. Like here, you can see I've just submitted conversation between me and one of my patient, and it beautifully summarizes the whole conversation in the patient profile. It takes the clinical history, it clubs it together, it clubs in the symptoms. It also talks about the consents, which I've discussed with the patient during this 18-20 minutes of conversation. It tells about the medication which needs to be discussed with the patient. And you understand the power of this. You can simply do it on your own, and you can extrapolate this into your EMR, into electronic medical records, and you have the whole conversation documented without even having to type all these things. And this is a time where you can actually spend connecting with the patient eye to eye, converting with the patient. So this is still in the build. There are a lot of platforms which are available already on the net, and you can explore it. But by far, this is in the build, and you can start exploring it. This is one of my articles where we have actually explored using Chat GPT in diabetes care. This is the QR code. If you want to read the full article, you can go. It's freely available to everyone. It's published in the International Journal of Diabetes in Technology. And this is probably the first one coming from India, where we looked how you can use effectively Chat GPT for diabetes management. Before I go on to the end of my session, let me tell you a little about how you can use custom GPTs. So now you can see these custom GPTs are very specific to your need case. You can have personalized chatbots, educational tools, and also use it for creative writing. So in your GPT, you will get something called a create a GPT section, and there you can keep on exploring this. The advantage is that this doesn't require any coding. It is more conversation based, and it can be kept private or shared publicly. Like I showed you some examples for your friends and local colleagues to use. So this is something that you can start getting hands on right away, and you don't need to be a techie. You don't need to know coding to do all this. You can start using through your chat GPT. What are the custom GPTs that you can build? So I'm just putting ideas into your mind. I'm not a public health professional, but after this session, all of you can start exploring this. You can create a risk assessment GPT, a screening guideline GPT. You just need to feed on the right set of data so that it learns. You can create a patient education GPT for a specific set of non-communicable disease. You can use it for data analysis, outreach, and communication GPT. So all sorts of communications can be simplified using these GPTs that you can build. A symptom checker GPT, policy analysis. So you can put in a guideline from WHO and have it analyzed. And you can train it to analyze any kind of policy by giving it a set of instructions as you go on. You can create a multilingual support GPT. So no matter whatever language you're speaking to the GPT in, it gives the response in a particular language, or it structures it from speech to text, etc. You can keep on trying. So this is a little tip for all of you out there who are watching, 210 participants, fascinating, that these are some of the other artificial intelligence tools that you all can explore. Perplexity, you can use it to learn and read research, summarize them. Humanta, Grok is a very fast using large language model. Claude, you can use it for summarizing PDFs. Quillboard for writing AI tools. Gemini is a very good tool, at par with ChatGPT, developed by Google. It's paid subscription. And Llama is, of course, something which is being brought out by Meta that you can try. You can use Gamma, Tome. These are all for making your PowerPoint presentations. And if you're on the Copilot, then you would know how you can beautifully use it to generate images. So these are some of the tools. Take a snapshot of this, explore it after the session. And what we are building is we also believe in not just using AI, but using AI responsibly. So Doctors AI, we believe in AI for doctors, by the doctors and for the doctors. Like we are talking about my health, my right. And we believe that AI should be triggered by the doctors in responsible ways. So we're building something called Madhu. It's called Metabolic and Diabetes Health Assistant. My friend Dr. Alok Modi is also a principal investigator in that. And we are at the moment using it to be validated. It's built on GPT-4. And we will very soon releasing the beta version of it for use by our friends in the medical community. We believe in responsible AI in healthcare. That is so very important. But again, with all the silver lining, there comes a streak of limitations that we must understand. If you're using a chat GPT, remember you're looking at data privacy issue, and that is so very integral. Always remember from what I've told you earlier that GPT is not trained as a medical large language model. But just because it's so finite and it is trained on such a huge parameter of data, it customs and adjusts in providing you medical output. But the privacy issue will still remain a big here because this is a general large language model, and it's a proprietor large language model. So you do not own the data. The data eventually is owned by the proprietorship company. So training data limitation is a big problem when you're using chat GPT. You need more GPTs you need more large language models like MedPalm, which is more specialized. You need them to have a contextual understanding, a real world application readiness, so that we can use it more effectively. And that's why we keep saying that as doctors, we need to understand how this is working and where it can be applied in the right way. The challenges are factual correctness. Error identification becomes a limitation. There is nowhere you can verify the data. For example, if you're generating a citation, it might even be a hallucinated citation. So you always need to go back and cross verify. The model training enhancement is very, very important and still not very robust with the GPT models. And it continuously needs monitoring and updating with the human in the loop. And that's why doctors need to be educated about AI. And we need to have a voice upfront that, look, this model needs to be a human in the loop so that it can give the right output. It can be misused. It can have fabricated risk, unvalidated advice. Imagine that going in the hand of the patient. Misinformation spread can be very rapid and it can even convince you. So you have to be very careful what you're using and how you're using. Contextual misinterpretation is a bigger limitation of ChatGPT, and it will always it will always need critical review with the human in the loop. A lot of ethics comes in. WHO recently released the guidelines on the large language model, and we had summarized that from Dr. Zayal, floated out to all of you if you want to read the summary. Bias becomes a big challenge. Ethical deployment is still a gray zone in our country and many countries across the globe. We need to sort of formulate these ethical guidelines and have a voice so that this can be used ethically including a diverse data set, having transparency. So the transparency of the AI model is so very important. The end of the day, it should be patient centric. The end of the day, we are trying to make an impact in patient care. So no generative AI tool should be centered around the benefit of any other community except the patient community. So the future is good. You can try out and we can explore with healthcare IT integration. A lot of developments can happen in advanced AI driven tools, personalized care I've just showed you, and collaborative AI models. You need to have a lot of regulations and policies in the making, which will drive the data privacy regulations before you start using it in larger projects. You can use it in your local projects, but you need the established regulatory framework. And we have our Data Protection Act coming in our country with the Aadhaar coming in, and we need more HIPAA compliance and something similar to the HIPAA compliance and the GDPR guidelines as well, as which is very strong in the in the other Western countries. So going ahead, folks, we need a human AI collaboration. Where the human oversight is very crucial. It needs a teamwork approach. It needs shared decision making. There's got to be a complementary role. AI is not going to be replacing you, but it's going to be complementing and augmenting your function. That's why I keep calling it as augmented intelligence rather than artificial intelligence. And it requires continuous learning and adaptation with and only with the human in the loop, and expert human in the loop. That is so very important. So when you ask a large language model that what it can do in the world of AI, what can physicians do then? It says physicians can increase their human touch, empathize. It can help you make ethical decisions, spend more time with your patients, and give more time in something which is so important, counseling the patient, connecting with the patient, while the automation task can be left to generative AI tools like GPT-4. So you need an AI assistance going ahead with a successful collaboration, and only then the sky can be the limit with future possibilities. These are the two most important taglines that I keep saying this wherever I go, that AI will help us evolve from evidence-based medicine to data-driven precision medicine. But as clinicians, we must now come out of that sci-fi wow factor and start asking the how factor. How is this algorithm giving this output? So we need to educate ourselves and learn, because literacy about artificial intelligence is the key. So to go ahead with that, we have done a lot of work over the last 1 year. We continue going to do it. This is one of our podcast series, which is very famous across the globe. And just on 2nd May, we are coming up with a series on AI in genomics. Anu will be joining us from Map My Genome, and we'll be discussing how AI is improving genomics. And that is one step towards precision care. This is the QR code if you want to join this podcast and listen to it live. We also do a 1 hour update hour every month. The next one is on 16th May. If you're connected with us on Doctors AI, we will be sharing the link with you, wherein it's a brainstorming session about the developments and updates that is happening on artificial intelligence. And to all our friends who wants to get their hands dirty into artificial intelligence, this workshop is coming up right tomorrow, although we are full with the students batch, but we can accommodate a few more. So this is the QR code to scan and sort of register yourself. And in case any of you are really interested to join, do write to me or do reach out to Dr. Alok or any one of us from Doctors AI. We'll try to fit you in. This is a 5 hours of workshop where we will give you all the hands-on training, how you can use ChatGPT and everything else for research and for building your own tools and stuff, etc. This is the QR code you can scan to sort of explore that more. This is a link to our series of podcasts. We have had 18 episodes now, and you can just explore and read about and go ahead with it. We've covered a lot of topics in healthcare, like how you can use ChatGPT, and we have got a forum of speakers connected with us from the West who are specialized in this, and they keep us giving their insights over these 1 hour of fortnight podcast that we run. And that's, of course, accessible to all through YouTube as well as through the MedSynapse platform. So this is what we do. Besides myself being a clinician, we've started a community called Doctors AI. This is the link to our WhatsApp channel. We keep on sharing updates and scientific literatures on AI because it's a fast-paced domain, and a lot of developments are happening every second as we speak. And we need to stay updated. We have got a monthly newsletter coming up run by Dr. Avnish from Udaipur, and we keep on educating and helping our community members to get themselves literate about the updates in artificial intelligence. This is our LinkedIn community. At the moment, we have 700 plus global members. And I will request all of you connected here, if you're on LinkedIn, please scan this QR code and join us on Doctors AI. The whole focus is that we need to get ourselves tuned to the developments that is happening in artificial intelligence, be equipped and use our own clinical acumen, expertise to apply artificial intelligence in the domain of healthcare. That's why we keep saying it's artificial intelligence by the doctors for the doctors, because that's where healthcare can benefit using artificial intelligence. So with this, I shall conclude. But before I end, I would like to pass on one very important message to all of you, that healthcare practice is going to transform, not from evidence-based medicine to data-driven intelligence-based medicine. And when this happens, as clinicians, as public health professionals, as physicians, it's the frontline ground zero workers, we need to be in the forefront driving this change. Thank you very much.
You so much, sir, for your deep dive into generative AI, basically the various terminologies that can be used, that needs to be used, the history of chat, evolution of chat GPT, its uses and advantages, even the prompting techniques that we need to adopt, even custom GPT that you spoke about, the type of AI tools that we need to use, that we can use, their limitations and ethical considerations. It was indeed a very wide-ranging topic on chat GPT that you have sensitized us on. I'm sure that a lot of them would get inspired to use ChatGPT and other AI tools for public health, because that's the way forward. So actually, there are some many questions in the chat box, but because of paucity of time, we won't be taking up those questions now. But we would definitely take them in the due course of time during panel discussion, which happens after the break. So there are plethora of questions that have been asked to you. So we will definitely come to them in the due course of time. Thank you, sir. Thank you, sir, for the deep insight. Next on our panel, we have Dr. Purvi Chawla. So I just wanted to inquire if Dr. Purvi Chawla could join us online. Ma'am, could you join us? Or
if Dr. Purvi Chawla is not joining, please take my presentation, because it is almost now 2 o'clock in USA.
yes, sir. Yes, sir. We're just confirming, because as per the schedule, we just called Dr. Purvi Chawla. If she's not around, definitely we'll go ahead. So since Dr. Purvi Chawla ma'am is not there, I would herefore invite Dr. S.P. Kulkarni sir, who has a vast experience. He is currently joining us from the USA. It's already night there. He's talking to us in the middle of the night. He's currently working as an associate professor of medicine at MGM Medical College. He's also a president of the Telemedicine Association of India, Maharashtra State Chapter. He's the editor-in-chief of Monograph of Technology in Clinical Medicine. He's also a vice chair of Digital Technology and Diabetes Work Group of Diabetes India. So these are very short introduction. This is a very short introduction to him, because there are many more things which we could have added. But again, because of limitation of space, we have cut it down to this thing. And I invite sir to speak on the topic simple digital tech to develop public health database for AI-based research. So I welcome you, sir. Please take this discussion forward.
Yes, thank you. Thank you very much. And I must appreciate the vision of the organizers. I'm just trying to share my screen. It is showing me. Just a minute. I just want to confirm that my slides are seen and they are moving. Can you see my slides?
Not yet, sir.
Are they moving? No, you can't see only.
No, sir.
You can't see the slides?
No, sir.
Okay. Because when I'm trying to use this, my share screen, yes.
Yes, sir. Now it's
Now
visible.
it is okay.
Yes.
You can see the full screen.
So now it's visible. Yes.
full screen and they are
Yes, sir.
moving. Okay, thank you. Thank you. It is 2 o'clock in the night in New York, and I must appreciate and thank Dr. Prasad and Dr. Amit for making my job absolutely very easy. Real appreciations to the vision of the organizers for making this particular topic, which is going to be a really hot cake for the next few years to come. I bring you greetings from my working institution, MGM Medical College. I don't have anything to disclose. I have not used AI for this presentation. And since this is my 42nd year of clinical practice, I am using more and more practical examples and taking you through only 6 points, which is the outline of my presentation. First is the introduction part, and all other things have been already done by my friends. What are the basic principles? I'm touching the basics because this is the subject in which there are going to be a lot of overlapping things. And it may not be possible for a novice person to understand. So this is a touching example with the principle. I'm going to give examples of daily use. There are people who talk against it. Is there really a bane? What is the PEEP in future? I'm going to give you some take-home messages, references, and further readings. AI is not only understood, it is ill interpreted. And AI is a mathematics, it is not a magic. So people have got different views of looking towards the thing. It's a big blanket to cover so much. I just give something very simple, the rules-based logic, then the risk scores, the ACVD score which we use for a patient. Then you have got predictive models. Then you have got targeted neural nets. Amit beautifully discussed about ChatGPT, which is generative AI and which is the keyword of 2024. Friends, my talk is very simple, but it is a very tough task. To develop a public health database for AI-based research in India, it can be a transformative endeavor. Our country's vast population and the diverse healthcare landscape is a big issue. A simplified roadmap to incorporate digital technology can help, and for that, we have to have been really data conscious. Now, let us see what all things can be helped by AI, right from automatic queries of the patient to billings and summaries and medical advisory messages. All the aspects of patient healthcare can be done with generative AI. Amit has beautifully given you the example. But my question, I stumble at the first step itself. That is the data collection. How I am going to leverage digital form platforms for efficient data collection. The basic form can be revised, but what you should do is you should stick to your things. I am a physician. I'm looking at metabolic disorders. I will give an example at the end of this discussion. You can use mobile apps, you can use Google Forms, or you are something like an Internet of the Things devices to which there are a lot of instruments which are connected. We must encourage participation through user-friendly interfaces and surveys, not only to the teaching staff and to the senior doctors. You start with your hospital staff, you start with the students. Incentivize whenever is possible, either gifts or some card games. And please do collaborate with healthcare providers, government agencies, and research institutions to gather diverse data set encompassing demographics, medical history, disease prevalence, and lifestyle factors. I can give example of one of my friend who was working in Sindhudurg district, and there he found out that those people who were working in the copper mine there, they had a huge incidence of diabetes. So it was a perfect public health problem which was dealt, it was discussed and used solved with the help of data only. We have to engage with patients and the other people in various communities, which is a more efficient personalized inquiry response, and that can be done with an enhanced chatbot performance. You can have improved access to quick, reliable information, and most important is avoiding misinformation and preventing panic in a patient. So what you can have, effective patient engagement, instant response to common queries, collect patient information, collect feedback from the patients, recommendations of wellness program, and schedule the appointments easily. I work in Navi Mumbai, and there are some people who have got off only on Saturday, Sunday, or they have got odd day off. So for me, the scheduling of appointments is very easy because from the calendar, my staff can find out that Thursday afternoon is easy for this person. So without asking, this appointment gets accepted from both the parties. That is the beauty where the chatbots can help you as a simple thing. So there are many AI techniques. For database, we need EHR, electronic health record. And that does not mean that it should be sponsored by some company or a real big thing. Your Excel sheet also can be a good way. Then there are other forms of data, computer vision utilities like X-ray, CT scan, MRI, and machine learning platforms, that is histological and genomic data, which is the really more complicated. It is the simplest, it is a bit complicated, and it is more complicated. Let us concentrate only on the EHR. We should have a collaboration and knowledge sharing as far as data concerned. We should foster collaboration among stakeholders, which are researchers, policymakers, healthcare professionals, and technology experts. The problem is healthcare professional wants something and the technology expert gives something. We have to establish platforms for sharing data, algorithms, and research finding to accelerate scientific discovery and innovation. Sharing is caring here. We need to encourage interdisciplinary research initiatives, spanning field as epidemiology, genomics, and most important, social determinants of health, which are not discussed by clinicians. And it is a real good way in which community medicine can help all the data standardization and integration is big issue. There are established standardized formats and protocols. You should ensure interoperability, a big problem, easy to say, difficult to practice. Utilize technology like HL7, this is called as the health level 7, and FHIR, fast healthcare interoperability resources for seamless integration of the disparate data sets, and at least adopt open data standards to promote transparency and collaboration. This is what about data. Then you have got data, but where to store the data? So the best way is doing cloud computing and big data analytics by using cloud computing storage. It harnesses infrastructure to store and process large volume of healthcare data cost effectively, embraces big data analytics tools and techniques for real-time insights and predictive modeling. This is then interactive, real at the real time. Best example we have seen during COVID epidemic. It deploys all the AI algorithms for pattern recognition, anomaly detection, predictive analysis to identify emerging health trends and risk factors. Risk factor analysis, best example is the anomaly scan, which we do during the ANC period. So cloud computing is not a rocket science. You can have your own personal cloud of 5 terabytes or 8 terabytes. It is not going to cost you too much. There are, in short, these are the advantages of cloud computing. It is cost saving, flexible, 24/7 availability, reliable, scalable, performance is good, is automatic updates of software, easy backup and restore, and unlimited storage. You can just go on increasing 5 terabyte to 5 terabyte, and the data can be stored very easily. The biggest problem, people are worried about the data security. So there are a lot of data protection measures. We have to adhere to the regulatory guidelines, and there are certain methods. Employ encryption, access control, and anonymation techniques to protect privacy while facilitating data sharing for research purpose. You should not disclose somebody's HIV status or HBsAg status with name during your working process. It may be harmful to the patient, to the family, and even for his prestige also. Now, with this data, you have stored the data. There come your machine learning models. And what are the steps in which machine learning can help you? EHR analysis, medical imaging, drug discovery, clinical research, and personalized healthcare. But with clinical research and your further workup, this will give you a very good path for research, publication, and presentations. So explore the deep learning techniques not only for image analysis, but for your research purpose also. It continuously refines algorithm through the interactive learning and feedback loops to improve accuracy and the performance of the same part. That means it is a self-learning model. It is a trainable model. Now let us go to our clinics, and I'm quickly going to show you what are the basic examples which we are using. And I'm sure all the 200 participants who are attending it, they will be really benefited with this. See, a human being is surrounded by sensors and watched. A connected patient is a big data generator. You can analyze so many things. Airflow sensor for breathing, obstructive sleep apnea. ECG, EMG, e-health sensor for it is galvanic skin response for stress levels, body temperature, pulse oximeter, BP apparatus, and patient position sensor or accelerometer. Every phone has got accelerometer. And where the use? In senior citizens to detect the fall. So these are the cricket team of the things which you can say monitor digitally, right from TPR BP, your blood glucose, the fifth vital, body position for fall detection, weighing scales, alarm buttons, ECG, FHS, atrial fibrillation, and other anomaly detection. You can monitor sleep, stress, and add-ons. You can make any add-on, many can delete. A future of digital technology is going to be something like this. You will get a box and you can just order what you want to monitor. It will be automatically stored to your electronic health record for research purpose. Simple example, pulse oximeter. It can be accessed through a mobile and it will give you a respiratory rate also and perfusion index. It is very useful in conditions like dengue fever. And triage of the patient. Suppose if you have got a busy OPD of 200 patients, you just put the pulse oximeter with PI and RR. If the RR is more than 30 and the perfusion index is low, the oxygen is low, this is the patient which needs to be taken proper attention. Everybody has got these kind of tapes and this kind of weighing machines, but how they can be interconnected? So this is a digital tape which is going to help to use your waist and hip circumference, and this is a height meter. Just put it on the head of the patient and it will give a height of whatever the centimeter. These are the body composition analyzers which are there, which come on the screen of the patient and your mobile, and there can be a complex analysis of your body in terms of fat, muscles, bones. This is a made in India stethoscope, but it is not a simple stethoscope. It documents and transmits. I can, sitting here in New York, I can listen to the heart sounds of my patient in Navi Mumbai ICU. And I can document as the third heart sound or whatever the murmur is there or a pericardial rub is there. Forget now tubes and bulbs to inflate, no batteries. There are BP apparatuses going to be like this, and these BP apparatuses can be directly connected to your electronic health record. If you want to give an image of somebody suffering from ASOM, this is a wireless otoscope. All these things are available. I am using it in my day-to-day life. I have got a ECG machine which has got a 1 lead, 6 lead, or even a 12 lead ECG. And this does not require any jelly, any cable, nothing. It will give you 6 lead ECG directly to me on my mobile, and I can send it to anybody. There can be a 12 lead ECG with evaluation advice. And I'm very proud to say that this is a product from Aurangabad. This is a ECG which is into tech, and you can analyze the ECG. The analyzed ECG is a boon for somebody suffering from ST elevation myocardial infarction, so that the doctors are ready with either thrombolysis or for angioplasty. There are many more players, like ECG is one of the example which I have given you. These are the kind of labs. These are the point of care of labs. Here, just put one cartridge inside and you get information about very laboratory parameters like NT-proBNP, which is a hallmark of congestive cardiac failure. I use a glucometer which is connected to my mobile phone, and it can give values of the blood glucose to 5 of the people which were registered. CGMS, again, Amit and Alok, they are experts in this. They will talk more about it. But CGMS acts like a detective in your body, and it tells you how your sugar goes up, how your sugar goes down with exercise, with the stress, and how you should adjust your day-to-day life. These are the futures. This is a meter called as a NOGA. It is a non-invasive glucometer available, but has got some duty issues. But this is what I am using. It is a multi-parameter 15 parameter instrument which gives me even hematocrit and hemoglobin in a non-invasive way. Friends, we are going to have not only watches, but rings like this which monitor pulse, SpO2 and sleep and stress, and it can be combined even with glucose meter. Don't forget eyes. Eyes are the mirror of body. So retinopathy screening with a non-dilated pupil remotely can give whether the person is suffering from diabetic retinopathy or not. It is not only tell you about diabetes, but it will tell you the smoking status, serious disease risk prediction, and CHF prediction. So you please take a look into the eye with AI in community medicine. Eye examination with and fundoscopy should be part like TPR, BP, and the blood pressure. This is a central illustration showing how the retinopathy is evaluating microvascular in the heart failure, and these are the standard published papers which you can refer, and it will be really useful guide. Now, I just talked in the initial part of, I have got a patient. All these parameters are here. Duration of diabetes, hypertension, COPD, family history, anthropometry, how much is his weight excess. I have got his biochemical parameter. Now, here comes the role of AI, which will analyze if my patient is vegetarian, then there is a high possibility of hyperhomocystinemia, which is a pre-thrombotic state. So in my treatment also, it will tell me to add folic acid in the view of homocysteine. So this is the way in which you are putting the patient's history and physical parameters, then you are correlating with the biochemical parameters, and then it can get a very good way of doing the physical examination as well as advising the prescription. So whole body has got so many things which can be managed. You are going to get equipments like this in future. There can be a patch on the skin which will tell you about sodium and potassium. This will be a fault detector. This looks like a waste, but it is a Holter monitor. And with the help of 3D, you will be in a position to explain to the patient and relative what procedure you are going to do. Digital twinning and personalized medicine are the future steps for public health also to understand complex medical problems. Now, from clinic to the basics of AI, let us go in a very practical way. How AI can help me in writing grant. So these are the softwares Jasper, Write Sonic, and Article Forge. The speed and quality of researching, drafting, and tailoring grant application is increased. It reduces significant amount of time, and it synthesizes background documents such as the national strategies plan to prepare a first draft or a context section for a grant. And it takes other your personal references also. Suppose if you want to talk something for Marathwada or something for Vidarbha or something for Konkan area, those parameters will be considered in this grant writing. You can help in global phenomenon also. It generates content and material for future ones. And there was a campaign for malaria, 1.4 billion people, and it generated 24 million digital interactions. So these are the campaigns which are quickly created, tailored messages supported by generative AI, and they are conceptualized or even confirmed by humans to keep the loop in, and the output would enhance the campaign's reach and engagement and further the goal of eliminating any disease, example malaria. Again, ethical is always a problem. Everybody is going to talk about it. But I will like to tell that there are two, three type of biases: aggregation bias, algorithm bias, societal bias, and cognitive bias. But the worst is what our vice chancellor told is the incomplete or the incorrect or the corrupt data. So all the things in AI for research and acceleration of the process, it depends upon clean data. So we should address ethical considerations related to data ownership, consent, then ensure equitable representation of diverse population in groups, conduct regular audits and validation checks, which is a very important step for our self-information. I will be really very happy when AI-based softwares as a medical device, a terminology called as SAMD. This is an action plan which is going to be there, and everybody from the community medicine is familiar with this wheel. Good machine learning practices will be of help to everybody. And the CDSS, that is clinical decision support software, the final guidelines are going on, and they are definitely going to help us. So friends, just to summarize my thought process, I have got 5 steps to get your started with generative AI and public health. Please identify the high impact user areas and strategic priorities. Art of the possible, where you can use maximum. Assess the organizational readiness. There is no point in people who are not ready to implement. Consider identify risks unique to the implementing general AI in public health. If I want to identify pre-diabetes in all the relatives of known diabetic patient, I have got a specific group. Consider policy, health equality, security implications, which is there for the specific generative AI. And most important, invest in partnership from industry and academia to design, test, and scale the initial general AI use cases. In UK, government has picked up DeepMind, OpenAI, and Anthropic to support the safe adaptation of AI. And since considering UK as a small country and the whole system has been nationalized, we could also start with our area, whichever is possible. Last but one, the caution is premium de nocere. Do not do any harm. Use the umbrella of responsible AI. That is very important. The other side of the technology is be aware of hallucinations called as a confabulation. There are large language models which are based on associations, can struggle with directionability, words with multiple meaning or closely related concepts. And large language models also abhor a vacuum. There is certain thing which not understood by this AI. So it is hard to get them an output. I don't know, or there is no evidence of this, maybe the victims. There are many things which are to be discussed, but I just end with that whenever we are expecting AI to come us, we have to have evaluation of LLM, that is a large language model. How I can tell if the answer is right? Automated scores, and the framework should be 3H. It should be helpful, it should be honest, it should be harmless. And I will add one more: hinderless and very easily flowing. If you want to do all these things, you need capacity building and training. So please invest, train, and encourage lifelong training, professional development to keep pace with evolving all the technologies and the best practices. If you are interested, please go to this website and you can immediately just type SARA WHO. What is SARA? It is a smart AI resource assistant for health. And using the new language models, a cutting edge technology, it is useful to millions of users 24 hours a day in different 8 languages, multiple health topics, and on any device. I have used it. Definitely, you will be also really thrilled. You ask a very specific question, mainly related to the public health and other things. The answers are really very to the point. So friends, we have got something from our own country also. These are the Government of India report task force on AI in healthcare. be part of the whole moment. There is a new kid in the block for the AI in medicine, a journal called as NEJM AI. Please request all the medical colleges, those who are listening to the presentation, to subscribe to this journal and encourage them to make research presentations on AI. H-index, which is a metric that measures countries' scientific productivity and impact, India ranks very low, 19. We produce a significant amount of data, but in research, it is been low. I had been to Boston, I had been to Silicon Valley. Whole of the software industry is managed by Indians. But in India, we are producing less. The onus is on us, clinicians, institutions, policymakers, clinicians, and community health people. So please do a lot of positive work on this. If you want to know something real, simple, basic about digital technology in clinical medicine, this is the ICP monograph, which was published by me with the help of Indian College of Physicians. And before we close the smart chapter, please thank our teachers, mentors. For us, the opportunities are endless, especially for the next generation. But do not get lost into the maze of apps or trapped into the cobweb of internet. Aim at what you want, but at the same time respect the teachers. The clinician's role prevails. Technology changes, advances are welcome, but human touch, rational thinking, clinical acumen, and empathy are non-technical and will always win. We have to combine it wisely, keep on learning. This is my email ID for contact, and this is the WhatsApp number. I will be readily sharing my presentation with all of you. I thank my 1974 Mirrors Medical batch, my family, Dr. R.D. Lele, and my teacher, Dr. Professor S.V. Soltur from Mirrors, and all the organizations and all my friends, Amit, Alok, who made me to switch from old to modern. And thank you of the organizers for giving me this opportunity. I end with saying be optimistic, informed, empowered, futuristic, build a bridge of knowledge, technology, and AI in data processing and community medicine. Thank you very much. Thank you. Hello.
Thank you so much, sir, for this very insightful talk on AI and its application in the field of public health. You spoke about data storage, machine learning, various devices that can be used as digital tools. You also spoke about grant writing for various softwares that can be used for it, the ethical consideration. You also pressed on the need of capacity building, constant capacity building and training, which is very important even for AI or for any other thing, and even about SARA that you spoke. I think there are a lot of public health professionals, would at least now be assured that community medicine or public health is a clinical subject, which you yourself said, because and use of technology is in basic clinical skill application is needed. So that put to rest a lot of arguments we keep hearing online otherwise. So and there is one more question which someone had asked, that will AI replace doctors? So
Never.
I think, sir, you have already answered it in your last slide, that rational thinking and empathy can't be.
Yeah, it will replace the doctors which are not using AI.
Right.
Yeah.
Okay.
It will replace the doctors who are not using technology and AI. And I really appreciate efforts of your department, Prasad and Dr. Kelkar. You have hit a 200. Your attendance right now is 200. It is double century.
Yes.
Real congratulations for this. Keep the recorded process for everybody's help. And please allow me, it is now almost 2:45 a.m. here. Okay.
Thank you for taking all the
very
time so much, sir. Thank
Yeah.
you for.
Can I leave the meeting now? Can I leave the meeting? Thank you.
Yes, sir. Thank you, sir. Thank you for being with us. Our president of IPHA West Bengal chapter, Dr. Surjit Ghosh, had raised his hand. Sir, do you want to speak something? Would like to add something? Because you had raised a hand. Dr. Surjit Ghosh, sir? Okay. You want to stop? So let's. Sir is not available currently. We will move on. We move to the next topic, that is by Dr. Aparna Chaudhary on the topic of application of artificial intelligence in infectious disease of public health importance. Dr. Aparna Chaudhary is currently working as an associate program manager at Vadvani AI, which focuses on infectious diseases. She has previously worked on along with WHO India for tuberculosis and also UNDP for HIV. She has completed MBBS, MD from Manipal and her master's in health policy planning and financing from London School of Hygiene and Tropical Medicine. Her work interests span various disciplines, including infectious disease, health system strengthening, and health policy. So we welcome Dr. Aparna Chaudhary for this talk. Dr. Aparna, on to you to take it forward.
Thank you so much. I hope I'm audible.
Yes.
And I think everyone can see the presentation. Okay. So before we move on, why we need AI in public health or in infectious disease? Very briefly about, I think the previous speakers have talked about why AI is required, but we all know that the world is facing a healthcare workforce challenge. That is by 2030, the world will have around 18 million fewer healthcare workers or professionals who are working, especially in the developing countries. And and the requirement for the healthcare providers are going to increase, especially in the rural setups in these developing countries. So AI has a potential to address the supply chain demand, as the previous speakers have also mentioned. AI has emerged as a transformative force in the field of healthcare, offering innovative solutions to enhance patient care, improve diagnosis accuracy, and streamline administrative processes and reduce care costs. When we talk about the infectious disease part, so with the growing threat of emerging and re-emerging infections, we have all seen how the re-emerging infections are happening. And with the recent COVID-19 outbreak, there's a prioritization for the response and management of the infectious disease, which we need to do. And also build a resilient healthcare ecosystem that becomes more relevant with the changing times and which can support the current growing threats, and also to utilize the healthcare manpower or the resources in a better and effective manner. So AI has been transformative and offer a resilient healthcare innovations for timely interventions for all these global biothreats. AI has brought multiple benefits for disease forecasting, drug discovery, and development diagnostic. So throughout the presentation, I'll be focusing mainly on the role of AI in the infectious disease. The previous speakers have highlighted about what are the roles the AI is currently playing. Throughout the presentation, I'll be talking about what all AI solutions are currently being focused globally as well as in India, which are deployed, which are being used currently by the various governments, or being used or are being in process of being used by the pharmaceutical industries for the infectious disease. So AI can be used for the computer vision technology for improving the diagnosis and detecting disease for mainly for the screening and diagnostic purpose. It can be used as a prediction model for identifying at-risk patient or for informing population health management or people who are on higher risk of developing a disease. For bioinformatics, for development of new drugs or therapeutics. Under epidemiology, for forecasting disease outbreak and the seasonal trends of the disease. And for system strengthening, that is, it aids in disease surveillance with reduced cost and administrative burden and resource optimization. So starting with the first part, the screening and the diagnostics. So AI, under AI, the algorithm, the deep learning technologies and the machine learning algorithms, they can be trained on large annotated data sets of images of parasites of the different stages of the parasite, egg or the larval stage or the adult stage, the skin lesions for the infective and the non-infective lesions of the infectious disease, the chest X-ray images, cough sounds, etc., to identify specific features and patterns with remarkable accuracy depending on the type of data we provide to the AI. So currently, WHO has recommended using computer-aided detection CAD2 screen and triad individuals, indicating their likelihood of TB by automating the interpretation of digital CXR, mainly using the CXR images to give the prediction whether the patient or the person has higher chances to develop a tuberculosis disease in the rural areas where there is scarcity of of a medical professional or a chest radiologist to give the prediction. So this is an example where one of the international organization, Cure AI, has helped for the AI solution has helped for giving for triaging the patients who have more likely chances to go for developing tuberculosis infection. Similarly, ADMAN for malaria parasite detection in blood smear captures the images through smartphone. So the AI model was developed using the photographs of the thin blood smear of different type of malaria parasite, how it looks in the blood, what different kind of malaria parasite is. The model was trained on it, and then a smartphone device was developed so that in a rural setup, healthcare workers who don't have much information what kind of malaria disease, what type of malaria parasite it is, or whether the person has infection of malaria or not, they can take the picture of that smear and then they can get malaria or not. This has been currently being deployed in African countries and is giving a very good accuracy, around 70%, for detecting malaria parasite in the blood smear of the patients. At a global network, the AI is being explored for detecting different parasitic skin lesions, eggs, and larvae in blood and stool samples of the patients. And in coming futures, they will be used for neglected tropical diseases, for detecting the patients of what kind of infection the person is experiencing. Coming to the drug discovery part, so there are supervised ML models that can be used to analyze vast amount of structured and unstructured data on genomics using the genome banks, which are currently present in the pharmaceutical industries, post-pathogen interaction, immune response, and drug target interactions in a very short given duration of time. We all know that a drug development is a very tedious and lengthy process, but using an AI, the amount of time which used to get all this interaction, both pathogen interaction, immune response, the gene data, all this becomes very short. So it just aids in the development of new drugs. It enables researchers for identifying potential drug candidates and design new therapies or repurpose existing drugs in a smaller time frame. For example, we have seen this repurposing happening in COVID-19, during COVID-19, where the existing drugs were used for different permutation and combination for COVID-19 treatment. So such technologies are being used for anti-parasitic drug discovery for malaria, American trypanosomiasis, and COVID-19. So a very small screenshot. I have added the sources where the participants can go back and read how different way the drugs can be used, and the AI technology helps in with the drug development and to understand its efficacy and its interactions. For disease outbreak part, the predictive AI-based modeling is done for infection outbreak forecasting. So by harnessing previous year data on retrospective disease pattern, the seasonal trends or number of people infected, the age, the population cohort which has been infected, the health records of the hospitals or the surrounding areas, the pathogen data which are there with the public health domain, the satellite image, real satellite image which is available, the mobility data depending on the travel history of the patient, of the people, and the geospatial features, which include the forest coverage or the water body coverage or the type of land. All those features which are present either at the health system level or at the public health domains can be used for predicting can be used for predictive AI-based modeling and give the prediction for the upcoming disease outbreaks. So these are the data which can be used, and it has been all these data at a very small scales are being used for forecasting influenza epidemics in Hong Kong, dengue fever outbreak in South American countries, Zika virus transmission in Africa, and for risk for cutaneous leishmaniasis in several countries. For disease surveillance, the AI also in a similar pattern it does gives us versatility in for giving early warning signs, epidemiological tracking, and even helps in allocation of healthcare resources in a better way to give a better outcome in a and not increase the financial burden on a country or an organization. So Health Map being for one of the examples, it's an internet-based infectious disease surveillance system that identifies the emerging infectious disease outbreak in a real time. So at a health map site, when you can go and see, and we can see what all kind of has been reported within the country, and it can ranges from different infectious outbreak which is happening in the country across the globe. EVA was one of the AI learning system which identifies individual at risk for infection, was used by the Greek government for to reduce the number of asymptomatic COVID-19 infected people for during the COVID epidemic. So, pandemic. So, through EVA, what the EVA AI learning system was the system which was deployed at the border crossing areas with the travel for the people traveling, and they were screened through EVA. The main reason for deploying that AI system was that it triaging patients who are more prone getting COVID infection, so that those people can be tested at a earliest level and can be isolated as per the requirement of the government. So coming to AI in health in India, how Indian government is working towards the AI part. So currently advancement of AI is hastily changing the face of healthcare in India. India, the AI market is predicted to go from 14.6 billion in 2023 to around 100 billion by 2028. As per NASSCOM, AI in healthcare has a potential to add about $25 billion to India's GDP by 2025. AI can become an enabler for rural parts of Asia in short-term. Currently, several AI-based solution companies for both for profit and non-profit are working for multiple projects for screening for diseases like tuberculosis, diabetic retinopathy, detection abnormalities like brain bleeds, cranial fractures, stroke, cancerous lesions, and prediction of at-risk adverse outcome and disease outbreak in the country. So coming to the organization where I currently work, we are AI for Social Impact. It's a non-profit organization. We are a cross-domain AI impact institution, which helps in developing and deploying AI solution with the government of India. And we have a MOU with Ministry of Health and Family Welfare for developing an AI for the government and the public health use. We have AI solution across various domains, that is healthcare, agriculture and climate, and education. Currently, we have 30 plus AI projects at different stages for modeling, for application development, as well as deployment. We have 3 AI Center of Excellence where we collaborate and where we have the medical professionals who help us in developing the AI solution or for refining the AI solutions. That is AIMS Delhi, AIMS Rishikesh, and PGI Chandigarh. We have several collaborative partners. We have 40 plus collaborative partners, which include the government partners as well, the ministries, the government partners, as well as we have several NGOs who are being supported, with whom we are working and supporting us. Currently, Vadhvani AI under various domains is present across these many states and union territories of India. So Vadhvani AI have several AI solutions which are currently deployed and for infectious diseases under the Ministry of Health and Family Welfare. So the digital solution, first one is automated outbreak monitoring, like for the disease surveillance part. We have a media scanning capabilities at the central and state level, which helps to identify any event-based disease outbreak monitoring system. And currently, this is integrated into the IDSP IHIP portal. We have Cough Against TB, which is an AI-powered pulmonary TB screening tool using cough sounds and comorbidity and symptom for triaging the patient who have most likely chances for going for developing tuberculosis. We have Flying Probe Assay, which uses computer vision to reduce human error and processing time in drug-resistant TB diagnosis by automating the reading of the line probe assay strips, which gives the resistance pattern for the TB patients. There is another solution in tuberculosis, which gives a prediction for adverse TB outcome for predicting the TB patients who are at a higher risk for developing adverse outcomes like loss to follow-up and mortality during the TB treatment. And vulnerability mapping, which gives use location coordinates for the patient and gives a remote sensing hotspot and spot mapping for predicting areas where the people are at a higher vulnerability for developing tuberculosis and other infectious disease. So I'll be talking about all these solutions one by one. So automated outbreak monitoring is a solution which basically use all the news articles which are present at an online domain in various languages used in India, as well as the YouTube videos where all the outbreak events which have happened, and then it extracts the detail of these news articles and provide the details to the central or the state government, and the final events are being confirmed by the state and centrals whether they have an outbreak which needs immediate response or it's a normal event which has happened across the state. So it detects and create timely alerts for the potential outbreak. It gives a real-time analysis and classifies the data and utilize data and even published online. Cough against TB, it's used for the individuals which work at the ground level at health and wellness centers or during the active case finding scenario. And they are being used to screen using a cough by taking 3 bouts of cough as well as the comorbidity data of the patient. And by that, AI solution will give the prediction whether the person has high chances for developing tuberculosis or not. So it's an easy to use, non-invasive, no cost and point of care screening test. The solution works on the Android-based smartphones, and it provides inference within 3 to 5 seconds of taking all the data, and it's functional in offline setting also. So it can be easily used in the rural setting or a remote settings within the country. So line probe assay, it is mainly developed for the culture labs or the reference laboratories of the tuberculosis under the tuberculosis program. So it helps to automate the reading and interpretation and transmission of line probe assay strips, and it provides the inference within 3 to 5 minutes, which was initially taking around 1 to 2 hours for interpretation by the LTs or the microbiologists in a manual manner. For prediction of adverse TB outcome, the solution uses the data of the Nikshay platform, which is currently the biggest platform, the online platform for all the TB patients' data. It uses the patient data and then it gives the predictions using the Nikshay variable and gives the prediction for the patient who have high chances for going loss to follow-up on mortality, thus aiding the healthcare workers to provide little bit extra effort or little bit extra care for those people who are who have more chances for leaving the treatment in midway or have more chances to go for an adverse outcome. So this solution itself is it also works on a web portal and Android-based smartphone, and this field, and it also works in the offline setting. For vulnerability mapping, the solution identifies vulnerable areas for TB and based on the location coordinates, and the solution looks like something like this. The photo next to it just gives the details about how the geospatial features looks like and where the high chances for finding a tuberculosis case is there. It ranks the villages or the ward to help the healthcare workers prioritize their use of resources in efficient manner for active case finding activities. The challenges, as the previous speakers have already talked about, we have data privacy and security challenges in developing all the AI solution. And we have to be very careful that there is no data breach or unauthorized access to the data which is being used for developing the AI solution. Then comes the data quality and availability. The biggest problem for developing any AI solution is the type of data quality which we get. For developing an AI solution, we need a very large quantity and a high data quality data sets for training. And usually the healthcare data currently which are being received are fragmented, incomplete, or of varying quality. So that poses a challenge for developing an AI solution, which is being very used, which can be used for a larger domain or the larger sector or of people. Their compliance AI application should be transparent and acceptable and should meet regulatory standards set by healthcare system. Currently, ICMR is one of the organizations which do a health technology assessment, and they do a third party evaluation, and as a regulatory compliance, they do give go ahead with the AI solution, whether they should be deployed or integrated with the healthcare system or not. Operability, integrating AI into existing healthcare workforce can be challenging because we need to customize the AI application, which need to favor the healthcare setting for the, be it rural health for healthcare workers from whom it is being used, so that there is essential, it becomes very essential for its successful implementation and also to help the workforce for better use. User acceptability, again, like I mentioned, to ensure that the healthcare staff can use AI system and a lot of education goes into picture in that the healthcare workers who are at the rural, who are there, who are supposed to use the AI application, need to be trained on the use of what the AI is and how to use the system and how the system or the AI solution is going to help them. And long-term sustainability. So AI model requires continuous updation. The more we update the AI solution, the better it becomes. And monitoring, it remains very effective, that we need to monitor how the AI solution is working in the field, whether it is giving a correct outcome or the required outcome or not. If it is not, then we have to go back and retrain and update the model so that it does not give any negative outcome or negative update to the people who are using it. And it has to be updated with the evolving medical knowledge and practices. So medical officials or the medical background folks are required to give continuous inputs to make the AI solution effective. Other than the infectious disease AI solution, we have the Badwani AI also have certain other AI solutions which are currently deployed across various geographies. So we have clinical decision support system, which is a AI-powered telemedicine system to assist doctor and other health providers for more efficient and informed resource and care management. This is currently integrated with eSanjeevani 2.0 platform by the eHealth division of the ministry. We have dermatology solution, which is being developed in collaboration with AIIMS Delhi. It's an AI-based computer vision solution for detection and diagnosis of common skin conditions. Around 6 to 7 common skin conditions are being developed under the solution. Then we have chest X-ray radiological feature detection model, which helps in detecting radiological features in chest X-ray, both for lung and cardiac anomalies. We have ophthalmology solution, which we are developing and have deployed within AIIMS Delhi for screening for diabetic retinopathy and corneal opacity to reduce burden on physicians and ophthalmologists for the district hospital. And AI assistant for ASHA, an AI-powered conversational agent to aid frontline health workers in knowledge retrieval for daily task optimization, especially for the ASHA and Anganwadi workers. This is currently in 2 languages, English and Hindi, and we are developing different multilingual model as we speak. Under MNCH, we have 3 models, which is newborn anthropometry, undersick pregnancy risk stratification. The newborn anthropometry and undersick anthropometry is basically a AI model which can accurately estimate the weight of the newborns within the newborn anthropometry, and to capture anthropometric measures of the kids. The pregnancy risk stratification is used to predict for maternal and newborn complication and adverse outcome. It is supplemented by the built-in decision support for prevention and management. So it just helps for the little bit earlier detection of the women who are at a higher risk for maternal and newborn complication, and those, so that they can be provided additional support at earlier level. So to summarize, there are certain challenges and there are certain advances which are there in infectious disease domain. And if we talk about challenges, we have ethical and security issues that it should translate the benefits for everybody, not just for the high income countries, but also for the low income countries, and the data poverty, where we have limited availability of data sets for unbiased and effective trading. Major areas, it can be used for disease forecasting, for drug discovery, and especially for diagnostic and screening part. Thank you. If there are any questions, we can take the questions also.
Thank you, Dr. Aparna ma'am, for this very insightful topic, because you spoke about the extensive use of artificial intelligence in various fields, spanning from screening and diagnostics to drug discovery, to disease outbreaks, to disease surveillance. And even you introduced us to Vadhwani AI and what Vadhwani AI does. Also, you spoke about vulnerability mapping and the challenges in use of AI. But you also spoke about how it can be used for CDSS, for dermatology, for chest X-ray, for ophthalmology. Even for Asha, someone had asked how can AI be used in primary healthcare. So that was one of the questions. So I think you have answered a part of it, that AI assistant for Asha, newborn anthropometry, under 6 anthropometry, and even pregnancy risk stratification. These are various ways in which AI can be used. I think that can be used for primary healthcare. So I would request the audience, if in case if you have anything very specific to this particular session, then maybe we can answer, because there are many other questions which are already there in the chat box, which we will be definitely taking up during the panel discussion. But if anything very specific to this particular discussion, if anyone wants to ask, you can definitely go ahead and put it in the chat box. We can ask Aparna ma'am for the same. Okay. Thank you, ma'am. Thank you so much for your talk. We would there's a slight change in the schedule. Basically, now we are planning to take a break now, and we will start sharp at 1:15 p.m. So requesting the audience to please be with us, because there is going to be hands-on live session wherein there will be a demonstration of AI, use of AI after the break. So we welcome you all after the break. So we can all take a break now until for the next half an hour. Thank you. We'll be starting in the next 2 to 3 minutes. So welcome back everyone for this post-lunch session on for today's webinar on artificial intelligence and digital tools for public professionals. Stage to Dr. Prasad Vengamkar sir, HOD of Department of Community Medicine, to take the course of discussion forward. So,
Welcome everybody in the post-lunch session. Dr. Alok Modi is soon joining with us, who will be giving the hands-on about the use of ChatGPT and other applications in the artificial intelligence. Meanwhile, there have been quite a few questions which we have received in the chat box. So, addressing to that, this question from Indra Vijay Singh: how GPT will provide help to patient interaction with doctor? Well, I think this will be answered in Dr. Modi's session and in the panel discussion. Does the ChatGPT require access to various data on the device, like location, documents, microphone, etc.? This is from Anupriya Mohakar. So this also will be clear in Dr. Modi's session. Then there is a question from Pranav Nimmagada. He wants to know how should a startup associate with NHM or other public health organizations to improve the current prototype to a fully deployable solution for large population screening non-invasively and efficiently, and how to approach the government for implementation. Given that our primary customers are governments and NGOs, please suggest any other methods to deploy the solution of scale for both revenue generation and sustainability for the startup. Dr. Nimagada, are you online? Pranav Nimagada? There have been similar questions by few others regarding the startup. There has been a question as a startup, how to associate with Vadvani AI.
Yes, sir, I'm online.
Yeah. So actually, before your question reached, the session got over, but we approached Aparna from Vadvani and she has given the reply. So I'm just forwarding it to you. She has mentioned that startups can send an email to me at aparna@vadvaniai.org, mentioning about their organization and what they exactly want to work on. Then we can take forward the conversation.
Okay.
Thank you. Then there is another question.
So pertaining to just 1 minute before you move on. Pertaining to the previous questions with regards to the.
I thought it was in continuation with that. Anyway, one thing you can do is you can approach the Vadvani as well as you can approach to the IPHA if you are interested in National Health Mission activity and all that. So you can write it to us, iphaMaha@gmail.com, giving the details, and maybe we can meet and you can demonstrate us what exactly you are doing. Is it fine with you?
Sure. I can share the details.
Yeah, thank you.
Thank you.
Email address for IPHA Maharashtra is iphaMaha@gmail.com.
Sir, if you don't mind, can you just leave it in the chat box because I
Okay, we'll
might
put
get
this
it wrong.
in the chat box. Yes, sure.
Thank you.
Then there is another question. Answers provided by it, how correct it is. That is regarding the chat GPT is the question. But GPT will not provide any graph. Answers been by Indra Vijay Singh. I think this will get covered in Dr. Modi's presentation. Then from Ashutosh, patient's data is being collected, so it is not leaking the data, and especially it's sharing details, talks between patient and doctor. Now, yes, there are ethical issues in the artificial intelligence. In fact, much beyond this also, and these will come up during the panel discussion. But you are very right that the way when we collect the data for the research, obviously the consent part is important. I mean, when the patient is consenting, then only you can utilize that data for the as you use it for the research purpose. Currently, there are no ethical guidelines or a regulatory body for the artificial intelligence apps. In fact, not only the ethical, I mean, as per the some of the questions which have been mentioned, that how correct the data or the answer is. And in fact, some of the artificial intelligence apps have been noticed being giving the wrong answers. And if somebody believes them as an authentic, that won't be correct. But for that, there has to be a regulatory body that which will permit that particular app is authentic and that can be used by the population. So unless that regulatory body is there and takes that decision, it will be a little difficult. Then, this question I think Dr. S.V. Kulkarni has already answered. Do you think the AI will replace the doctors? So, as he has rightly said that those doctors who will not use the AI, they will be definitely replaced. Then this question is, should we accept AI as the end user, or we should delve into coding as well, or apply in healthcare development? Now, obviously for them, whom it is difficult for the coding and all, most of the packages, newer packages which are coming, they are basically end user friendly. Now, even if we see the chat GPT, you don't have to do any coding. But then at the same time, if we see the R software, which has become a popular for the statistical analysis, to give certain commands then, unless you're using R Studio. So it is as per the comfort zone of the user that which package or which artificial intelligence app you want to use. There is one question from Dr. Uma Maheshwari that can we get the recording or PPT? Now, this entire program is being streamed live on the YouTube, and also the recording of the program will be available on the YouTube. But we cannot share the individual PPT of the presenters because that is an intellectual property of that particular presenter. If you want that PPT, then you can approach the presenter directly and get it from them. But otherwise, the recording will be there on the YouTube. Then from Kalyan Bura, how AI can be used at primary healthcare level? I think that has been answered by Dr. Aparna's presentation that she has mentioned. Many of you may be knowing that just 2 days ago, there was a World Malaria Day, 25th of April. For malaria in Africa, they're using ChatGPT based software for the practical use in the public health. Simple for the prescription in the local language, because in Africa there are so many languages being spoken. And then if you want to make the prescription to be prescribed into that particular specific language, how it can get converted? They're using a ChatGPT app. ChatGPT 4 is obviously required for that, but that is there. As a startup, how to associate with Padmani I had already mentioned, and then we'll put these email addresses into the chat box also. So I think Dr. Modi has joined, and I hand it over to Dr. Ganesh to introduce to Dr. Alok.
We welcome Dr. Alok Modi with us amongst us for talking on the topic demystifying artificial intelligence for public health professionals. Dr. Alok Modi has multiple fellowships and degrees to his advantage. He's a consultant diabetologist. He's a critical care specialist and the co-founder of Doctors AI, which we saw with Dr. Amit Kumar Day as well. So he's a fellow of a lot of associations like American College of Physicians, Indian Society of Hypertension, and he's also the head of Artificial Intelligence Cell of American College of Physicians India chapter. He's a certified Microsoft Office trainer and artificial intelligence and health sciences. There are many more awards and recognitions that he has got, which is difficult to cover in this short span of time. So we are privileged to have him here with us today. So I hand over the course of discussion to Dr. Alok Modi. Welcome, sir. Please take this discussion forward.
Yeah, a very warm good afternoon to all of you, especially Prasad. He's my batchmate. It's real fun and a lot of pleasure. Ashlesha and all the respected organizers, Vice Chancellor Sir, and a warm welcome to all the delegates who are here to leave their natural intelligence and to hear about artificial intelligence. And like Amit said, it is augmented intelligence. And like I say, it is a mix of both intelligence. Human intelligence gave artificial intelligence. Artificial intelligence is here to augment and help human intelligence or natural intelligence. So what I will do is all of you have been exposed very brilliantly, starting from Prasad, who gave a very beautiful foundational laying down of what AI is all about. Amit covered it very nicely. Dr. Kulkarni sir, who we call as a Bhish Pitame of technology very fondly in our group, and he's covered a lot of aspects. So, it's very nice to keep hearing about the ice cream and the pudding, but the real fun comes in tasting it. So I'll take you to the practicals right now. I'll show you what real life is all about. So we use AI in our day-to-day life. I use it in my real practice and we use it for a lot of work. So what we do is we create papers out of it. We generate prescriptions. We generate patient-related seminars and educational tools. We have our own chatbots. We're using it in real life. I've also created my own builders on ChatGPT. And the first thing is all of you need, students and delegates and all of you need to create PowerPoints. So I'll be showing you in real time how you can use ChatGPT to do things. So let me get comfortable with AI for you guys. Now what I'm showing, let me first, I need to share my screen. So I'm sharing that task screen. So is my screen visible now?
Yes, sir.
Organizers, am I audible?
Yes, sir.
And is my screen visible?
Yes, sir.
Okay, fine. So what you're seeing right now is OpenAI. So this is OpenAI, and that's the company behind ChatGPT. 70% stake is by Microsoft. So Microsoft controls a lot of stuff in OpenAI. Now here is my ChatGPT. Now let's say I want to create a PowerPoint, and let's see. Let's tell ChatGPT to create a PowerPoint on prevention of malnutrition, okay, in gestational in pregnant women. This is a natural language processing because I'm not writing any coding here. I'm talking in simple natural language. Create a PowerPoint on prevention of malnutrition in pregnant women. I've reconnected. Am I audible now? Is the net? Can I be heard or is my screen visible?
Yes, sir. It's visible, sir.
Is my screen visible?
Yes, screen is also visible.
Okay. So as you can see, I gave the command to ChatGPT to started creating the PowerPoint. Now you see all the slides are being created by, am I audible? Because I can't hear your voice.
You are audible, sir.
Sorry?
You're audible, sir.
We
Prasad, I
can
can't
hear
hear you.
you.
Am I
We can hear
clearly
you.
audible?
Yes, sir. Clearly audible. Yes, sir.
Copy these slides. Having done that, open up Microsoft Office, which is the online version, not the installed version. Okay, that's very important. All of you have an email ID or a Hotmail ID. You need to have a Hotmail account with Microsoft. Either that's an Outlook account or a Hotmail account. That's obviously free of cost. Very few people know that once you have an Hotmail account, you have open access to Microsoft Office free of cost. All the flavors of Office are there with you. As you can see, my Hotmail account is opened up. Microsoft 365, which is the current nomenclature for Office, is opened up. So now I'm going to open up a Word document, a blank Word document online, not the installed Word. That's very important to understand because you won't get this feature in an installed Office document. So I'm opening up a Word file over here. Okay, having opened up, I just paste it. You got that? The slides are pasted in Word. I go here, I export it. Please mark my steps. I export it to PowerPoint. Okay, this feature is not there in an installed Word. When I do that, it's going to tell me which theme am I going to prefer. So let it load the themes. I think the net in this hotel is a little slow. Maybe I'll switch on to my hotspot here. Give me a minute. I've just checked in. I've been traveling extensively. So pardon me, and I'm sorry for all the trouble. Let's connect to my hotspot. So I try to export this file. The net is quite weak. I can't work unless it gives me the themes. See, what will happen is it will load the themes. Once the themes are loaded, you select the theme and give the command. It will create a PowerPoint live with all the slides. Once you do that, you can download that PowerPoint onto your desktop or wherever you want on your computer. And having done that, you can start manipulating the PowerPoint the way you want. Now, how do you manipulate it to get a very good thing? Let me show you that. I've done that with phosphomycin. So let's see. It's not getting loaded here. There is some problem with the net here. Now, see, I had created a similar tutorial for another session which I had taken, and this was on phosphomycin. So I just got the slides prepared on phosphomycin by ChatGPT. Now see, this is the phosphomycin slide which it created automatically. You can see the graph and the coloring done by the PowerPoint AI, which is inbuilt into PowerPoint. Now what I will do is I'll just save this, or I'll give you a better example. Let me take a PowerPoint which I've created, which is a little bland here so that you can understand. Because when you copy from Word to PowerPoint, it gives you very blank slide with only the headings. Nothing else is there. So I want to show you how that works. There is some problem with the net over here. Anyway, so what I want to show you is, let's say we have this PowerPoint here, right? Okay, now this is the phosphomycin PowerPoint which I had already downloaded. Now, what's important to understand here is, once you have this PowerPoint, there is an inbuilt AI into PowerPoint. This is called as Designer. You see this Designer tool over here? Is my screen visible? Just click on the Designer and you will start getting a lot of design ideas. So you can see different forms of PowerPoint which would color, which would give different impact. Different kind of scenarios would be created automatically by Microsoft. This is the AI which is inbuilt. So if you have a blank PowerPoint, let's say suppose I say I just remove this over here. Okay. I remove this and I remove this picture. Now this is a blank, this thing, right? The moment now this is what it looks like. I want it to look better. I want it to look more presentable and nice. So the moment I click designer, see it creates so many wonderful patterns. You see this? It can give you a lot of ideas which would suit you. And depending on what your theme is all about, your talk is all about, you can create a PowerPoint which looks good, which is present. Add a lot of features. So this is what you can do, and then you can download and save it and keep it as a PowerPoint presentation. Now, the next question you will ask me is, ChatGPT gave me the basic content, right? It gave me the basic thing. Now, suppose I want to talk about educational programs and resources because that fits with the theme of preventive medicine. So once I do that, I tell ChatGPT, good, you have given me an outline. You talk to ChatGPT in NLP like a normal person, like you're talking to your secretary or your resident or your student. So you say, good, I like the presentation. Learn to give proper prompts or you won't get a good answer. What Amit said, if you give a wrong prompt, you'll get hallucinatory answers which are not correct. Now, good, I like the presentation. Please give me 5 slides elaborating slide number 12. Okay. Education programs and resources. So it will work on that. Now give it some time while it's working. It will expand. See, it talks to you like a friend. So we are expanding on slide number 12. So it's further on scans all these resources from till November 2022. There is something called as Microsoft Azure, which is a collection of all the databases, okay, of all the research which is there on the internet. The entire data of internet is stored by a pot, a sort of a room or a collection, which is called Microsoft Azure. And Microsoft is lending this Azure to ChatGPT, and that is from where it's getting its data. So you see that, so it gives you all the detailed slides which are coming in. And having given all these slides, you can again convert it back and add it to your presentation and make it more colorful. Now, in that subtype of that slide, if you want like accessing and utilizing resources effectively, you can again ask it to make another 5 slides with references. So give a prompt, give me references and give me the Vancouver references. It will give that, and that can be added to your slide. So that's a very beautiful way of making a presentation. Of course, this is not the final presentation. You need to add your data, your understanding to that presentation and make it the final presentation when you go for a national or international meet. But 80% of your work is done in less than half an hour if you do this. I actually use this method to create my own presentations, and I will be just showing you my own presentation which I have created through these methods. And AI is something that I use very extensively in my work, in my research work to do this. So this is one way. There is another very beautiful way, a little tough way, which I like. Now what I will do here is I'll tell ChatGPT, give me the code, the actual code, give me the VBA code, the Visual Basic Code on which Office works on this same topic for 15 slide presentations. Okay, so I'm asking for the VBA code over here, but it will give me the actual VBA code. Now, this is something I like because it gets my hands really dirty and it gives me a much faster way to do this instead of going through all the online. So it's actually writing the code, as you can see, as in real time, writing the entire code. You can actually create AGP codes. You can create codes for an app which you're creating. You can use a good AGP system which can link your code to your WhatsApp and make your whole ecosystem running in a very beautiful way. So see, it's written a code over here, right? Now, whatever code it is writing, let it finish writing, and we just take this code and put it in Microsoft PowerPoint and get it out. So see, it's written the entire code here, right? Now take this code, just copy this code here. Now come to PowerPoint. Now here is something which I've opened up over here, right? In this PowerPoint, now there is a code, there's a developer tab here, right? This is where the real machinery, the factory works. Click on the developer tab, go to Visual Basic over here. Once you open up the Visual Basic console over here, go to the VBA project and insert a new module. Got that? Now, having done that, just paste the code over here. See, the entire code is pasted here. Run the code. You see this play button here? Run the code. Okay, sometimes there is an error if there is not a debugging done. Sometimes there is a little problem. It happens if you have not given a proper prompt. Let me do this once again and let me ask ChatGPT to rewrite the code for me. So let's just do this. Let comes to this. So here I just copy this, create a 15-point slide PowerPoint presentation on prevention of malnutrition in pregnant women. And I tell ChatGPT this. And one second. In VBA code. So let it write the VBA code again. So it's created the code here. So now I just copy the code here, go back to where I was in Office. Here is my PowerPoint. I create a new module here. And I paste the code. And then I run the code. Okay, unfortunately, it's creating a bug. Sometimes there is a problem, but then if you're successful, if you're able to debug or if you're able to run the thing, it gives you 15 slides instantly, very beautifully and completely. Try it with some topic, it will work. I don't have the time. I need to debug it. Sometimes you have to do that little debugging, it works well. So the slides are ready. And having got those slides, you can use AI to change the slides to the format you want. Now, this is one use of Chat GPT in real life. Now let me go to another presentation, and I've actually published papers on it, and my papers have been accepted in leading journals when I do this. So now how do I use Chat GPT to write a paper? So let's come here, and I think this is something which you all will love to do. So let's say I want to publish a monograph on air pollution in Mumbai. So write a 5,000 words monogram for air pollution in India, let's say, with updated references in Vancouver spelling. Okay. Even if you don't correct for the spellings, it's okay. ChatGPT understands, it will correct it. So let's ask it to write, it will start writing. So it's giving me an outline. I'm not interested in an outline. I want a proper 5,000 word monograph. So I'll say, I'll stop it. I said, kindly write a detailed monograph. You sometimes have to fight with ChatGPT. Many times I fight with ChatGPT and get what I want. So it's understood that I want creating it's quite a project given the depth and breadth. I'll draft a detailed outline and include an expanded abstract. So it started writing. Now say it will give you a little smaller thing. It won't give you 5,000 words, but it will give you something. Now you read it, copy it into your Word document, paste it into your Word document, and see the features which it has found out from its own resources after doing a lot of research. Saves a lot of your time in doing the research. Having seen that, pick up certain paragraphs that you like and ask it to amplify that and increase it and give you another big monograph out of it. So then you have to collaborate and work on it. So this whole monograph gets ready and you can put graphics on it. Now, how do you add graphics to that? Now, for that, we need to go to another AI. Now, ChatGPT uses Della 3 by which it can create graphics, but this is another AI called Copilot. You see this Copilot? Now, this Copilot comes installed with Windows, or you can buy the Copilot for 2,000 rupees. Now, remember one thing, the ChatGPT that I'm using, like Amit told you, is ChatGPT 4. You can get a free version, which is 3.5, but it won't give you a lot of leverage. If you want the updated references, updated till November 2023, which is what 4 does. 2022 to 3.5 is updated till November 2022. So this is what we pay for, and we get the maximum benefit when you buy ChatGPT 4. You have to pay roughly 2,000 rupees per month. There is no concession as far as I know on any portal. You have to directly pay on the account section of ChatGPT. You can also buy Copilot, that is called as the professional Copilot, but Copilot uses all the resources of ChatGPT. So I don't think you need to buy both. You can prefer whichever you buy. And once you do that, you can copy this monograph. As you can see, the references are here, right? So if you copy this monograph here and take it into your Word document, and then now you ask, kindly create a good graphic on air pollution for my monograph. Once you do that, it will take some time, but it will create a good graphic and give you an actual image, which you can copy and put it in your document. It's remembering my previous conversations. So it's telling me to move to a new topic. So I'm doing that. I've given it the instructions. Now let's see how it does. But the problem here is that the net is very poor here. So I'm not able to function the way I would like to function. I'm very sorry for that. I'm not getting a good net here. It's a very poor internet over here. That's one thing of technology. You are really helpless if we do not have a good net. So see, now it's going to try to create it. Now you can include a data on different air pollutants. You can use visual comparisons. You can highlight the health effects of air pollution. So I did that. It will create a graphic. While it's doing that, let me show you some other things of ChatGPT. Now I told you can create a prescription out of it. Let me show you how you can do that. So I'm giving it a case scenario. Mr. Kumar, 70-year-old male, South Indian, is having pulse 88 per minute, blood pressure 170 by 100 millimeters of mercury, creatinine 2.1, fasting blood sugar of 230, post blood sugar of 340, HbA1c of 8.9, cholesterol of 340, kindly generate the prescription. Now it will tell you that it's not his job. It will not generate the prescription. It is not the thing that it's supposed to do. It will not give any preventive advices, but that's how ethical it is and that's what it's trained to do. But then if you persist behind it, it will create. Now it's giving you an outline that these are the things which are required. These are the things like Amit told you, you can ask for the health advices, the preventive advices, the food advices, the calorie counting advices. All those things are here. Now, this is not a replacement for a doctor. It will not generate a prescription, but it can give you a very good idea in your busy schedule, and you can get a lot of preventive advices out of this kind of patient scenario, which you can copy down and give it in any language of his choice. Now, I will go a little step ahead and I'll say, kindly generate an actual prescription. Real-time prescription. See, it says it's not a legally valid scenario. I cannot replace a doctor. I can't do that. But it is creating a hypothetical prescription. Now, this is where the fun lies. It tells you exactly all the medicines that it has to take, what are the dosages, which insulin, what amlodipine, how much atorvastatin, everything which it thinks is right, it will tell you. Now, this is not the way to replace it, but it will give you a lot of insight and tools what you should do in case you are able to not remember a certain drug. Now, I wanted to give me some preventive advice. Give me preventive advices on this patient, and I wanted in Bengali language, in Bengali. So let's see what it does. Saw that beautiful thing? Isn't that good? So I actually use it in real life in my practice to work as my assistant. I use it in so many scenarios. Now, I'll go a little step ahead and I'll show you how to do it. Give me BMI and eGFR for this patient. Now what happens here over here? Okay, stop. I got the answer. I understood. Now give me BMI and eGFR for this patient. Now when I say that, it does that. See, now it will tell me you have not given me the creatinine, you have not given me the height, you have not given me the weight. Give me all that. Okay. So give me the gender, give me the race. Okay. So height is 5 feet 4 inches. Weight is 120 kilo. South Indian. Go ahead and tell me what to do. Now, see, it's going to actually analyze. So you need not open up the calculators, the formulas, and anything. It will do. So, what is ChatGPT? ChatGPT is nothing but a pot of mud. It's a pot of paper. It's a pot of a child's tool. It is your creativity. It is your thinking. It is your need, which you can use to create the scenario that you want. So, the right prompt, the right scenario, the right thinking, and the right creativity can give you all the information that you need. As you can see, everything has been done here. Now I've created a prescription. Now I have done something which helps me in my real life, which can help you in your preventive life, which is what it's now this is something which I've created. Dr. Alok Modi's prescription drug interaction checker and Dr. Alok Modi's SMBG AGP calculator. I'll show you what that is. That is something you can also use, just as Dr. Amit has created his own ChatGPT builder. This is Dr. Alok Modi's prescription checker. Now, once I've created a prescription, my patients are on antifungals, antibiotics, antiarrhythmics, cardiac drugs, antihypertensives. They can have interactions, right? They can cause confusions and complications. Now, will you open up your Google base, open up your books and start going through the interactions and look for what can happen, what QTC can get prolonged, what can happen to the cytochrome P450 levels, what can cause hepatitis and nephritis and all that. Wouldn't it help if AI can do that for you? So let me show you that. Give me drug interactions on this prescription. Okay, so now it will tell me what interactions are possible, but I've not given it a prescription. See how intelligent it is. So see what answer it gives me. It looks like you want to check for drug interactions, but I need to see the prescription. So, okay, so I give it. So you see this clip sign. Here is where you can attach an image, you can attach a Excel sheet, you can attach a Word document, you can attach so many things. So now what I'm doing here is I'm attaching a prescription here. Okay, now this is one sample prescription which I've actually created for a patient. I've attached it over here. Let it get loaded. My problem is the net is very slow. I'm so unhappy about the net over here. Now I've attached it over here. Now see, it has got dapagliflozin, it has got AKT, it has got, see, it's going to, and I didn't even tell that that's isoniazid, rifampicin, ethambutol. I'm writing the brand names, which is Horcox. I'm writing Depavel, which is dapagliflozin. I'm writing Fragile, which is metronidazole. Now it is reading the whole thing, it is interpreting it from its own database, and it is telling that these are the drugs which are present in your prescription. This is what will happen when fluconazole will combine with isoniazid. This is what will happen when metronidazole combines with rifampicin. So before you dish out the prescription to your patient, you can go through all this and realize what all things can go wrong in your prescription and change your prescription accordingly. Now, this ChatGPT builder is what I have created myself, and I'm using it in real life. It's getting trained in more than 2,000 patients, and it's giving me wonderful results. It's available free of cost. Those of you who want it can start using it. Now, another scenario is biostatistics. You people are doing a lot of statistical analysis. You have data in which you can do students pair t-test, you can create graphs, you can publish papers. Let me show you something over here. Let me show you a dummy. Now let's show you something which is working here. Now, this is a correlation CSV data. I'll just show you what that data is. I upload this data here. Okay, and I ask ChatGPT, kindly run the correlation analysis. Now, see, it's going to start doing its own biostatistics. You don't have to put in any formulas. You don't. Okay, one second. It's gone into another. Okay. I am sticking to that. I'm sorry. I need to come out of it. I need to go back into ChatGPT 4. Okay, here is where I need to load. I was loading it in my ChatGPT build. So I come back to this correlation CSV data. I load it and I say, kindly run the correlation analysis. Now it's going to analyze my data. It's going to give me the entire precision analysis on my data and will tell me where I'm, what it means and how does it set. Now, if the file is not loaded properly, if it doesn't consist of a proper data structure data, you know what Amit and others were saying, you need to have structured data. You can't have silo data. So if you're not having a structured data, it will do that for you. So it's going to correct itself. You don't have to do anything. It will reload the data and they need to be identified correctly. It's cleaning up the data right now, and then it will analyze. So see, 3-4 times it has tried to improve your data and structureize your data on its own. See how much all your headache is taken care of. So it's not doing the analysis for you. It's done the analysis that is saying the relationship is not extremely small, extremely strong. I'll just show you the data. Give me the graphical analysis because I need to publish my paper on this. So it's analyzing the data once again for you. You saw the graph? See how beautifully the whole thing has come out in front of you, scatter plot. That's the best graph it can give you. All you have to do is just copy this image. You see this, copy this image, put it in your paper, publish it, send it across, and believe me, it will be accepted. I have got my papers accepted and published. Only thing is, don't just copy paste the data that it gives you, the analysis it gives you word to word, because then you will have plagiarism, because it's going to look up references to do that. You need to remove the plagiarism. There are AI apps available for that. I use that. Now coming back to Copilot, I asked it to create a image file of air pollution. You see the image file which is created? You need not know, there is no copyright issue here. You can directly download this image file, put it in your PowerPoint, put it in your paper and publish it, right? So another very real big time use. So ChatGPT, Gemini and Meta AI of Facebook, all of them can be, these are different AI tools. You can use it extensively, very nicely to do your research, to do your biostatistical analysis, to check your prescriptions, give advice to your patients for prevention, run database summaries and do so many things. These are something which we are doing, created by us, doing on our own. There are professional AI tools available. Now, if you have the time, I can show you a couple of slides which will show you what are the professional tools available in the market, which people in hospitals in US and in India are using in real time to treat their patients and to prevent complications in their patients. Do I have the time? Do I show that or do I stop here?
We can continue, sir. Please continue.
Do I stop here or do I continue?
Please continue, sir. Please continue.
Hello?
So we can hear you, sir. Please continue.
Should I continue with a series of presentation or should I stop here?
Put the message. Put the message.
Put message, sir. Yes, sir. We put it in the chat box.
So please continue with the.
Yes, sir. You can continue, sir.
Yeah, I got that.
Sir, you can continue, sir.
Saw that? Fortunately, I got the slide, the net is and I put designer on work over there, right? Based on the designer, you will get beautiful slides. Again, it's taking a lot of time because of the net issue, but then all these slides will get, see, you see this? You see the beauty of the slides which you're getting here, which can give impact, which can tell your audience what you're trying to say. So you can generate without doing much work. So imagine if you're putting up the research data over here, the AI which is inbuilt into PowerPoint can take that research data and can actually hook up and give you graphs and charts created live and actually do that in my real life. 99% of my slides which I'm using at national and international level are actually, you see the diet seen over here, balanced diet in pregnancy. See what an impact it is making because of AI. And all these slides can be saved research and your own thinking, and you can take it at any international conference. And okay, so that's one thing. Now let me walk you through what I was trying to tell you is some real life in real life. Okay, so for that I need to take you on another presentation here. Let me get that presentation for you. Okay, and all this work, like Amit said, we are not spending, we are not getting any sponsorship from anywhere. This is all our own work. So this is just to tell you about the history. This is to tell you what happens with an Apple phone, what happens with a telephone, what happens with the newer cars, what happens with the even with internet and with mobile technology. The people who were there were very much against it. They said these things are not going to last long. Today also we are getting a lot of people who say it's all fancy stuff, it's all exotic stuff. It is for something which is too complicated and it is not worthy of it. But trust me, AI is here to stay and will replace us if we are not AI-enabled doctors tomorrow. So these are some of the real-life scenarios of AI algorithms that are being used in real life. I'll go a little fast here because I time. Look at in radiology, it is being used extensively in the US. And where it is being used, this is Which LV, which is a real-time AI app. So what happens if a person gets a stroke? He's got a little facial paralysis, a little stroke. You don't know if there is a bleed in the brain. You don't know if it's an infarction in the brain. And that scenario creates problem because if there is a bleed, you can't give anticoagulants. If there is an infarction, you need to give anticoagulants or clot busters immediately, and you can actually reverse the stroke. Now, how do you come to that decision? It's very difficult to create an MRI image at that time and get it interpreted through a radiologist because in the first 6 to 8 hours, most of the MRI images are normal. So what happens is an AI interface works over here and it can actually create an image, whether it's an infarct or a bleed, to the sensitivity of 96% and 93.8%. That is how effective it is. It is being used in US in real life. And this does not need a higher-end resources. It can run right from your own mobile. So the radiologist can be sitting in one part of the country, the patient can be sitting in a rural area, and the treating clinician can be sitting in another part of the country, and the whole scenario works in less than 5 minutes. Another valuable AI tool is Lunit Insight MMG, where it picks up mammograms and can tell you whether this is a cancer mammogram or a non-cancer mammogram. The patient can get a mastectomy avoided, can get a breast biopsy avoided. Rapid AI is another AI tool which can pick up intracranial hemorrhages and to the tune of 95% and 94% within 3 getting walked into the casualty of a hospital. QXR is an Indian startup called Cure, and it is in function in Nanavati Hospital in Mumbai. Its pickup rate is 87 to 92%. It picks up lung cancers, tuberculosis, coronaviruses. It has been used extensively in AI got trained in COVID times itself and look at the mediastinal fat and can tell you whether the person is a pre-diabetic or is going to head for diabetes or not. The advantages of using AI in radiology, and it's being used extensively in radiology, is in renal failure patients where you can't give contrast dose is very less. So you can actually do contrast enhanced imaging in renal failure patients. You need not keep the technician inside the room, so the radiation exposure is reduced. The image quality can be manipulated by AI. So what you see is not what the reality is. AI manipulates all that and gives you an image pickup which is much higher than being picked up by a radiologist. So what happens is here is what Amit has already told you. There are 4 layers of neurons. We popularly call it as neurons. Actually, these are algorithms. So on 4 layers of algorithm, the image is processed through NLP, which you have already heard, natural language processing, and the output is again in NLP. It gives you a different image than what was clicked, but with a better diagnosis. So what happens is AI is being used now to take treatment decisions before the doctor takes the decision. And based on that, the precision medicine or personalized medicine care is much higher and enhanced. And people who were diagnosed as X disease are now being diagnosed as Y disease, which is much more accurate and much more pragmatic than what was being done without AI. Mayo Clinic is actually using AI to pick up lung cancers in cases which were not diagnosed as lung clinicians. Royal Free Hospital is picking up acute kidney damage within 2 hours the ICU, which was not being diagnosed for 8 to 10 hours after the patient walks into the ICU. So this is a real life scenario. You can understand that our acute kidney damage and chronic kidney damage can be picked up at a much hastened scale, which was not being done by clinicians alone. And the reason is they are not just looking at serum creatinine value, they're looking at your diet, lifestyle, and they're doing so many other parameters that they're looking at that they can pick up a propensity for AKT, which is not possible only on a pathological report. Much more examples of the skin cancer diagnosis, University of California AI-powered clinical decision support system, University of Alabama, Birmingham's AI system for picking up heart failure. All these things are getting picked up at a higher level of sensitivity and specificity and at a much faster plane than you can do with a clinician sitting alone. And a real life example is if you people have bought the Samsung AI, the S24, which is an AI enabled smartphone, and the Samsung and HB enabled laptops, they can capture image. And there is something called as Google search by ring. If you people have read the latest development of AI, the current method by which Google searches is on an AI system that is called as a Google ring. So you just draw a ring around an image or a substance or an article that you would like it to be searched. The AI looks into the search and gives you answers at a much faster and a much more accurate way. So in that way, skin lesions and cancer images and histopathological images can be scanned through AI-enabled Google search to give you a much faster and a much more superior answers than a clinician would do. Now, this is for prevention, which has been used in Hyderabad. Diabetes and hypertension by conventional methods of picking up as a pre-hypertensive and a pre-diabetic was
Can you hear me, sir?
seen to be
Dr. Alok, sir?
done in a much
Can you hear me?
superior manner. Yeah, I'm sorry,
Can you hear me, sir?
I couldn't get you. Somebody, Prasad, were you saying something?
I was saying, sir, this is Dr. Ganesh, sir, from MGM. Can you hear me, sir?
Yeah. Should I stop here?
Sir, sorry to interrupt, sir, since we are running short of time, but we would definitely want you to continue doing the same during panel discussion, because you again
So
are
I'll just
involved in the
stop
panel
here. I'll just stop here. I'll just show you just one or two things I'll show you by these AI tools. Diabetics was picked up to be much more in Hyderabad than was possible by other methods. And there are such fantastic tools being done in the world today. So just show you over here. Just this is something which I will take in the panel discussion. What is ABA? But I want to show you this. This is where things are. So many tools are there which are approved by US FDA. So many tools are in the pipeline today, and so many preventive drug delivery systems and preventive theologies and AI tools are there in the market, which are getting launched in the next 2 years. As you can see in the graph, tons and tons of tools which are approved are getting launched to do therapeutics and prevention of healthcare systems because of AI. So I'll just stop here because of paucity of time and we'll take it further. But this is just to give you an idea that AI is here to stay. It is doing phenomenal work. We are using it in our own real life with much more success than you can imagine. So thank you very much for the opportunity, and I'm open to question and answers.
Thank
Am
you,
I
sir.
audible?
Thank you so much. Thank you so much for the insightful talk, because you spoke at length about the use of Chat GPT, especially how we can use. Basically, we might have a few PG students also who can use it for developing PPTs and monographs, even BBA code prescriptions. You also spoke about correlation analysis, scatter plot, so graphical analysis. It was interesting to see how you were interacting with the Chat GPT in a very humanly way possible by using the words kindly and please. Whereas a Chat GPT really does not have any emotions, but still you gave it a human touch. It was very interesting to see. So and also the extensive use of clinical the Chat GPT AI in clinical diagnosis and treatment is amazing to see. At least more than 50, 100 tools that are coming up in the coming years. I think definitely all of us would want to learn a few of them so that we don't fall back and we are not left out. So as Kulkarni sir was saying, that if we don't learn AI, probably we will get outdated. So it's better that we start learning a few of them already. So thank you so much, sir. We would definitely get back to you in your panel discussion and listen to more of your knowledge and wisdom. We would go to the next speaker. We have with us today Dr. Ashlesha Tavde-Kelkar, who happens to be our faculty in MGM Medical College as well. She'll be speaking on the topic of Aayushman Bharat Digital Mission, Health Practitioner and Health Facility Registration, along with a team of National Health Authority, which she herself will be introducing. For introducing Dr. Ashlesha, she has done her MD from same MGM Medical College. She is also a fellow of Royal Society of Public Health. She is also a certificate holder in digital health, and she has been a consultant for digital health with MUHS and has been a contributor on the Digital Health Foundation course by MUHS. She has participated and presented posters on digital health and PMJY in Sangam at IIT Bombay. She was invited as a member at the Arogya Month in 2023. She has been invited at multiple places. She is quite a popular personality, not just in our MGM, but across Mumbai and India as well. She has also published in many publications. She has been a speaker and chair at several national and international conferences and symposia regarding digital health initiatives in public health and preventive medicine. So we are privileged to have her here with us today. So I welcome you, Dr. Ashlesha, and on to you to take it forward.
Thank you so much. Thank you, Ganesh, for that was really a at length introduction. Thank you so much, the organizer team and Dr. Prasad sir for really deciding on this topic, which is the need of the hour. Without further ado or introduction into the topic, we have had several beautiful talks and really understanding the digital health. Now, I would just simply state that there are 4 pillars of Aayushman Bharat. As we all know, that there is Aayushman Bharat Health and Wellness Center, which we call Aayushman Arogya Mandir now, and then is Aayushman Bharat Pradhan Mantri Jan Arogya Yojana, and which is Aayushman Bharat PMJAY that we know. Pradhan Mantri Aayushman Bharat Infrastructure Mission, or PM Abhin that we fondly call it. And the last but not the least is Pradhan Mantri Aayushman Bharat Digital Mission, or ABDM, is what we are going to touch upon today, because we have with us close to 150 participants, maximum of whom are public health professionals. So to tell you, healthcare is basically teamwork, and teamwork is the backbone of healthcare. We have been having a team of nurses or technicians, but of late we have added more stakeholders to our teams for healthcare per se, for the patients, and it also involves the government. India is in a unique position to really embark upon the journey of digitalization, where on 15th March 2017, National Health Policy was approved by the Union Cabinet. In February 2018, Pradhan Mantri Rashtriya Swasthya Suraksha Mission was announced, and followed by that, in June 2018, we had National Health by Niti Aayog, and July 2019, we all saw the National Digital Health Blueprint being released. In 2020, we had the National Digital Health Mission, and followed by that, the Honorable Prime Minister of India launched Aayushman Bharat Digital Mission in 6 union territories first in September 2021. Thereon, next. We had Aayushman Bharat Digital Mission in phase-wise manner, where there was rollout in union territories, followed by expansion in states and various services, and then nationwide rollout. Health is a state subject within federal structure of Indian Constitution. The states would need to be consulted in it, and the states would be critical actor in hosting and using data, and would also have the legal right to regulate it. So during Aayushman Bharat Digital Mission rollout, these points were also taken very much into consideration. To go ahead with next. The vision of Aayushman Bharat Digital Mission is to create national digital health ecosystem that supports universal health coverage in an efficient, accessible, inclusive, affordable, timely, and safe manner that provides a wide range of data information and infrastructure services, duly leveraging open, interoperable standards-based digital system, and ensuring privacy of health-related personal information. There are certain objectives, which is basically to simplify hospitalization, enhancing the ease of living of citizens, strengthening the healthcare facilities in India, leveraging upon the open interoperable standards-based digital system, ensure the security and privacy and confidentiality of health-related personal information. It also aims to promote efficient, accessible, inclusive, affordable, and timely and safe healthcare system, and establishes a state-of-art digital health system and manage the core digital health data and infrastructure. Please next. We also have digital mission. We also have to enforce the adoption of open standards, establish a system of personal health records, and it also aims for cooperative and comparative federalism, aims to ensure national portability in the provision of health services, promotes the use of clinical decision support system, that is CDS, ensuring their conformity with the defined standards and integrate with the proposed UHID ecosystem. Next. So this is the scope of Aayushman Bharat Digital Mission: health and well-being for all, universal health coverage, citizen-centric services, quality of care, accessibility of for performance, efficiency, and effectiveness in delivery of services, creation of holistic, comprehensive health ecosystem. Next, please. And here we see the ABDM ecosystem. It's a very, very well accepted and very well taken image we have seen in various presentations across the pathies and across the specializations, the ABDM ecosystem. Here I would say that if healthcare reform one or first generation was about coverage of healthcare system or about coverage of healthcare, the healthcare reform 2.0 would be the healthcare delivery. And seeing this, we already have our government looking into this through Aayushman Bharat Digital Mission. We are very, very privileged now today to have the National Health Authority team joined here with us. We have Mr. Narendra Singh. Yes. So we will have now Mr. Narendra Singh.
Good afternoon.
Sir, good afternoon, sir. Yes.
Yeah, good afternoon, everyone.
Yes. So Aayushman Bharat Digital Mission, we just had an introduction, and along with the introduction, I would like to introduce our today's speaker, Mr. Narendra Singh, and his team as well. Mr. Narendra Singh is currently the program manager for the adoption of Aayushman Bharat Digital Mission with the NHA, National Health Authority, an e-governance consulting professional with over 23 years of experience in managing a variety of programs like large record management, BPR in income tax, e-governance roadmap for states such as UP, West Bengal, and Jharkhand. He has managed implementation of large-scale national programs like Aadhaar, Deen Dayal Gramin Kushal Yojana, Pradhan Mantri Matru Vandana Yojana. He is currently working with both government and private sector partners for increasing the adoption of Aayushman Bharat Digital Mission across the healthcare sector. He is an alumni of IIT Delhi and IIM Kozhikode. Along with Sir, we also have a team from NHA, Ms. Yukti Sharma, Kenneth Fernandez, Anita Gupta, Jitendra Kumar, and Ajitesh Gupta. We welcome you, sir, and the entire team of NHA. We look forward to learning from you, sir, regarding the Aayushman Bharat Digital Mission. Over to you, sir. Thank you.
Thank you, ma'am. So before I begin, I'll just start. Let me just share my screen. So yeah, yeah, yeah. This presentation is, keeping the tradition that we, whenever there's a speaker, we come with the presentation. But so it's on that note. But before I begin talking about ABDM, let me just try to set a context of what ABDM can be or how it can be. We have all been, think currently we all know about digital finance. We have all used, most of us would have used Paytm or a Phone Pay or any other application since the time, after demonetization. I think most of us have used these applications. So these things have allowed us access whenever we go, access to our financial records in our hands. It also allows us to transfer money from one person to the other person at an instant using an UPI or a similar thing. So digital is has become a part of our life, at least in terms of the finance, and we are all comfortable. So uh, so now I just come back to health. Uh, we all know when we go to a doctor, I mean, we are all, you are all doctors, most of you here, but from a, normal patient perspective, when you go to a doctor over a period of time, if there is some disease, it takes long time, like blood pressure or cancer patients or all those things, we continue to create records. If I go to a doctor in January, the doctor will prescribe some medicines for me. They'll prescribe some test. I'll go the test done also, and I'll get a report from that. I'll keep it in a file. Over a period of time, all those records they get accumulated in a file. I get well. After that, that file is lost. Maybe 2 to 3 years again down the line, I develop similar kind of symptoms. I again go to a doctor, and uh, as a previous speaker was talking about AI and all those things, they are all dependent on the previous data that has been generated for various things. But before AI came into being, the doctors that we have, we all, I think everyone likes to see the previous reports and how the medical history of the patient would have been. But at that point, every time it is dependent upon the diligence of the patient, whether he has kept this record or not. Or when I go to a doctor, the patient, whether I take those records with me or I don't take those records with me. Sometimes, so this is the kind of so if the doctor has the access to my medical history, they came up with a decision which is better for us. And they can take the decision. But if it's not there, then it's mostly based on the information which is provided by the patient at that point of time. So that was one case. Other case, we also had certain hospitals who started going in the digital way. So if you go to many large chains, the doctors are creating the whole history of the patient on the computer system. They digitize this. They don't even give you a paper record. They say, our hospital has an app and you can see all your things on the app. If you go to Lal Path Labs or Agilus, they'll do the test and they'll send you an SMS in the evening that your record has been generated. Please download it from this location. You can download it and you can use it if you want. You don't need to come to the lab again to pick up the reports. I mean, they are saving paper that way, but again, you're dependent on that downloading the report and saving it some Google Drive somewhere. Suppose that 6 months down the line, the doctor asks you, "Oh, you had got the test done 6 months back. Please show it to me." It's not available to you. So through ABDM, what we are trying to do is, we are trying to create a digital ecosystem. I mean, digital ecosystem is already there. If it is not there, we're trying to get people to start using systems using digital. But still, if there is a digital ecosystem, it was all in a silo. See, currently, if you look at the banking system, if I want to transfer money from one bank to the other, I simply use an app and I do a NEFT, and money could be transferred from one account to the other. Money could be transferred from one person to the other. I'm not dependent on that. I have to go to that bank, take out cash, and then give some cash to someone else. Even the ATMs which I use, it's all cross banking. But the health records in a hospital currently are there. If I use, I don't, I mean, there's a big, large chain of hospitals here. They have their own app. If so you see the records only on that app. If you want to show it to a doctor, we have to show it using that 16 mobile phone that we have, or you have to take a printout, and you again go back to the same story of diligence of the person keeping that record, and the doctor seeing that record. Maximum things, the doctor will see that record on the 16 screen. And I was talking to one of the doctors some time back. Actually, he was unhappy even when he had to use a computer. He says, हमारी आंखें फट गई हैं ये कंप्यूटर देख देख के. He had to give rest to that computer, and imagine to that doctor, if you want to show him on that 16 screen, it will not be possible. So if a doctor wants to see, he wants to see it on that big screen, whatever he has in front of him on the laptop. So that's what ABDM is trying to do, is that all these records, if you have in one, let's say if you go to Apollo or a Fortis or AIM system or any other system, the records, if they are created digitally, they can be accessed anywhere in the system. But again, for this, what we are doing is, it's not that the records are available just like that. So to do that, everything has to be on systems. When these systems have to talk to each other, these are some of the terms which are used very easily in the technology conferences, but there are the doctors here. But let me just try to say it. It's a open standard suite architecture. What we mean to say is that when you see those lab reports, let me talk in that. You see those lab reports, they're written in a structured format. You have those, and everything is. So if you get a lab report from Lal Path Lab, Agilus, or any other this thing, you can see the report because everything is written in a very similar structure. So they're standards. So similar kind of standards are there for computers to talk to each other. That's what we call open standards, open API based. And it is scalable and interoperable. The thing is not dependent on scalable. As in, if I have the thing can be used same way at a primary healthcare center in a remote corner of the country with simple a small computer and an internet connection, or to the best of the hospitals, AIMS or any other private sector hospital, even in Delhi. Federated and secured. Two things which is very important for ABDM. We have been talking about in AI's earlier session, I was there, data of the patient being available to someone else. And there's a talk about ethics and, all those things. So ABDM says the data stays where it is. If I go to AIMS and a doctor prescribes some medicines for me, test reports, whatever are generated, they stay in the AIMS system. If I go to, let's say, some other hospital in Patna, Nagpur, or Kanyakumari, the doctor there wants to see my records, they will get access to those records based on consent. A digital consent will have to be provided by me for the doctor to get access to those records. So you don't pay, anyone cannot just request money from your bank account just because they know your UPI or a bank account number. If they request some money, you get a notification on an app and you enter a PIN, and then only the money goes. Or you scan that QR code and send the money. So it's actually driven by the person who has the money. And so similarly here also, the data sharing, the data access is driven by the patient. It's not even dependent on the doctor. This thing, the AIMS doctor cannot share my doctor to the doctor in Kanyakumari. They won't even come to know. Let's take it this way. Doctor in Kanyakumari wants to see my records. They will create a request. I will give an access to those requests, and the doctor, thus data will come from AIMS hospital. If the time permits, at end of my session, I'll try to share a video with you where we'll see this thing happening. So it's not actually, I'm not talking something in thin air, we can actually see records going from one system to the other. We'll show. I'll try to show that to you. So what are we trying to enable here? I think ma'am had earlier shown a slide to you. This is a different depiction of the same thing. But what we are trying to say is that there are various players in the ecosystem, health ecosystem. There are labs, there are practitioners, there are private hospitals. But suppose they want to transfer data from one to the other. Like it's a telephone call. I am on Airtel mobile. Someone may be on Idea. Someone may be on Reliance. But if you want to talk to each other, we talk to each other through an exchange, and the data go. I can call up the number, and it goes to the person on the Reliance mobile. So similar kind of thing happens here. What ABDM is trying to do is that you are not dependent on the network. If there is there does not need to be a connection between one hospital and the other on their own. If you want to integrate 5 people, there cannot be one line of data flowing from one hospital to the other. They all come to the ABDM exchange, and we provide that facility that you can talk to each other. So if there are 10 lakh hospitals in the country, they start using an ABDM enabled solution. All those 10 lakh hospitals can exchange information amongst themselves. Currently, around 60,000 hospitals are ABDM enabled, and they are, conceptually, they can exchange information from one hospital to the other, provided the patient grants it. So that's what we are, the crux of this slide is that you don't need to integrate one system to the other. So what do we actually trying to achieve here? See, the citizens or the residents, they have a better control over their medical records. I can give you an example of medical records. My wife and we are trying to, for a baby, and there were some complications. So it was a period of we went to various doctors. So one doctor had suggested a surgery. That surgery was done. After that, nothing happened. We went to another doctor. So, and we told the doctor this surgery was done. Incidentally, we didn't have the discharge report and other things related to that surgery. So the doctor told me that no, yeah, this report was very critical. I want to see that thing. Right. And if the doctor tells you something, you have to bring that thing. So we told him we didn't have it. So fortunately, both the doctors were in Delhi. So I told him, sir, we'll bring it next time for you. Okay. So he said, come whenever you get the report, come to me. So 2 days later, I took a leave from my office, went to that hospital. I asked for that report. So the doctor was on leave. So they said come sometime later, but because the archives you can access only because if the doctor allows it. Okay, so 3 days later, the doctor came. The doctor gave me a permission. I submitted in the admin records office. They told me to come after 3 days. I went back and I got the records. And then we went back to the doctor. After 15 days, he saw that report, and incidentally, what he wanted to see was not there. Anyway, that's besides the point. But see the fallacy, the whole fallacy in this. It was a record pertaining to my wife. I had to take permission from the doctor. I had to go to them and to access the record. And there's one more fallacy. See, it is a record of my wife, technically. So my wife, they never asked my wife in between, the hospital who had the record. So, it could have been anyone who just knew that this thing was done and would have taken the record. So it is the patient who should have the control over their medical records. So that is something which ABDM will provide. There's no loss of medical record because a digital record is somewhere in the system. Also, I can take a copy of the digital record in my application. It is also available it is linked somewhere and it is available. So there is no loss of the record because of the paper record, that loss of that is not happening. And so we'll also, what we are trying today, I'll come to that. We are trying to create registries of healthcare professionals and hospitals. So you will know that information, that all the information is available, and digital records save time. They save time because if you have it, if I want to see my BP blood pressure monitoring over a period of 12 months. Don't have to skim through 12 reports. Any tool can just pick up and show me a beautiful, show to the doctor graphs, and they can see, and you can also have a yellow line which shows the standard thing and all those things. So I think previous speakers have been talking about a lot of these things, so I don't have to explain it to you. Healthcare providers, they can do better clinical decision making because they'll have access to full history. Teleconsultation was in real vogue when COVID was there. So I think still teleconsultation can be much more useful, if not for normal general practitioners, but for very specialized people, because if they can't travel to all those every nook and corner of the country, specialists, but they can provide consultancy to everyone. And record management is accurate. And I said, I will be talking about the better way of, digital records can also lead to things where insurance companies have more faith. See, paper records are easy to fake, but if you're talking of digital records, which are coming directly from the systems of the hospitals, if the insurance company want to have access, provided the consent of the patient, they'll be able to provide better settlement of claims. And again, the policymakers have access to these records because all of us want data. So somewhere some data is available with the consent, the policymakers can do a better decision making. So, when we're talking of this digital ecosystem, what does it actually need? When we are talking, when we said, financial system, I come back to that. Every bank has a IFSC code which digitally identifies that bank. Every person has a bank account number. Now we also have a UPI. We also have Aadhaar. So the identities are fixed. So for this digital ecosystem to run efficiently, we have identified 3 identities for everyone. So we are creating 3 registries. One is an Aabha number. Aabha number is a number, 14-digit randomly generated number. It will be given to each and every patient. So I think someone will come back. Aadhaar, we have Aadhaar also. Then why are you creating another number? So Aadhaar is for your identity. It has its own requirement. Aabha is your health account number. Okay, so with this, every hospital has a UHID. Some hospitals call it UHID, some call it CR number. But then it's related to that specific hospital, specific system. But Aabha is one common number which will identify that patient going across any health ecosystem in the country. So that's where Aabha is there. Aabha is backwardly linked to Aadhaar. When we say whether they want to give the Aabha, our system wants to give an Aabha number to Narendra Singh, we check from your Aadhaar number and we give a number to you, to me. And so I don't get a new Aabha number. So one person, one Aabha is our concept. Healthcare professionals registry. So we are trying to identify all the kinds of various health professionals in the country. Health professionals are not as ABDM or NHA. It's not healthcare professionals specific to a single line of medicine. Healthcare professionals can be anyone, but we are trying to identify. So you can be in, as you can, modern medicine, Siddha, Unani, but we are trying to create a registry. Currently, it is for doctors and nurses. We will be opening. So because there are various advantages. So these are verified registries. They are not, suppose you go and try to register yourself as a doctor. Basis some of the identity will be based on Aadhaar. But for verifying your medical credentials, we try to take, you have to provide your degree certificate for MBBS if you've done MD, and then it goes to council and their councils approve it, and then only you get a verified. So this registry is not like a Google account that anyone can create for anyone. So this registry is for will be a verified doctor. And the beautiful thing about is that tomorrow, if you in our country, there are a lot of doctors which are no, I'm not saying doctors. There are a lot of people who are operating as doctors, and they put the name, and at least through this health professional registry, this will give access to people to verify that they're actually doctors or not. So this is one thing. I think these are the kind of people who bring bad name to the fraternity. I think that is where you would see that there is a value for you. Health facility registry, as I said, uniquely identify the facility. So when we are talking of ABDM, the health facility registry, something will be unique because that will know the record which was created in that facility. We don't track which doctor created a record. We're not tracking a system, but some we should know where the facilities are there, where the hospitals are there, blood banks, even your pharmacies. These are some things which we don't have access most of the time. Uh, uh, we come out of we know the pharmacy is nearby our places, but if we go to some other place, we don't know where the pharmacy is. Either we'll just look at the pharmacy which is just outside the doctor's place, or we uh, uh, that's it. That's the way we know. So if you go to a new place, we don't have access to it. We don't even know. And at the time of COVID, we had to everyone had to do some tests somewhere there. That information was not available because the facility which was very near to your place was closed down. So health facility registry will provide you access to that information. And the last thing is health information exchange and consent manager. I was talking to you about, ABDM is an exchange. It allows information to flow from one place, one system to the other, from AIMS in Delhi to a hospital in Kanyakumari or a hospital in Ladakh. But all that information flow. So there has to be an exchange, and in exchange means there has to be a directory. So that's what we do. Suppose whenever I go to a hospital, a record is created, a digital record is created, so an entry is made. For Narendra Singh went to AIMS on 25th of April, and a record is created for him somewhere. And I had gone to some hospital in Patna on 14th of February, and that record exists there. So if I go to Bhopal or Kanyakumari, the doctor says, can you provide me information wherever you've gone in last 6 months? So it is not that information is asked for from 10 lakh hospitals or systems, clinics in the country. The information is just goes to HICM, checked, okay, Narendra Singh, 2 hospitals, message goes to my phone that you've gone to these 2 hospitals, and the doctor in Kanyakumari wants to see. So then I decide, okay, when I went to this place, it was I had some minor headache, but I didn't want, because I was traveling, I didn't want to show, and the doctor said there is nothing. So I said, okay, no, that's not necessary, but my AIMS visit is important. So let me just share only those records. So doctor in Kanyakumari sees my AIMS daily records, and they can do. And now to do all this, we have got a concept of Abha app. We all know Bheem, we all know Paytm, we all know PhonePe. These are apps which are being used to access my banking balance, or if I want to pay to someone. But here I'm talking about you can share your record from one system to the other. But how do I do it? Will I get a SMS on my phone? Then I will approve it. How does that happen? So for that, we are talking about personal health record applications. So these are applications where you can, as I have personal finance application, PhonePe, similar kind of these applications will be there. I can create my Aadhaar number for using this application. I can, if I go to a hospital and the record is created, I can, pull that record from that place and onto this application. So I know all my history. We have, as NHA, we have created an Ava app which does the basic functionality that it can pull a record from one place, from one hospital where I have gone, or it can do some 2, 3 other things also, which I'll show later. Where use cases that we have come up with using this ABDM, but this are main. But there are other apps in the market which are also to do this. They are also integrated with the ABDM system, and they are also providing that if you pull your record for lab reports, which talks of sugar report for last 6 months or last 12 months, it can give you a trending analysis on that, or if you want to use it. Most of the times, when we have been talking of AI chatbot and other things, but I would, and these apps give you some indication, but anyway, I prefer going to a doctor anyway. But the doctor can give you the best advice, whatever it is. And to do this, we need ABDM enabled digital infrastructure. Not talking. So here, when we talk of HMI, health management information system, other doctors who are learning this single, 2 doctor, 3 doctor clinics, they cannot invest in a big infrastructure, but they will have a small application running on their in their system. So that has to be ABDM enabled. That has to be connected to internet. But and that is what we are talking about, ABDM enabled digital infrastructure. So these are the core building blocks of which ABDM flows. And I think this, yeah, this looks slightly complicated and very dense, but the thing was that I was talking about, if you look at the top, top block, Aayushman Bharat health account, which is identifying a person, health facility registry, which is identifying the facility, health professional registry is for the doctors. And if you see on the left, you see public health program, doctors, hospital, diagnostic centers, and health locker. If you see on the right, again, you see the same people, same actors. So it is like when we say health information providers, if I go today to a doctor, they create a record for me. And if I 2 days later, when I go to another doctor, then they want to see my old record. So someone is providing that information. That's what we call health information providers. And the other side, if you the doctor who is using that information, they will be health information users at that point of time. So you can be a user or a provider depending on the context. So that's why all I mean the left and the right they are the same people, but they are on the context. So as I said, Kanyakumari Hospital can be this is an HIU for me, but if the patient from Kanyakumari travels to Delhi, the doctor in AIMS wants to see the record, they will be HIU, the roles will reverse. But similar kind of, you have information with you, you are an information provider, you are accessing that information, and the whole thing happens through the information exchange and the consent. Consent is something which is very important. The data does not flow from one system to the other without the patient giving that consent. And the patient coming to know that this information is coming, someone has asked for it. When you do your Aadhaar biometric or some other thing, you normally get an SMS that, your Aadhaar has been used somewhere. So that's how in this also we are doing this. So, and some of you may have heard about DPDP Act, Digital Data Protection Act and all those things. So even before that act came into being, all these things are in play, and a lot of people who have seen, after that act, they're trying to see that, and they say that it is all complying to that. So it is, how is it useful to, patients also? When I think longitudinal health record, medical history is something I don't need to explain to the doctors here. You are all familiar that medical history is something which is very important and to come to any decision, but it is not something which a patient keeps. The record in a proper manner is something which a patient never keeps. I go to, I had a, concept, I had a surgery long time back. After discharge, I put it somewhere. I shifted, when we shifted my house from one city to the other. First thing which you throw out is the discharge. What is the use of the discharge summary? I already got surgery. Everything is done. What's the use? I threw that record. And there was some other thing, I kept it. So later on, I was going for a term insurance that the thing which they asked, have you had surgery in last 5 years? I said, yes. So they said, where is the discharge summary? I said, I don't have it. So, it is not, and similar kind of thing, I think the doctors, you would also like to know, anyway, for any thing which we go, when my wife was pregnant, then they wanted to know, you had whatever you had in last 2-3 years, what are the kind of medicines that you took, or whenever you have back pain, they would like to ask you whether you had a back pain in the past or not, or anything. So this is when you talk of Rani Devi, she's pregnant and she goes to RCH. They would like to know whether she had any other disease. So many people who are below the line, or they get access to health services from government system, they definitely don't have those records, but a digital record would help them because they are available in government programs somewhere now. So they would go for various programs. Nikshay would give them a TB, this thing, malaria would be IDSP, RCH, but all these things will be available to a doctor treating them, even if they had gone to a public health system, because if they are available, they are linked to ABHA. And I mean, as a patient, I have access, I can go to government system or a private system. That is not something which we should stop. So that's where I think medical history would help, and this is available. This is available on the phone. This is shareable to the doctor at any point of time. So where are we in the context now? Whether it is only to the government systems, or so we have government health programs which are linked with ABDM. I think 2 to 3 years back when COVID was rampant, and so we all know about COVID. We are sharing those certificate everywhere we went. Reproductive and child health is a system which is there. It has around 2 crore beneficiaries. When they go, all the mothers, they are given their the everything which is done for the doctors. It's in the government system. It's recorded there. Then we have non-communicable disease program in the country where they scan everywhere. Everyone who is more than 30 years of age, they have so these are the programs which are there on the government health programs. Then we have government health solutions. But I think the critical thing is what is in the third rightmost thing. We have private healthcare players who are actually integrated with ABDM. We have Agilus, which is the previously SRL, which is integrated. So if you go to a SRL lab, you can get an ABHA created, you can get your records linked, and you can see on a PHR app. You don't need to depend on the SMS, which the SRL labs will send you an email and it download it. Even the Lal Path labs, which are these are the two big chains which are all integrated. So there are solutions which are working with independent, labs. There, cloud pathology, which is an Indra IVF lab. They're all across the country. They are linked. Then Eka Care is I was talking about, personal health record app, which we said ABHA. Eka Care is also a similar kind of app. You can search for it when you go home. Briefcase is another app. Even on Paytm, there is a health section. If you go there, you can create your ABHA and you can get your COVID certificate at the minimum. And if you go to any ABDM enabled lab in future, or any of your patients come to go to that, they can get that records on Paytm also. So so that's the kind of thing I'm talking about. And I think when we say why is it necessary, it will be useful. We will be there's a thing called discovery. If you are on HPR once, say all of us know about Google. We go register ourselves on Google accounts. Google searches. You say hospitals nearby in Google search, you get a list of hospitals. So, but if you, but it is again dependent on Google. Suppose you want to say a call center number and you get some numbers, and people are putting websites, fake websites for call centers for banks, and they get so. But HPR, HFR, when we say discoverability, it is a verified claim. So it is not like a search for a doctor's near me. Google will give you a response, or an HPR will give you a response. HPR will be much more verified. And soon, I think Google and all those things, they will also be using the registry which is given by ABDM. Longitudinal health record, as I said, it will be available to you. Patient satisfaction, you can do teleconsultation. We have got a thing called UHI. It has been launched in a pilot mode, but you can provide your consultation through a UHI. Let me just talk about, I think there's a slide after that. And you can do follow-up and referrals, because it's easier for, once you have a digital record, it's easier for you to track. You can build a inbuilt, reminders that can be gone to them. And since there are paperless records, you can view everything in a simple way. As I said, trend of my whatever sugar level and everything, I can get, and I don't need to go through 12 reports to see my 12-month thing. Healthcare facilities, ease of queuing and OPD process. I don't know. We have been talking about something called scan and share. If you go to AIMS Delhi or any other AIMS in the country, you would see there is a patient registration counter, but that is not, it's free of, long queues nowadays. Or you go to any other place in Delhi also, across the country around 450, there is no queue. Because we have started a queue management system through a scan and share. As you go to a doctor, to that hospital, you scan the QR code of the facility, and you can share the, your information. When you go to an OPD registration counter, what you do? You tell them your name, your age, your DOB, some address, and then you tell whatever your problem is, and the person will tell you, go to this orthopedic, go to this oncologist, go to general physician, go to, but this whole interaction sometimes used to take 10 to 15 minutes. And if you are a 6th person in the queue, you'll be standing in the queue for 1 hour. So we have started a process of scan and share. So once you scan the QR code, you get a token number. But these kind of things were, if some of the hospitals also had a queue management system, but it was depending on the management of that hospital. So if they want a queue management system, they start it, but if they don't have it, they don't invest in it. So ABDM has provided a free of cost queue management system to all these hospitals where they're using it. They can use even a appointment system, efficient discharge process. I'll be talking about health claims exchange. So I mean, some of us have your doctors here and maybe running your hospitals also. So I think you would have given instruction to when you're taking your morning rounds in a hospital. You'll tell the patient, okay, now at 8 o'clock or 9 o'clock, you tell them, yeah, you're perfectly fine. You can go home after your surgery or whatever. You come back, but that patient is, if it is he's a very lucky person, I think they would leave around 2 o'clock. If a normal course, if a doctor tells me at 10 o'clock in the morning that you're free to go, till the time that claim settlement happens, it will be 4 o'clock or 5 o'clock. So till that time, if you get a new patient, you can't give them that bed, and you're unnecessarily, maybe you had to build that extra charge for in the bill, or because you can't charge that patient for that day. So all those things happen. So uh, through an digital claims process, the discharge process will be faster. We have been talking to all the insurance companies, and 30 companies have been actually on board. IRDA is also working on that. And you can track your patient healthcare indicators also in a digital world. That's I was talking about 3 use things called National Health Claims Exchange. Today, as we talk, we have around 30 insurance companies who have come on board with the National Health Claims Exchange. They have, in a POC mode, they have tested one of their at least one of their best products, which will be used by various patients, largest selling products. So if they go to a ABDM enabled, HCX enabled hospital, uh, the pre-authorization and even the claim settlement happens in an electronic way. Still, currently also, they think that it happens in electronic way because they are sending something in an email or a fax, or you have a system where there's a claims platform or the insurance company. But all these things are dependent on various insurance companies, because if there are 30 insurance companies, I can tell you there will be at least 20 ways of asking the same record by these insurance companies. Someone will ask for a fax, and they don't have a standard things. They'll they were standard, they'll ask for certain information once, then the person who's sitting behind, they'll again ask for certain thing, then they'll again. So all those are not standardized. So National Claims Exchange will standardize the information which is sought for by these insurance companies. So once the your you have taken care of the patient, all the reports, whichever is required, they go in an electronic way immediately once the claim is requested. So the whole administrative cost and waiting time for claim settlement will be reduced, because the insurance companies will have much because this information is coming from directly from the systems of the hospitals. It is much more reliable. It is not something which is, they don't have to come back and verify. Sometimes I know again, my personal experience, I had to sit in a hospital for 1 hour because that insurance company had a policy that they wanted to actually verify that the patient had come to the hospital or not. So someone just came and saw me sitting on the bed. So that's one thing. So I think National Health Claims Exchange, it will become something big, and it will help everyone, the hospital administration also, because the beds will be freed faster. You can give it to some other patient who is already sitting there. Unified health interface. This is something which we have been talking about. Again, I come back to the financial. If you want transaction example, if I want to give money for anyone who is on Google Pay, Home Pay, I don't need to have a Home Pay or Google Pay or Phone Pay. I pay that person money using only a Paytm, so UPI address. But a doctor who wants to give a teleconsultation service right now, they have to register themselves on a Practo, they have to register themselves on 1mg, or there's some other platform, M5, MediBuddy. But if I look at a patient, if someone develops, pain in the chest at 9 o'clock in the evening, and there is no doctor available, if I'm searching on an app for a doctors available, so I'll just go from one Practo. If no one is available, I go another app. I'll go to another app. I'll do fifth app. Maybe I'll if I'm lucky, I'll get it on the fifth app, or if I started from that fifth app first, I'll get it on the first time. So it all depends on the luck factor there. But from UHI, what we're trying to do is, if a doctor can be available on any of these platforms, they may not be available on any of these platforms. They are just available, the hospital has registered themselves on the UHI. They're not on Practo or anything. But anyone can search for a doctor using in the Practo app. I get all the doctors who are available in various systems. And if I want to do a consultation, so technically these things are integrated. The doctor can come on teleconsultation, video consultation, who is registered on any app. I can book for a lab test. I don't have to search for a lab on 1mg or any other app. I can book from any other these things available. I can even book on the government systems which are available. So that is where we are talking of UHI, single platform for all digital health service providers. So that's where, health facility registry and NHPR will help the doctors. Third thing, as I talked about, scan and share. I just scan the QR code of the facility. I can just provide the information available for myself. But we are even thinking that tomorrow, if I go to the doctor in Kanyakumari and I have that phone documents on my phone, he doesn't go through the whole process of asking for a request and the report from AIMS Delhi coming. I can scan his QR code and I say all these records you want to see, please see this. Or if I go to a pharmacy, I scan the QR code and the prescription directly goes into the system. From that system, the pharmacist will just check. The pharmacy store software will provide him that information. Okay, these things are available at this counter. Please bring in, and the invoice will be generated, and I can, in a digital format, everything happens. It's not that the person looks at my prescription, then he tries to decipher what is written there. Then because when we write, I think the handwriting is sometimes not legible for many people. So that is also not required now. Yeah. So we have reached these are the numbers. We just want to show it to everyone. These are the numbers that we are talking about right now. We are around 59 crore people, and you can just have a look at these. I don't want to repeat them. And when we started in 22, we had around 1 crore records. Now we had more than 30 crore records have been linked. And as I said, standardization, we are trying to bring standardization across in a health data, health exchange, and UHI. So that is the thing that we are trying to bring about here through ABDM. And I think I promised you a video. So let me just run through this video. I think I've been told that this time is less, but I'll just take you through this video. I'll just take you through the part where the information exchange is happening. So this person has gone to a doctor in AIMS. The registration is happening here. So let me just take you to that screen. Yeah. See, this is where the doctor is seeking a consent. Okay. The doctor is seeking a consent that I want to request all your information which is available somewhere in the medical world. So for care management, they are asking for these records. So this is the system of the doctor, digital system of the doctor. Now, if you there's a request which has been generated, and it asks for records from certain time. And this is the PHR app which I was talking about. So this is person Nilesh Ashok. On this phone, he sees, if you see the KYC is compliant, he has an ABA number, has an ABA address, and there is a health record for him. So here the doctor is asked that Harsha wants to access your records, and the purpose is care management. He has asked for the record on 14 March at this time. So he has asked for these kind of reports, and he has the consent has to be given. So there's a diagnostic report, discharge summary. He gives a consent. He gives a PIN. We all are familiar with the concept of PIN. And on my phone, this person has given the consent. So now, if you see, this is again the doctor's desk. This is the doctor. He is seeing all these consents. Nilesh Ashok Nigam. He clicks on that patient thing, and he'll just patient details, his consent, whatever he had asked for. So if you see, this person had actually gone to AIMS Rajkot. I skipped that part, and he is getting the records which are coming to him from AIMS Mangalagiri. So AIMS Mangalagiri prescription is available to him. He had gone at some other point of time, and this is what you can see. So as I was saying, it's not just simple, where it's not a high-tech thing that we're just talking about. The actual records are visible to each other, and I can tell you from the way that we have done it that it's takes more time for me to explain to you how it has happened than the way it actually happens. So end of this thing, the doctor is now writing the prescription for this patient in uh, the AIMS doctor is also writing a prescription on his system. So you'll see that this record will be saved. This is OPD prescription. And this is again available on the PHR app of the patient there. See, he had gone to AIMS Rajkot, and this is again available on the phone. The doctor had saved it on his or her desk, and it is available to the patient on the phone immediately, with a small time lag. So I think I'll just stop here.
That was really amazing. And it is the reality. And we all need to, it is high time that healthcare industry takes up digitalization now, which has been a long time pending. It is slow and steady that the healthcare industry is becoming digitalized, not an overnight journey, although it is like how seasons change from autumn to, let's say, spring. We are also going forward with digitalization in healthcare, and especially healthcare delivery from public as well as private sector. I thank you, sir, for being here, and especially talking about National Health Claim Exchange, which is extremely important in today's day. Unique health interface and scan and share. These are the three, the most important things today. Each one of us, especially the public health professionals, need to know and need to adopt as early as possible. I thank again the National Health Authority and Mr. Narendra Singh for being a part of this specially focused program on digital health and digital tools for healthcare professionals in public health, especially. So thank you so much, and over to you, Ganesh.
Thank you so much, Dr. Ashlesha and Mr. Narendra Singh and his own team for throwing light on Aayushman Bharat digital mission in detail and telling us about how it connects database for patients across government and private hospitals. Eventually, we will be turning into something like an NHS, National Health Services for UK. So having a common database for all patients at one place. As Dr. Ashlesha rightly said, it's slow and steady for us because of a huge population. But I think eventually we will do it for sure. So moving on to the next event for this program, that is panel discussion. So the panel discussion today will be on the topic of the webinar, that is artificial intelligence and digital tools for public health professionals, my health, my right. So for this panel discussion, we have a list of eminent speakers with us, with our moderator, Dr. Alok Modi sir, who has already given a very wonderful talk on the use of Chat GPT, hands-on experience along with other AI tools. Along with, since him being the moderator, our panelists will be Dr. Sanjay Agarwal sir. Dr. Sanjay Agarwal sir is an MD in internal medicine. He's also a diabetologist practicing in Pune and has an experience of more than 38 years in this field. He's a member of the RSSDI, the IMA, AACE, ISCCM, and CSI, and many more. Because of paucity of place, we have limited to this description. We would be a part of our panel. Welcome you, sir, to this panel.
Thank you. Thank you for the invitation.
Thanks, sir. Our next panelist would be Professor Dr. Ketan Mehta, sir. He has an MD degree in mental medicine along with many multiple fellowships. He's associated with multiple hospitals, Suchak Hospital, Asian Heart Institute, Ritigare Asia Hospital in Mumbai. He is also the president of IMA Mumbai West, and he's currently and also holding many other posts of general secretary, vice president, chairman of many prominent public health bodies, and he's also a postgraduate teacher for FCPS and ex-teaching faculty at KJ Samaya Medical College. He has been a principal investigator for various clinical trials such as TIPS 3, HOPE 3, TIPS Mars, and TIPS K. So he has a huge body of experience that he has joined us in this panel. Thank you, sir, for joining on this panel. Next, we also have Dr. Harshad Thakur, sir, who is working as a professor with the School of Health System Study, Tata Institute of Social Sciences, Mumbai. He was a director at the National Institute of Health and Family Welfare, New Delhi, for 2 years. And he started an MPH program in social epidemiology at TIS. So he has also expertise in guiding research projects for the projects of PhD, MPhil, MPH, MHA, and DHA, and many more accolades to his name. Thank you, sir. Thank you for joining us in this panel. We also have Dr. Anuj Maheshwari, sir, who will be joining us in a short period of time. He's an MD along with multiple fellowship to his name. He has been a past vice president of RSSDI, along with a member of American College of Physicians. He is a professor in the Department of Medicine in the Institute of Medical Sciences, Ataria, Lucknow. He also has been a MD, PhD, and DNB teacher and guide for the last 14 years. He has been a recipient of multiple awards, especially an Outstanding Community Service Award by Indian Academy of Diabetes at Mumbai. So we welcome sir also to this panel discussion. I would now, along with them, we also have our HOD, Head of Department of Community Medicine, MGM Medical College, Dr. Prasad Vengankar sir, whom I have already introduced in the beginning, and he has been with us throughout this webinar. So he would also be a part of this panel. And I hereupon give this panel discussion. I forward this talk to Dr. Alok Modi sir to take forward from here. Thank you, sir.
Thank you, sir. Thank you for the wonderful opportunity. Once again, I would like to thank the organizers for this wonderful opportunity. And the task that has been given to me is a really difficult task because moderating so many wonderful stalwarts becomes a very difficult thing. I'm sitting with some of the top names in the industry and in the healthcare system, and I find it a little embarrassing for me to do the moderating, but I'll try to do my best. So I was thinking how we would go about it is we have 20 to 15 minutes. Let the respected and panelists give a small presentation on the that they would like to talk about. And then we could probably have the panel interacting with them and asking them and trying to clarify things. And then I would prefer to take the questions from the audience first before the panelists would like to interact with the speaker for that time. So that I think would make a lot of sense, and we would clarify a lot of things down the road. So to start with, it's an honor and a pleasure. You've already introduced who doesn't need an introduction. He's a big luminary and a very well-known personality who's done human service in diabetes and internal medicine. So pleasure to invite you to the virtual dais. So, sir, if you would like to talk for a few minutes or with or without a presentation, may I ask you to take this opportunity and share with us your ideas on preventive aspects of AI as per your point of view, and then maybe we can take a few discussions over there. So over to you, sir. Am I audible?
To whom is this question directed, Alok?
Hello, sir, am I audible?
Yeah, to whom is this question? You broke off.
I just welcomed you. I just welcomed you to the dais, sir. I said it's an honor to have you on the dais. And I was suggesting that what I thought we would go about is that we would give all of you, the panelists, around 10 to 15 minutes to present and talk about the subtopic of the agenda that you're comfortable with. And then probably we'll have a small interaction after each small speaker in this panel discussion, primarily first from the audience and then from the panelists. So as to we can clarify the agenda of AI that we are here for today. So the first thing is I was coming to you, sir, and I said, it's an honor and a pleasure to introduce you who doesn't need an introduction. You've done human service in the field of diabetes and internal medicine. So for the next 10 minutes, the dais is yours. And would you like to tell us something about what you think is important and relevant from your point of view?
Yeah, so I think, we're
aspects and a topic of your choice, and whether you'd like to do it with a presentation.
No, I have no presentation, but I can certainly sort of speak for a few minutes, something that we have been doing through the RSSDI. So I think a couple of things that are very important from our point of view is we are looking at now from a futuristic vision as to where we should lead the body for the next 5 years or 10 years. What we really have a paucity about is data. And we need to see that what are the best ways that we can collect data. It's very difficult in a country like India with diverse populations and very poor record keeping that we are able to generate data which will be of high quality and meaningful to see that it can generate policy decisions, or for that matter our guidances for making guidelines, or for that matter most important thing is we yet don't know what should our normal cutoff points be and where should we really transition a patient from normalcy to abnormalcy. So that is something which is very key to understand, because whatever cutoff point that we adopt or our target goals that we adopt are borrowed from the Caucasian population, from the Western population. We have never tested this to understand that do these apply to our own populations. So I think one of the most important things that we really need to do is probably come together through various platforms and have a kind of a data pool that we can create and say that, okay, we have a baseline data that are sort of ethnic specific to our population. And can we plug in data through various sources like the wearable devices, laboratories, EMR systems, and wherever we can collect data from, and we can sort of have people pooling in data out here. The main thing that we have been sort of following up with our own organization is how do we get people to contribute data? Because we have something what we call as a data hugging disease. We hug the data and we don't want to share the data. And that's a very important problem that we face, because we will not do anything with the data, but neither are we willing to collaborate with that data to make it more meaningful. Second thing is, it is sort of lying in formats that we are probably not able to collect together to sort of plug that into a larger database format which can interrogate each other. So, I mean, we now are trying to see that can we have systems, and we had in between sort of looked at a database or sort of a data tool from the Harvard system, which was called as I2B2, where the entire Harvard system research works on that. And we say, okay, can we interrogate different EMR systems to find specific data sets, and then ask those people that, okay, would you like to collaborate with us and see that we can come out with more meaningful data in a specific data set of population. And if we're able to make more meaningful sort of collaborations out of this, then perhaps we may be able to sort of come out with more meaningful research. One thing that we have done in the body is that we have looked at what is the published research that we've got in the Indian population, because that's where we started out from. Because if we are able to collate together the data that is available for us, then we probably can understand the gaps in the data that we need to look at and perhaps encourage, more data collection in that specific direction. So we created a repository of data which is freely available on our website, and it's open source for now. And we sort of said, okay, let's look at the published articles, and we got an AI-based system, and we collected almost about 20 lakh plus articles, which we collected and put it in the repository, and we put a search engine to it, so and filters along with that, so that if you are searching for a specific data related to diabetes, then you can perhaps look at this repository and take out, what is available. Now, I'm not saying that is 100% totally there. I'm sure there must be a lot of articles that we have missed out on, but we have kept a possibility that, let people submit the articles if they don't feature there, and we can sort of have, people over a period of time collect articles that are unpublished or published and not featuring out there and update the repository. Second thing that we have done is, now earlier we used to sort of have a lot of funding from our side for research purposes. Now, we are not like a large body to have unlimited funding, and we have very specific amount of funding that we can give. Now, a lot of research got submitted to it, which from the body's perspective was not in the domain of how we can change lives of people with diabetes, which is the intent of the body. So we said, let us pick out, let's say, 8 or 10 research questions in specific areas, whether it may be therapeutics, it may be basic research, it may be glucose monitoring, technology, so many sort of categories, which will have impact in the lives of people with diabetes. And we fund research when something comes along that way, where 8 to 10 questions that we have posed or subtopics that we have posed, where people can submit research to us. And this will help us in particular format to develop research data. Third thing that we have done is we have been running countrywide surveys, which have been hugely successful to get us a lot of cross-sectional data. Now, mind you that this is not longitudinal data. Our first experience was when we ran the Defeat Diabetes program, where we said, how many people are aware of the fact that people are not supposed to test their blood glucose, given the fact that almost about 57% of our population are not aware that they have diabetes or not. And we need to see that they get more and more people to test their blood glucose. And very often they get incidentally detected. So we said that, okay, let's run a campaign across the country where we can make people aware that they need to test their blood glucose. And we said in 100 days, can we touch 100 million people? And to a surprise, we touched almost 128 million people through various medias to make people aware. And this was a monitored activity. And then we got 1 million people to test their blood glucose on a single day, and which was monitored by the Asia Book of Records, and it features out there. But what important was this 1 million people, we could actually collect some basic data sets out of them, which helped us to generate certain basic level of data on what was the age patterns, what was the gender patterns, what was the kind of comorbidities people had, what was the BMI, or what was the kind of blood sugar that they had. Now, I must admit the fact that good quality data was limited in this because this was entirely a patient-driven and doctor-driven activity, and we did have a lot of unstructured data that came in. But learning from this, we had multiple other surveys like Save the Feet campaign, Obesity Matters, Pre-Diabetes survey, and currently we are running a survey on patient attitudes and knowledge and awareness. Now, all these, we have been now collecting high quality data, and from our diabetes, obesity, as well as pre-diabetes surveys, we have been generated enough data. We got almost 80,000 patient data that we could collect. We have submitted almost 7 abstracts to the ADA, of which 3 got accepted. And we are now publishing 9 articles out of that data in international journals. So we have been sort of collecting huge amount of data, and I'm sure this will help us to build up the data platform, which we are really aiming for. We're also trying to get other sort of societies. For example, we collaborated with the National Cancer Grid, and we're looking at can we partner with the National Cancer Grid to come out with the cross-sectional data on diabetes and cancer and look at longitudinal research in these areas to see what we can make a difference in the lives of people. So our next intent is, of course, we're sort of working closely with the IIT Mumbai and various other IITs as well as triple IT, ICERs and Indian Institute of Sciences to collaborate. And Prasad Bangikar, I can see, is over here. We've had a sort of his presence at the research retreat this year. And he presented some wonderful data. He belongs to the IIT and we were very privileged to have him with us. But these areas, so we feel that research happens only in the realm of the healthcare community, but outside the healthcare community, there is a huge amount of research that's happening with the scientists, with various other institutes, and there are good labs that are structured labs that are coming out with multiple sort of research papers. We've had one that was presented on thermostability of insulin that came from an IT. And we're also sort of partnering with various tech companies to see whether we can come out of innovations that will help us to take us ahead. So I think I'm going to stop here and just make my point that we all need to work together in one ecosystem. We need to see that how best we can generate data. And data is going to be the future for us in terms of leading us ahead in terms of research, patient care, or for that matter, identifying that how can we make impactful journeys ahead to reduce the burden of complications as well as the non-communicable disease incidences if we identify the root problems that are associated with it and we put together preventive measures early enough and have a national program that will help our population for the future. Thank you very much for this opportunity to allow me to speak.
Thank you, sir. That was very relevant, and actually that was the most pain point because we have a huge patient database. We have a very good a very good team of clinicians across the country who are very well known on the planet as the top-notch clinicians. But then, like you very rightly said, there is a lot of siloing of data. Data is very much restricted to each clinician, and they are not willing to share it. And I think the reason is we do not have the infrastructure. Neither we have the AI tools nor we have the EHRs which can talk to each other and actually pile up the data. Otherwise, it would actually boomerang, and probably I mean I might be talking through my head, but then if that happens probably US FDA will start looking at Indian data rather than US data. That is the amount of benefit we can pass on to society. But then I'm sure AI will help over there. What would be your any comments you would like to add to this, Ketan? Let's have a discussion on that. Ketan, Dr. Harshad, Amit is here. I see
Yeah.
Amit is here. Dr. Prasad, any comments from your side? How we can help this and how we can take it forward?
Yeah, hi, good afternoon, everybody. At the onset, would like to thank my dear friend Dr. Alok Modi for inviting me over here, and a special thanks to NGMIHS for arranging this fabulous program about the AI. And what Dr. Sanjay Agarwal said is absolutely right. And probably we are definitely going to see more and more involvement of AI in each spectrum of medicine, be it in diabetes or any other specialty. So I would fully agree. And as we have said, now we are going to see the we as a clinician can use more and more use of AI, which will be not only from the perspective of the patient management, but in terms of managing our academics, managing the patient's data, taking out the statistics out of it, and for the publications point of view. So there is a vast scope of implementing AI in clinical practice as well as in the academics, which is there. And subsequently, even I would like to, give a little brief overview of how AI has changed the perspective in managing in cardiology practice. So, with your permission, whenever you will say, then I can give a small presentation on that also. Thanks.
Yeah, Ketan, I'll just come to you for that a little later. Let's just have a small discussion on what Dr. Agarwal sir has said. So, what are your views, Dr. Harshad? Would you like to give some views from your side on any comments on what Dr. Sanjay Agarwal?
Good afternoon, everyone. And I thanks organizers for inviting me. From my side, I will say that artificial intelligence or AI, we should treat this AI as a means and not an end in itself. Means only having AI is not going to solve the problem. We have to see that AI is used to take proper decisions. AI is used to monitor whether we are able to reach our goals, whether we are doing it cost effectively, whether it is giving benefits to the patients, whether it is giving benefits to hospitals or clinicians. So that should be our aim. And we have to see that AI is not misguiding us also. That is also important. So this data is dangerous. So we have to be very skeptical. We have to see that data is reliable, valid, and then only we should proceed with it. I think that's it from my side as of now. Thank you.
Thank you, Dr. Harshad. Prasad, I'll just come to you, Amit. Prasad, you have been working in very heavily on the preventive aspects and you have done phenomenal work. And for the benefit of the audience, I just wanted to share one secret. Prasad and I go as we have joined MBBS and St. James Medical College together. So we have been T partners and dissection partners and all that. So thanks, Prasad, for this wonderful thing that you have done today. It's the need of the hour. And Prasad, any thoughts about you, how you can help get the dream of Dr. Agarwal? And that's a very relevant requirement today for the growth of India. What would you say from your angle, from your specialty angle?
There is a lot of data handling in the medical field, but the quality of the data and then the completeness of the data and then again the organization and compilation of data, these are the big issues which still remain. Again, there are handful of doctors like you, they like to play with the data, but then rest feels that this is not our job. This is to be handled by some clerks or somebody and all. So we need to first educate the doctors that data is very important. And if you need to gain some information, that data you have to convert it into information, and that information then further gets converted into intelligence, and that intelligence will ultimately result into the actionable points. So we need to proceed in that direction, and then AI can be of a big help, especially considering the creating the subsets of the trained data using the AIs, or having the unorganized data converted into the organized data and those kind of things. Some of the questions which I answered since morning in the post-lunch session, there has been the apprehension about that people felt that if we give the data to the chat GPT and expect some answer, not only the chat GPT, any other artificial intelligence app, how much reliable it would be. That is one thing that they were thinking. And second thing is that what about the various artificial intelligence apps that are giving advices and all that? I mean, sometimes if they give the wrong advices, is there any regulating authority for controlling these apps? As far as my knowledge, I think there is no such regulating authority. And again, there are quite a few ethical issues are also involved into it. Some of the concerns which Dr. Harshad Thakur has expressed, I think these are the things which need to be looked into from the public health point of view.
That's very valid. Very right, and that's why US FDA has been validating. There was a wonderful article by WHO on that, and I think the right person who can handle it very beautifully, labs and through doctors, yeah, and the person who's actually the brain behind it and who can really give a little light on it in a very scientific manner. And coming to is Dr. Amit. So coming to you, Amit, my dear friend, and Amit is a person I refer to as a living, live intelligence amongst us. His knowledge is so profound and so deep. And not only that, he's contributed immensely to medical science in the last few years from India. And I will talk later. So Amit, coming to you, what are your suggestions for the dream that Dr. Agarwal has very rightly said. And the second, a very important point that Prasad has raised about the validation aspect of a AI tool. So a quick, because we need to invite other speakers
Okay,
also, a
so
quick
I will
2-minute
kind
capsule,
of
and I'm sure you can do that.
try to kind of split my comments into two aspects. One is, of course, about the data. Now, from the data point of view, no matter how much of artificial intelligence tools we are trying to build, it will all survive on data. And if the data is not sufficient, then the AI tools will not be able to thrive. Let me just give our viewers here a quick difference between us and the West. In the West, we will find that there is a lot of structured data. However, their data is not very clean. But the advantage that they face at the moment is that majority of their electronic medical record systems are based on Epic, which is a large structured EMR, and that is now integrated with Microsoft, who is kind of trying to integrate artificial intelligence, generative AI into Epic. So they still have got a good section of data interoperability. In our country, our biggest limitation and challenge that we are facing at the moment is data literacy. We've done a survey and we have found that only 5 to 7% of doctors are actually using electronic health records. Majority of the people are still on pen and paper, and the reason is an inertia. The inertia or the fear of losing data, the inertia to adapt, the inertia to adopt. So that is, from Doctors AI, we are taking initiatives where we can at least spread data literacy and AI literacy amongst our peer groups, because that is the first key, the first building block that will actually help us build these AI tools based on our database, rather than, build something which is based out of a Cleveland Clinic or a Mayo Clinic data repository. At the moment, you will find most of the AI tools which are being provided in the market, they're usually built by Indian techies who are working for US companies, and they're working on the Caucasian US data sets. So that block is still there, and I think we need to sort of make ourselves more literate into adding to this data pool, so that we can have the tools or the models and the algorithms built on our data set, on our geological, I mean, based on our geographical distribution and the varied factors taken into consideration.
That's
The
exactly,
second
Amit,
part I
what,
wanted to, yeah, I'll just come on to the
that's
second
exactly
part,
what,
which
yeah. I'll just make a comment here. That's exactly what Dr. Sanjay Gawal sir was saying, that there is a lot of data, there's a lot of siloing of data, and that data is what we need to adopt to get our research moving rather than depend on Caucasian data, which you very rightly agreed. So that's where the effort should be, and that's where his vision is. Yeah, coming to your second part, I'm sorry to interrupt.
and also
What
I
about the validation?
strongly believe that ABDM is going to play a very crucial role there in getting these data integrated, because all that we'll all need to depend upon is data interoperability. At the moment, we have got 4, 5, 6 EHR or EMR players in the market, but they're not interoperable with each other. So perhaps a platform like ABDM, and congratulations to the authorities in the NHA, they're doing a fantastic job in getting this integrated. So coming to the second part, and that is a very interesting part about when you're putting in a data to any AI algorithm, how can you be sure that the output that the data algorithm is generating is actually a validated output? And this is a very, very important section, because you will recently see, and maybe I can share it in the chat for some of the people who are interested. The World Health Organization had recently released guideline on how you can ethically use large language models in building your algorithms. And it was like a large section of a document, and we have compiled that, so we'll share that with you. And I also said that during my session. So the important thing which is missing at the moment is validation of the AI tools. The next question comes is, who validates the AI tool? So that is where you need the human in the loop, and the doctors who are actually going to be literate about artificial intelligence, who can come up and validate these AI tools. Now, when you mean validation, what exactly are we talking about? We are talking about human validation of AI models. Now, for any AI model that is built, it has got a layer of fine tuning and reinforcement learning that can be done, especially if it is a small or a medium language model. If you're talking like a model like a chat GPT, which is a large language model, which I showed in the morning, no matter how much of inputs we give, we are giving very minuscule inputs as compared to the data set that it has been trained on. So over a period of time, a long period of time, it might impact its fine tuning, but in a minuscule amount, it doesn't impact. But if you're working on a small language model or a medium language model, which is based on a localized set of data, that data set can actually undergo very good fine tuning and reinforcement learning, and the humans in the loop can actually validate the answer. This is what we are actually doing in Madhu. Some set of questions being asked to doctors and the chatbot is actually being validated by the set of doctors. So at the end of the day, when that particular response will be used by the end user, which may in this case could be a clinician or it could be the patient, at least the output we can say is validated. But this is again a process in the making. Dr. Prasad wanted to know if there is any ethical or if there is any regulatory authority. The FDA has issued some guidelines, the WHO has come up with some paper, but by far and large, we still do not have any global authority kind of giving a straightforward guideline. Neither do we have any regional authority. And that is something which is very important in today's world where we stand. Dr. Alok.
Thank you, Amit. That was coming back to Agarwal, sir. What would be your final thoughts on what you said? And we've had this add one or two lines to that. What would be your final thoughts? And before you come, sir, I would like to say congratulations, and I'm really something really big which we are doing through RSSDI. We are collaborating with IIT. We have taken a human step that we are taking pains to make sure that our data doesn't get lost, it doesn't get siloed, and we are taking help of the right people to join it with us so that we can actually make sense for the future generation, and probably we can establish India in its rightful place as far as data and healthcare is concerned. So would you like to share one or two final thoughts about it?
Final thoughts about data and AI. So I think,
Yes,
I feel that we need to learn, as I said, that we need to do a lot of collaborations. And all the panelists have made very valid points, right where, each one has his own viewpoint. But ultimately, what we're really looking at is the same story. And, we're just looking at from different angles as such. It is important that we can't dissociate today technology from our healthcare. I think that's come to stay, and we have to adapt. We have to sort of accept that. Earlier, we could think that, are we good with paperwork? But we realize that paperwork now, given the progress that we have made, is not good enough because we cannot replicate, we cannot collate, we cannot analyze, we can't do anything with that paperwork. So we have to, and I think we started with a lot of disruptions. I mean, the phone was a disruption, the internet was a disruption. All these have been disruptions in our life that has already happened. And today, AI is going to be the biggest disruption that we're going to face. And that is going to rule the healthcare industry for the future. We're going to have AI-based systems that is going to come in and disrupt. And it's not the question of do you fight the AI, it's the question of how you can modulate the AI to help you structure a better care plan. I think that's what our approach should be, that we shouldn't use AI as a threat to us. I think that's not true very much. Neither should technology be looked at as a threat to us that is going to replace jobs, that is going to make things more difficult. It's better that we sort of incorporate this in our routine life as well as our working patterns, and see that we utilize the technology and AI systems to make our approach more meaningful, more precise, and more analytical. So this is a welcome disruption that we will have to accept, and going forwards, see that we can utilize these tools more effectively for patient management.
I totally agree with you. What you said is very right. It's high time we shake hands with AI rather than run away from AI and look at the positive side of the coin. And believe me, within 5 years, the way it is going, within 5 years, we would be a different set. We don't know. We might be having an AI-enabled RSSDI tomorrow on a humorous note. So
That will make my job
something.
easy. I can retire.
So, sir, we don't have much time, so I'm anxiously waiting to listen to our dear friend here who's going to talk on cardiology, a topic that has not been spoken to since today morning, and that's important because that's where we live, right? Our lives lie in our hearts. So, over to you, Ketan. Looking forward to, and by the way, let me congratulate you for coming back as the president of Mumbai IMA with an astounding success. And heartiest congratulations to you. It speaks volumes about the good work you're doing for the medical fraternity. So, Ketan, the dais is open to you. Let's see your PowerPoint, and let's hear your views on preventive aspects of AI in cardiology. So, over to you, Ketan. Could you just unmute yourself, please? Chetan, you need to unmute yourself.
Yeah, sorry. Uh, can you see my slides? Yeah,
Yeah,
can you hear me? Yeah.
yeah, fine.
So yeah, thank you, Alok.
Yeah.
I would quickly talk about the prevention of stroke by artificial intelligence based ECG monitoring and the way it has really changed it. That is so much true. And when we talk about the AI, what is most important, it reminds me a beautiful quote by Sir Alvin Toffler, who states that the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. And that is so much true when we talk about putting artificial intelligence in clinical practice. So, quickly, I will be going about, as you know, talk about atrial fibrillation. We know the absolute number of prevalent and incidence cases of AFib have almost doubled from 1990 to 2020. And in Indian data, also, what we have found, there is a threefold higher incidence which has been found in the current years. Now, what is more astonishing was the stroke with atrial fibrillation is found in 25% of patients, and that is one thing which is definitely a matter of concern for all of us. And this atrial fibrillation, we know it increases the risk of stroke and which can lead to morbidity and mortality. So there are many arrhythmias which also increases the risk of stroke. I would not go into the details of it. The most important point is to pick it up at the right time. So when we talk about arrhythmia management, which remains a challenge and it is always changing also, first is there is a lack of an effective screening strategy for atrial fibrillation. And then there are challenges in diagnosis, risk stratification, and pinpointing the underlying cause, and challenges in establishing cost effectiveness of various interventions. So, what we need to do is we need to have a documentation of atrial fibrillation for somebody where we were suspecting. And if you have documented a FEEP, you can start the intervention in terms of starting, say, for example, oral anticoagulation. And the traditional monitoring technologies are no more adequate because of there are lots of issues pertinent to it. And here it reminds a beautiful quote from Sir Richard Dole, who states that death is inevitable, but premature death is not. And we as a clinician put all our efforts to do something on that. Now here it comes the role of devices and how where. So there are various such devices, and how do we choose the right one? And as rightly said, what we require is validation. So Dr. Day has very nicely pointed out. So we need to have the devices which are certified and accredited. Here, obviously, we look at US FDA clear certificate validation, one which has got a six-lead personal ECG solution for maybe for a professional or even a personal use, and the one which can pick up various arrhythmias. So, be it atrial fibrillation or one with the supraventricular contractions or sinus rhythm with PVCs or sinus rhythm with wide QRS, bradycardia, tachycardia, all these things we should able to get it from there. Now, the data from the various studies on portable AI-based ECG monitors, they have been shown that for the detection of atrial fibrillation, the algorithm sensitivity is 98% and specificity is 97%. So that is a huge achievement, I would put it. And diagnostic yield is comparable to a 14-day ambulatory event monitor, and recording from the six-lead device is equivalent to taking from a various ECG machines. So there are various portable AI and app-based ECG monitors which has got a high sensitivity and specificity, which can be used from the laptop, or there are smartphone-based operators. I would go into the details of it now. Before that, I would just like to show a simple demo video, which is a short video, and which will give you a very beautiful view on this, and you can have an idea. Just it's a very short video. So this is one app whereby then there is a app which is in the software which is there. You need to select which one you are losing, single lead or a sixth lead. This is the small device which is there, handheld device. This is how it is placed. So basically you have got the three leads which are there. Look at the clarity of the graph. And you can come to know whether it is a normal or if there is a atrial fibrillation which is detected. So it's so easy, especially those who had paroxysmal atrial fibrillation. That would be one thing which will be of relevance. Now, this portable ECG monitor, which we know, which can allow clinicians to effectively monitor. So not only that, the patient can detect. There is a system by which at a distant hospital or clinic-based software solutions, so where they have definitely day and night, there are a lot of operators who are looking at it, and they can pick up those things, that arrhythmias which are there. So you have, this is like a typical outpatient or inpatient setup where you have a one central monitoring system, and somebody who is on a OPD basis or somebody who at a indoor where only a training nurses, paramedics are monitoring, they can send, and that has been interpreted and analyzed over there. And then you have a typical ECG report which can come up, which can come with the interpretation. Now you know, in the clinical practice, we have seen most of now newer ECG machines which are AI based, where you have a self interpretation. They will calculate all the necessary data, rate, rhythm, QR, the PR interval, QT intervals, and everything is measured, and it will be there at this thing. But of course, you need the validation. Now, say for example, one which I have shown over here, which is certified by a leading authorities, including FDA, has got a validation, which even the recommendation coming from the NICE guideline also. So there is a proof of concept and there is a strong adoption. Now, what about guidelines and evidence? Now, more recently, these smartphone-based ECG monitors have been developed that can be helpful for long-term intermittent surveillance, and this is as per the guidelines from HRS, EIHRA, ECAS, APHRS, so on and so forth. Now, look at this 2020 European Society of Cardiology AFib guidelines, and they have clearly mentioned that opportunistic screening by ECG strip is recommended in patients more than 65 years. Systemic ECG screening should be considered to detect AFib in patients more than 75 years or high risk of stroke. And 30-second single lead ECG is sufficient to diagnose and document AFib. You don't require 12 lead ECG. So even a rhythm strip, which is good enough to detect atrial fibrillation in these patients. So if you see even the consensus statement, it clearly mentions, if you see the one which is kept in the box, the smartphone monitor, which can be used to detect the arrhythmias, especially even for patients who have undergone a surgical ablation for atrial fibrillation. So the recommendation is as high as class 1B recommendation is there. Now what about data? Yes, there are enough data which shows that AF monitoring in clinical practice, which can be have as good role as when we are talking about the Holter monitoring also. So be it in a post-ablation monitoring or detection for the first time. So, ladies and gentlemen, to give this brief summary, we know that AF is the commonest cause of cardiac arrhythmia, which can cause stroke. Detection of paroxysmal AF is the key factor for starting anticoagulants, and AI-based ECG monitoring can help detecting atrial fibrillation and other arrhythmias so that appropriate therapy can be started to prevent stroke. So we know we were talking about how AI has come. Probably now in the surgeons have gone to robotic surgeries, and this robotic era, now we will see that the CME, which has become a most mandatory thing, and now Alok mentioning about the AI-based RSSDI, probably the delegates will also send their robots to listen to that, and they will come back and do the clinical judgment. Thank you so much for your patience. Over to you, Alok.
Where we can catch hands of people, hand holding and tell them to bandwagon and don't shy away from them. I remember on a humorous note, we used to be MBBS and undergraduate. And by the way, Ethan and me are again from KFZG with a difference of 1 year, and we remember the our mess in our residency days, and we used to have together. So we need to the kind of flirting we used to do with other aspects of our life in those times is the kind of flirting we need to do today with technology, so that we can come on the right path and take India it deserves. So that's something very important and relevant. So before I open the thing, I'll come to you, Prasad. Would you like to pass any comments or give any suggestions or ask something to Dr. Ketan about his fee? Any comments from your side, Prasad?
Yes, I mean, creating awareness about this is, I think, a big task in the medical fraternity, because there's still the apprehensions about the AI as we see. And another thing is that India, the major part is rural area. And the computer savviness or the reach of the technology into the rural area, that is another major obstacle. However, over the years, the things have improved quite a lot. Even there was a question that for the several different public health programs, we have then different apps, and we have to enter the data. Now, even for example, maternal and child health, there is a portal even at the primary health center, and the data is being entered into the portal. But still, things still need to be get more organized, and maybe whatever efforts which Aayushman Bharat Digital Mission is doing, creating the ABHA ID for each person and getting that thing integrated with the health data, because now it is becoming sooner or later the registration of the health facility and the health practitioner, the mandatory for the practicing. And as it comes, I mean, obviously, the data of the patient can get collected with in a more organized manner, and if this can be linked with the national health programs and all, there could be a single data entry portal where all the data can be collated with the unique identifier for the patient, which would be the ABHA ID. So in the previous session, the speakers have from the National Health Authority have enlightened quite a lot about this, and that definitely is a picture of the future, I would say.
Thank you, Prasad. Amit, I'm going to come to you a little later. But then I wanted to make one. It struck me, which I think is very relevant. I have seen who became critical on the flights, and I realized that neither Jet Airways or Indigo, my friends have, and Amit would share. Amit also had an experience. They are not well equipped, to handle cardiac emergencies or any medical emergency. You have such wonderful portable thumb-size hardwares available, and if you enable them with AI technology, so on a flight station, on a roadside accident, wherever somebody becomes unconscious, falls sick, the diagnosis can be made, and the concerned an AI tool can actually save life when it's really required. And that's how AI will actually work if this becomes a practical situation. I don't know if you know, in US, when you dial 911, within 10 minutes guaranteed, there is a paramedical force at the bed, take care of the emergency and then ship the patient to the hospital as quickly as possible. Enabled AI, so they can actually diagnose the disease and treat the disease and get the patient out. Apple Watch and Samsung flouting and saying that the ECG can. That is the place where these are not validated tools. There has been a lot of noise that Apple ECGs don't pick up arrhythmias. They do not give a diagnosis of an infarct. But AI tools enabled on your smartphone, a Luna ring or a Samsung ring, which is Galaxy ring, which is going to come very soon, would make a big difference in the life. And this is where, Ketan, I think you brought up a very relevant point. It can make a big difference in life today. Well, that's my point of view. Let's ask Dr. Harshad. Dr. Harshad, would you have any comments to make on this? Dr. Ketan has presented just now.
Yeah, I think I will talk from my specialty, public health point of view.
छोटा को भी दो ना हल्का.
Hello.
I would request the delegates to please keep themselves.
Okay. Anyway, that is another AI problem. We are not able to filter out unnecessary sounds. So anyway, I will talk from public health point of view. I will say that AI has definitely helped clinicians for diagnosing and treating patients when patients visit them, or when patient ask for some preventive methods, what they can use. But from public health point of view, we need to ask few questions. Means, for example, India is a very big country. We have so many states. Each state is like a country. When you look at very small countries in Europe. So in India, we have so many communicable diseases, TB, malaria, leprosy, वगैरह. We have so many non-communicable diseases, hypertension, stress, diabetes, different types of cancers. Then we have mental health issues. Geriatrics is coming up. So these are diseases. Then we have infrastructure problems. So our manpower is, we have private health sector, public health sector. There is hardly any integration between the two. They are working independently. Then within public health system, we have staff, but it is quite inadequate, overburden, and they have to do too much work at the ground level without any proper equipments. Forget new technologies of AI. Then we have, let us say, coverage. Coverage of our services is quite poor. Then we have these various A's like availability of services, accessibility of services, then affordability of services, common health services, means common cold, cough, fever. Even these are not treatable in, for example, nearby tribal areas near to Mumbai. So forget about tribal areas in Jharkhand or Chhattisgarh, or hard to reach rural areas. Or why rural areas? Come to urban areas, slums. Slums, we have so many problems and we are not able to reach them. Then another thing is, AI is, I will say, it might be leading to poverty in another sense. For example, AI is introducing new technologies. Common man cannot afford these technologies. Middleman or rich persons, they can afford. But if you force common man to use these technologies, then it can lead to out-of-pocket expenditure. And this out-of-pocket expenditure can lead to poverty, because our health insurance is quite poor. Health insurance coverage penetration is quite poor. So that is another problem. So we need to ask these difficult questions, because AI actually, what we are following currently, AI is nothing but application of computer softwares. For example, I still remember my students, they come with their thesis and they will say that they have used latest software. And that latest software is, let us say, SPSS 26 version, वगैरह. And then I ask them, what have they analyzed? So they will say that they have carried out frequency distribution table. So basically they are using elephant to kill ant. So it should not happen that way. We have to use technology where it is really required. So that is a big public health picture. So we have to see that also. Again, we are relying on Western countries. We accept whatever is practiced over there. We have to see from our local point of view. We have to be independent. I will say Atmanirbhar also. We have to develop our own technology for our own people, which will be useful for our common man, which will be useful for common man who can be sure about those technologies. And we should be having reliable and valid technologies developed by ourselves. And again, I will repeat that artificial intelligence is not going to solve our health issues. It will only going to assist us uh, to solve these particular issues. We cannot look at artificial intelligence technology as end in itself. It is only a means. I think I will stop here. Thank you.
Okay. Yeah, yeah. Yeah. So yes, Dr. Anuj Maheshwari, last he was at the airport. So we are fortunate that he's on a video, recorded video. So in the head, I will stop the panel discussion here. So can I request the organizers to please, so we can do that, and then we can probably take a few questions and then go for the validatory function. Thank you.
Hi friends, myself Dr. Anuj Maheshwari. I am Governor American College of
The
Physics,
panelists to
India,
please keep their
Calcutta.
videos on.
I am Professor in Medicine at Hind Institute of Medical Sciences at Lucknow. Today I shall be talking you about artificial intelligence and digital technology and its use in management of the hypertension and prevention of its complication. So let me share my slides. In the meantime, I shall like to pay my thanks to organizer who allowed me to present today before you. And also I could be allowing to use my recorded video for the presentation as I am not being able to join at the time of meeting because of being in the travel. So let's have the presentation started. As you all know, BP technology starts 1733 when first measurement of the blood pressure performed by the Stephen Hales in a horse. And you can see the picture and you can understand how complicated this process was there and how difficult it would have been remained. But since then, measurement of the blood pressure is very important, but it has taken very lightly by many of the clinicians. Many of the times we don't even measure by ourselves. Most of the time, our clinical assistant or clinical nurse in our clinic does the blood pressure measurement. As far as the hypertension complications are concerned, we all know about the dreaded complications of the hypertension, which may be in the form of the stroke, heart failure, sexual dysfunction, heart attack, vision loss, and kidney failure. So because of all these complications, which are too much dangerous and as much as dangerous as the complications of the diabetes could be, we are not really focusing on the management of hypertension as much as we are focusing on other diseases, including diabetes. Now question arises, what is the importance of the early diagnosis and management in case of the hypertension? If we talk about any disease, not only of the hypertension, once it is diagnosed, then a person knows that what kind of the health condition he is going through. After that, it is more important to link it with the
proper person who can care for that health condition. And then adherence of the treatment is the most important thing which is to be done, which is most lacking in case of the hypertension. And finally, the treatment should be up to the standard or up to the level that it may be able to achieve the disease control. Failure at each stage precludes a successful outcome at the next. So the cascade tumbles rapidly, and same thing is actually happening in patients with hypertension. Mostly when the patient is diagnosed, they delay their acceptance of the diagnosis. And once they accept the diagnosis, they delay their treatment. They keep on remaining in the dilemma whether to start the pharmacological treatment or continue with the non-pharmacological treatment. So there is a lot of scope of artificial intelligence in decision making as well as proper guidance to the patient for the hypertension management. What are the challenges for the management of the hypertension? As you all understand very well that adherence to the treatment is one of the biggest challenge in the management of hypertension. The majority of patients, good number of the patients, those who start their treatment, they get diagnosed for the hypertension, they stop their treatment once they reach to the normal blood pressure. And this is the problem because of what? Many patients, despite knowing that they are hypertensive, they enter into the complication, they develop the complication. Second most important challenge remains the side effects of the medication. Their drug interactions, many of the time it is non-known to the clinician, or many of the time they are ignored by the clinician. Cost of the therapy again makes it's difficult to continue the treatment in country like India, where most of the cost of the treatment is borne by the patient pocket. Inadequate control is a major problem. We understand that we are having the high blood pressure. We should start the medication. We start the medication, but never care whether this medication is enough to have the control or not. Measurement issues are also patient, we can integrate the health education which may be related to its prevention, diagnosis, and treatment with the self-monitoring tools. And this self-monitoring tool, when they are combining with the cardiovascular risk estimator, blood pressure measurement statistics, and they are associated with the lifestyle intervention strategies, then they become actually the real caregiver. They can tell you about the medication. They can give you a reminder for the medication if it is missed. They can tell you the appointment with the doctor. And at the same time, if any emergency communication is to be done, which can also be given by e-caregiver. So again, we are having the pros and cons of these technologies too. It's quite convenient, makes the life more convenient, but keeps on engaging all the time the patient with the technology. It could be personalized. Applications offer tailored tracking and feedback to the individual users. Easily accessible. Apps may be more easily accessible than traditional healthcare professionals for the rural and underserved population. Of course, cost effective too. But on the other hand, there is a high doubt over its accuracy. But this accuracy is becoming more and more reliable as the days are passing on and we are improving in our technology. Some of the applications may be affected by the external factors like movement. Some of the applications are affected by the accuracy reasons. They are not so reliable. Security reasons are there because of what? Data security may be a concern, especially when transmitted over unsecured network. There are some limited interactions which are to be known to the healthcare provider, and they may hinder timely medical advice or intervention during emergencies. Many a time it is poor recognition of the problem which is arising out of there, or sometimes it is a overdiagnosis also. Many a time the uh, digital technology gives more serious information as it actually happened. User engagement is also for the longer time. So telemonitoring is an important part of that, where we can say that it optimizes the treatment with the event generation, as well as it also keeps the data, and these data are actually transferred to the healthcare provider to give the appropriate healthcare advice. So home remodeling, as well as when we talk about the home monitoring, as well as the self-monitoring done by the patient, might be by the digital application, might be by the digital platform. It helps in reducing the hospitalization. It reduces the hospital stay. It gives more liberty to the patient, remaining his keeping his control on his own hand, and even doctors can allow the earlier discharge for such patients. Basic monitoring system which works here, you can see that vital signs measurement combining with the automatic data collection system, where you can see that transmission is being done from the site of the vital sign measurement, the site of the patient, to the site of the healthcare provider, where you can see he can have the auto analyzer, where he can have the analyzer for the information in the computerized analysis, and finally give the direction to the patient what should be done. So the future, what we were expecting out of this technology, is actually has reached. Now we can see the clubbing of the digital health platform may be proactive hypertension management. However, challenges remain, such as limited access to technology, privacy concerns, and the need for further research to determine long-term benefits and risks. Thank you very much for the kind listening.
Alok, are you there?
Sir, that was.
Yeah.
Thank you, Anuj sir. That was very wonderful and very relevant and practical again. So fortunately, we had two sessions on cardiology today. Could tell us a very good preventive and day-to-day application of AI. So that brings us to the end of panel discussion. It can go on and on. There is so much. It's such a vast field. There are so many questions. I apologize if some questions have been left unanswered, but this is paucity of time. We have to look at the time schedule, and I'm sure we'll be happy to, the organizers would be happy to arrange a meeting again where we can take this forward. Before I hand over to the organizers back, the dais, I would like to thank them once again for giving me this opportunity and making me a part of this wonderful symposium today. I thoroughly enjoyed it. Learned all the respectful speakers, Agarwal invited, for taking your time from their busy schedules and being a part of today's. And Amit, a lot of thanks to you. And a reminder, those of us who are interested in the delegates, who really want to learn AI, we are running Doctors AI over here. Join us, join our LinkedIn group, join our WhatsApp group. There's lots and lots to pick up and take healthcare forward, because AI should be by doctors, for doctors, and should benefit doctors, the patient community as such. So back to organizers. Once again, thanking you from the bottom of my heart for this wonderful opportunity. Thank you very much.
Thank you, Alok. So all the dignitaries, expert speakers have given their opinions about the role of artificial intelligence into the various aspects of public health and medicine. And then since morning, several speakers have contributed for the success of this today's webinar. So we thank them all and begin with our valedictory function of today's program. I welcome Dr. Prakash Duke sir, who has been former Director of Health Services of Government of Maharashtra and the past President of Indian Public Health Association of Maharashtra. Dr. Murlidhar Tambe, who has been a professor and head of community medicine at BJ Medical College, and then the past president of Indian Association of Public Health. And then we are also thankful here that Dr. Kaushik Mitra has joined this. And I also thankful to Dr. Kaushik Mitra, who is the Secretary General, National Body of Indian Public Health Association, for this valedictory function. I welcome you all, and I would request Dr. Prakash Duke sir give his comments for today's program.
Yeah. Thank you, Dr. Vangankar. I could hear only a small part of it. I was rather busy in other program. Are you able to listen?
Yes, sir.
Okay. So I was hearing about this cardiology session. It was extremely useful, interesting, and enlightening. So as a public health administrator, I will also like to share how this journey of AI to public health is slowly begun and it's still progressing. I can vouch that initially it was only the telemedicine. The government of Maharashtra attached all these rural hospitals, sub-district hospital to JJ group of hospitals. So that was the initiation of telemedicine in Maharashtra. And this we received help from ISRO. That is still going on, but that was the only amateur attempt of what we call as today's health intelligence. And the second attempt we have done, not as a public health, but as a teaching institution, and that has progressed quite well. I can quote that the malignancy CS cervix is next to CA breast in women, and its diagnosis requires ultimately pap smear and histopathology. So we have worked on an instrument, what is called a smart scope. It's a pen-like device which has very high density camera. You attach it to a mobile phone. The initial stage was capture the image and send it to the professor of OBGY. So that was like a part of telemedicine. But now it has evolved, and now we have included AI in that. And now when it captures the picture, it gives you color signals. Dark red means the woman is having malignancy. Light means some pathology, benign or other pathologics like cervicitis or maybe other, and absolutely green, nothing. So it's developing. I'm very happy that it is being introduced in many places, even in Madhya Pradesh, Chhattisgarh, we have introduced. That was the initiation of personal experience. But sir, Vangankar sir, we are now more worried about our students. They are presenting their dissertation, they are very losing it. And we are facing problem. They are losing the skill of writing. 100% they are using GPT and writing their thesis. I don't know what is your experience from again as a public health. For the last 2-3 years, we are focusing that in India, the number 2 cause of death is COPD. And unfortunately, in public sector, there is not much being done. There are guidelines, but the guidelines are sidetracked. So what we developed, it was a small instrument like spirosphere, we can call as a portable spirometer that is given to a CHO at subcenter. It has all basic AI functions. You enter your height, weight, morbidities, etc., etc. And with the spirosphere, it can detect you obstructive or restrictive pulmonary disease, COPD, and the information is sent to the professor. So we are using this, but last thing, more and more use of AI will certainly benefit the poor community, those who cannot afford service of specialists, but with the help of AI and telemedicine, they will be able to utilize the best technology from medical colleges and professors. I think this I want to speak to you about few experiences and future in public health.
Thank you, sir. Thanks for your presence. We have with us Dr. Archana Bhate, the observer of Maharashtra Medical Council for today's webinar. Madam, very much thankful to you for remaining present and attended our this webinar. Would you like to say something?
Good evening, sir, all panelists. It was a really nice session, though I couldn't attend the whole thing because I was engaged in my college activities. And just now we had a meeting with the dean, sir, also. But Alok, I know, Alok is a wonderful person, so he has arranged very good sessions. And if further, whenever you are going to arrange this type of the session, definitely I will come and attend physically. Thank you very much. It was a wonderful session.
Thank you, madam. Now we have with us Dr. Muralidhar Tambe, sir, who is a professor and head of community medicine at BJ Medical and also the past president of the Indian Public Health Association. Sir, requesting you for your comments.
Good afternoon, and thank you, Dr. Prasad. The artificial intelligence in public health, per se, it is being increasingly used in our day-to-day life across industries and sectors, including the healthcare, finance, transportation, in education, and in entertainment. I feel that AI has the potential to revolutionize the public health by enabling more accurate and efficient disease surveillance, diagnosis, treatment, and prevention. Now, if you identify the areas where AI is being applied in public health, one is disease surveillance. AI can analyze large volumes of data from various sources, such as social media, electronic health records, and wearable devices to detect patterns and trends which are related to the disease outbreaks. It can help public health agencies identify and respond to potential epidemics more quickly. One more area where it can help is the diagnostics, definitely. AI algorithms can aid in interpretation of medical images, such as X-rays, CT scans, and MRIs, and pathology slides also. AI can improve the accuracy and the speed of diagnosis, particularly in regions where there is a shortage of skilled radiologists. This is one more advantage. Then the machine learning models can also learn from large data sets. They can aid in detection of diseases like cancer, tuberculosis, and diabetic retinopathy with high accuracy. One more is, as Dr. Dokesar said, the telemedicine and the remote monitoring. AI can support telemedicine initiatives in India by providing automated triage, remote monitoring of patients' vital signs, and analysis of patients' reported symptoms. This can help extend healthcare services to underserved areas, difficult areas, and improve access to healthcare in rural and remote regions. This is definitely going to be a boon for the public health. Then one more is the drug discovery and development, like we saw in case of the COVID times. AI can analyze vast amounts of biomedical data and identify potential drug candidates. machine learning algorithms can also predict the efficacy and safety of drug compounds, thereby reducing the time and cost involved in preclinical and clinical trials. Thus, the pharmaceutical companies have a lot to benefit from the AI in identifying potential new drugs and streaming development process. So with this AI only, we could develop the vaccine so fast. We could develop the drugs also, newer drugs also so fast in case of the COVID. Then in personalized medicine is one more area where AI can predict disease risk, determine optimal treatment options, and optimize the drug dosages for better patient outcomes. This can help healthcare providers in India optimize the treatment plans, improve patient outcomes, and reduce healthcare costs. Health behavior monitoring is one more area, that is the AI-powered wearables and mobile apps can monitor the individual's health behaviors such as physical activity, sleep patterns, and nutrition, which can provide personalized recommendations and interventions to promote healthier lifestyles and prevent chronic diseases. And one more important in case of the public health is the outbreak prediction and modeling, which also was tried during the COVID times. The AI algorithms can analyze various data sources, including climate data, population movements, and healthcare utilization patterns to predict and model disease outbreaks. This can help public health authorities respond quickly and effectively to prevent the spread of diseases. Thus, it can help in allocating resources, planning interventions, and mitigating the impact of outbreaks. In health education awareness also, it has a role to play. AI-powered chatbots and virtual assistants can deliver personalized health education and answer common health-related queries. This can help improve health literacy and empower individuals to make informed decisions about health. So thus, the scope of AI in public health is enormous. And the future, it's going to be in those areas in which are not told. So the other areas are also going to be added. And one more thing, what we need to do is, as a public health specialist, is this calls for reskilling, that we need to skill ourselves to these future needs. Then only we can make the fullest extent the possible use of this AI in public health. Thank you.
Thank you, sir. Thanks for your technical inputs. And your article on this artificial intelligence in earlier issues of the IPHN newsletter was also very popular. And you have taken initiative for the spread of and the use of artificial intelligence and digital tools into the field of public health. Thank you very much. Now, I request the General Secretary of Indian Public Health Association, Dr. Kaushik Mitra, to give his remarks.
Thank you, sir. Am I audible? I think so.
Yes. Yes.
Good afternoon. Good afternoon, all of you. Good afternoon, Dr. Prasad sir, the President of Indian Public Health Association, Maharashtra. I can see our Vice President, sir, Dr. Muralidhar Tambe here. I can see Dr. Prakash Doke sir, so many. I can see Dr. Aslesha madam here. So all my friends there in Maharashtra. And in the morning, we have so many sessions, starting with Dr. Shashank Dalvi sir, Dr. Gajanan Bhallal, Dr. Harshad Thakur, and so many things. We have learned so many things in the morning from regarding AI. So actually, this is also a follow-up of this World Health Day, which was held in 7th of this month, as per the theme of the CME. So we all know that right to health of millions is increasingly coming under threat. So, and there are so many diseases and disasters which are looming large as causes of death and disability. And there are conflicts are devastating lives, causing death, pain, hunger, psychological distress, so many. To address these types of challenges, the theme for this World Health Day in 2024 was My Health, My Right. And that has been rightly held up in this today's CME. And to afford the right of everyone, everywhere, to have the access of quality health services, education, information, as well as safe drinking water, clean air, good nutrition, quality housing, etc., etc. And obviously, there should be freedom from discrimination. So we can urge or we can make people aware to know about their health rights, to know that they can make decisions about their own health. They can protect their right to health as a basic human right and promote health as an intrinsic pillar of our broader human rights. In the same time, we have merged it with artificial intelligence. And artificial intelligence, as we are talking from the morning of today, it's a software program that can simulate context-sensitive responsibility or conversation. So there are so many AI softwares right now available all over the net. We know about the Chat GPT. There are so many other Perplexity, AI, etc. There are some open AI sources also. But from a public health perspective, AI-based applications can benefit health education and promotion with accessible, cost-efficient, and interactive solutions. AI can assist in the self-management of chronic illness. We are talking of these, including diabetes, hypertension, and asthma. In hypertension, how AI can help, we have just now seen the video. AI tools also can help people to access remote or automated health services, screening, diagnosis, and therapy, and to automatically track and monitor health data, symptoms and treatment, and provide emotional support also with mental health issues. Personalization could remind individuals to get health screenings or immunizations or provide personalized health advice tailored to users' medical history, lifestyle preferences. So there are so many AI models that can remind people, go for immunization, go for your personalized health checkup. So this is how AI can help us a lot. And there are some personalized information on healthy lifestyle, behavior, diet, etc., etc., etc. So we have seen the dimensions of AI, how large it can be. But still, I can say this AI will not replace us. AI will not replace doctors. AI will not replace the healthcare workers. But what it can do, the people knowing AI at one point of time, the people knowing AI or how to use AI will replace those people who do not know AI. This may happen in future, but they will never replace us. But they can replace these people who don't know AI with the people who know AI, because we have to rightly use AI for the benefit of ourselves, for benefit of the community. So with these words, I can say from today morning, IPHA Maharashtra branch as well as MGM Institute together, they have done a wonderful CME starting from morning, as done in other times also by the Maharashtra branch. They're doing very well. I really applaud them for their initiatives in these types of CME. Thank you all. Long live Indian Public Health Association. Thank you, sir. Thank you all.
Thank you, Dr. Kaushik Mitra, sir.
Thank you.
As you rightly said that with reference to the World Health Day theme of My Health, My Right, the AI can help quite a lot into improving the access of the patient to the health care. And that is why this topic was chosen by IPHA Maharashtra for today's webinar, with the support of the experts into the field and in the members and the office bearers of IPHA Maharashtra. I would like to sincerely thank the IPHA team and then the team from MGMIHS along with me, Dr. Ashlesha, who is the IPHAC member, Dr. Nupur, Dr. Ganesh, our IT expert, Mr. Anil, all who contributed for the success of the today's webinar. I also thank more than 500 delegates who registered for today's webinar and then attended the program. I got the supports. Especially, I would like to mention the name of Dr. Alok Modi, who has taken efforts to coordinate with the various speakers in the field, and then they provided immense knowledge to the participants today. So with that, it is a time to call it a day. and let us end this today's webinar with national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे